Good morning, everybody. Yesterday was an enlightening academic feast, and on the same note, let's begin revisiting the journey of labor again today. We all know that labor is the most anticipated and arduous phase in a woman's life. Hence, SOGS has planned this conference to make this difficult journey a pleasant one. Let's begin the first session of the day. I invite Dr. Sneha Bhuyar ma'am and Dr. Rashmi Kahar ma'am to kindly chair this session. Dr. Sneha Bhuyar ma'am has been the chairperson of the Breast Committee SOGS in 2019-2021. Dr. Rashmi Kahar madam is consultant OBGY from Amravati, Maharashtra. She is the chairperson of AMOGS High Risk Pregnancy Committee. She was the organizing secretary of AMOGS 2020, and she has won many awards. Over to you, ma'am.
Very good morning, House. It's a very great honor to welcome all of you to the second day of this conference. And I would like to invite Dr. Ashish Zararia for his talk. Dr. Ashish Zararia will be talking on PPH bundle, postpartum hemorrhage, prevention and treatment. Welcome, Dr. Ashish. Dr. Ashish is Associate Professor at GMC Nagpur, and he's from Nagpur, Maharashtra, of course. He has done a tremendous and lots of work in PPH management with Dr. Thomas Berg. Welcome, Ashish.
Thank you, ma'am, for this kind invitation, and thank you for the photograph organizers. Can I have the presentation? So at the outset, let me thank Solapur OBGY Society. I'll be talking on a very innovative and unique approach in management of postpartum hemorrhage via bundle. So when Dr. Monica called me for inviting to the CME, I was in dilemma whether to come or not. But when she said, I'll be talking on PPH bundle, I cannot say no to her, because I am attached to this innovation since its inception. Amongst the 14 medical colleges which were involved, which has contributed to MGH and FIGO for this innovation, GMC Nagpur was one of it. So I bring greetings from GMCH Nagpur and Omega Hospital. So this is the pamphlet or the chart which I am going to talk of. At the front, it contains the emergency care management part, and on the back side, it is a non-clinical care in PPH. So what it is, how it is developed, and why it is developed, I'll be going to take you all through this journey in next 15 minutes. So before that, let me share an experience from Colombia. Colombia is a country just same as that of India. It's a small country though. So they have developed this is their experience developing a world-class emergency care, and it takes time, of course. In 2009, they started with red code strategy. In 2011, they started with transfusion policy. In 2013, they started with anti-shock garment and UBT, compression sutures. 2015, they introduced checklists in their national guidelines. And then in 2017 onwards, they started using PPH bundle, and they got tremendous success in reducing the morbidity and mortality due to PPH. So similar was the experience with us. In 2014 onwards, we started this project at GMCH. Initially, we used the bundle. Then we started using anti-shock garments and UBTs. Later on, the non-clinical part, we worked on teamwork and communication. And then we identified two big referring hospitals. They were catering something in the range of 15,000 and 8,000 deliveries a year. So this PPH bundle, the teamwork and communication, we were significantly able to reduce the deaths and morbidity due to PPH at our setup. Then we took this project to UP and Bangladesh also, and it is in the process of putting in the national guidelines of our country. Now, why bundles? Why use bundles, and what is this bundle? Bundle is a new term for OBGYN, but it is not so new for critical care specialists. They are using it in ICUs. Bundle is a set of interventions to be practiced whenever we come across a particular medical condition. Suppose a PPH has come, so we have to use multiple interventions together to take care of that. So that is why this bundle was created. But then why there was a need of bundle when there is already a set intervention protocol? So it is found that the world evidences says that despite of having those interventions, the deaths are occurring due to three main reasons. The one is delay in putting interventions, disorganized interventions, and of course the delay in diagnosis of PPH. So that is why this concept of bundle has come. And then why PPH? We all know it is the leading cause of morbidity and mortality worldwide. We know the definition of PPH and the causes. 80% of the time PPH occurs because of atonicity. But then retained POCs, trauma, and coagulopathy also contributes to it. Now at the start of this chart, we have kept AMTSL because it is a very important tool in prevention of PPH. There are three components of AMTSL: the prophylactic oxytocin, control contraction, and uterine massage. When we started using this bundle at GMCH, we got many revelations. One of it was the treatment of PPH was told by our resident as 10 unit oxytocin intramuscular. But we know that it is to be used prophylactically. Each and every case should be given, unless contraindicated, 10 unit oxytocin intramuscular within 1 minute of delivery of the fetus. No anterior shoulder, posterior shoulder stuff. Within 1 minute after delivery, we have to give oxytocin. We may use injection methargine 0.2 mg or tablet misoprostol 400 or 600. There is no role of injection prostolone in that. This is an optional technique. We can use it if there are stillbirth attendants. We may skip if they are not there. We have to support the uterus from the top and a gentle traction over the cord as soon as we see the signs of separation of placenta. Uterine massage, many people confuses it with the bimanual uterine compression. The uterine massage is an abdominal procedure. We have to palpate the fundus of the uterus and a circular motion. We give massage to the uterus with slight pressure downwards so that the blood clots comes out from the vagina and uterus. So all these three components forms AMTSL, and also there are routine postpartum care for hemorrhage prevention, like checking for tears, advising patient to pass urine, and putting the baby to the breast. The most important part of PPH management is call for help. So we must have a technique. Whatever the ways we do, may have a buzzer, we may have a loudspeaker, or we may just telephone or run. Then coming to the first response bundle. It contains 4 things, and all these 4 things should be practiced together. Uterine massage, IV fluids, uterotonics, and tranexamic acid. The technique of massage I already told you. It can be done by even the birth attendant if there are lack of hands. About IV fluids, please remember it is a two-edged sword. We have to use it very judiciously. IV fluids concept is that if the bleeding is stopped, then only we have to give IV fluids. For 1 liter of blood loss, we have to give 2 liters of fluids, NS or RL. But if the patient is bleeding, then we must restrict IV fluids. So the concept is not to use IV fluids more than 300 to 500 ml. And if we really want to give it for blood pressure, if there is a fall, then aim should be to give it 300 to 500 ml every 15 minutes. And the aim is to keep the blood pressure in the range of 70 millimeter of mercury. If the BP is more than 70 millimeter of mercury, no need to push IV fluids. So restrict IV fluids 500 ml. And all efforts should be directed towards control of bleeding. So that is a basic. About uterotonics, we all know it. Oxytocin 20 to 40 units in 500 ml NS or RL from one side. There should be 2 large bore cannulas. The sample should be withdrawn. One side oxytocin should go, from one side fluid should go. You may use injection methargine 0.4 mg IM or IV, and you can repeat the doses too early, maximum 2 mg over 24 hours. Injection prostadine can be used, 250 microgram intramuscular, maximum 2 mg dose, 8 doses can be given. Methargine 1 mg, that is 5 doses can be given. You can use tablet misoprostol 800 microgram per rectally or sublingually, and carbetocin we can give. So we should not use for the action of one oxytocin to come before using the other. We can use 2 or 3 options together. About tranexamic acid, the women's trial has categorically told that tranexamic acid must be used in each and every patient of PPH irrespective of the etiology. So 1 gram is the dose, diluted in 10 ml slowly over 10 minutes, that is 1 ml per minute. You can repeat it after 30 minutes, but it should be used within 3 hours of PPH. There is no role of tranexamic acid after 3 hours of PPH. So these 4 things should be done together unless contraindicated in each and every case of PPH, irrespective of the etiology: massage, the fluids, the tonics, the tranexamic acid. And then comes the supportive measures. There is a definite role of supportive measures. We had lots of discussion on this. All the skilled birth attendants must be in a position to identify tears. If they are unable to repair it, at least they pack it and it should be done. So another is emptying the bladder. Putting the catheter in each and every case of PPH is not required, but moderate to severe hemorrhages, you must put a catheter. Emptying the uterus. So the Western world people, they were not very, they did not agree to it, putting the hand in the uterus and removing the clots. But then in routine practice, you also agree that it's not at all a difficult job, just bit of reassurance and some analgesics is needed. So emptying the uterus, and many times you come across some retained POCs, and if it is removable, you remove it. If it is not, then you take the patient to OT and remove under anesthesia. Then still the PPH is continuing. What is to be done? We have to use refractory PPH intervention. Initially, we put a name of second response bundle, then we change it to refractory PPH interventions. I don't know how many of you are using it, but then it contains the compression manuals, the UBT, and the anti-shock garments. Compression manuals we all are aware of. There are 2 basic types. Bimanual compression, where we put a fist in the anterior fornix and with the other hand we compress the uterus. It is commonly practiced by all OBGYN, and it is actually a tamponade test. If it is positive, the bleeding stops, that means your UBT is going to work, the balloon is going to work. Abdominal aortic compression is a very difficult technique to perform, although it looks so easy. You have to give pressure over the aorta near the umbilicus, slightly on the right side, compress the aorta against the spine such that the femoral pulsation goes. So you have to, with the other hand, you have to see for the femoral pulsation. This we practiced while we are shifting the patient from labor room to OT, and she is continuously oozing from cervical tears. This is a good video, but I am not going to play due to paucity of time. So most important components is a uterine balloon tamponade and anti-shock garment. We must start using it. It gives excellent results. We have used around 200 UBTs in GMCH and around places. And anti-shock garments we have used more than 50 times, and it really works wonder. So these are the refractory PPH intervention. The trigger here is PPH not responding to the first bundle on supportive measures. So we should not always wait for shock to set in before using this refractory PPH intervention. About anti-shock garment, the trigger is changing shock index. If the pulse rate, the shock index is a very important tool in determining early shock. It should be less than 0.7. The pulse, systolic blood pressure divided by heart rate. If it is around 1, systolic blood pressure is getting 100, pulse is getting 100, we ask our residents to put anti-shock garment. So, other supportive measures in PPH is blood transfusion and readiness for transfer. India is the leading country in blood wastages. So many times, as soon as the PPH takes place, we call for blood. You can arrange the blood, but then depending on the clinical scenario, you ask blood. And of course, there is a role of massive transfusion protocol whenever needed, so it should be there. Transferring to a higher level of care, it is very important. We have a national transfer policy. The government of India has it in its rule books, and if you fail to transfer patient of PPH without the proper guidelines and a patient dies, you may be sued. So it has to be ready. If you are a private practitioner, you must have a recognized tertiary care center or a nearby critical hospital where things can be done. You have to supplement blood, you have to supplement fluids, you have to give uterotonics while transfer, and constant communication with the center must be there. So this is all about the clinical part. It should be used in, this pamphlet should be there in each and every labor room. That is the aim. And we actually designed it. I'm the small member of that committee. And we designed it for peripheral health workers also. But despite of that, the only clinical care is not going to stop PPH. The morbidity and mortality of PPH is too big. Just for clinical management, we are not going to achieve it. So we put some additional best clinical practices in PPH prevention. Other than AMTSL, we have to work on anemia prevention, recognition of malaria and HIV, and identification of comorbidities, especially preeclampsia, and of course the birth planning and hospital deliveries. In first response, we mentioned about the early recognition of bleeding and postpartum monitoring. One of the center which is just in the 4 kilometers of range of GMCH Nagpur, we found that they had very less staff. So monitoring was there, less. Patient used to bleed, and then patient used to come in very critical state to us. So we give them simple advice to put monitors to each and every patient after delivery or seizure for 4 years, and their monitoring has improved and our results improved. So early recognition, monitoring, lab investigations, and of course retained placenta diagnosis and taking care of tears. One more important point is surgical management of PPH. There is no alternative to surgical management of PPH in many cases, but this bundle is going to give you time to shift the patient to a operation theatre or a particular place. And despite of that, you may lose patient if you don't have your facility ready, if you don't work on your vertical integration or network integration of hospital, and teamwork and communication. So these are the non-clinical components also, which is a part of this bundle. So this is what is the PPH bundle, the clinical and the non-clinical components. Thank you very much for patient hearing.
Dr. Ashish, for that wonderful talk. Very well described the PPH bundle. As you have rightly pointed out the 4 steps, I think each and every obstetrician must follow. They do follow, but still it has to be stringently followed. And of course, prediction, prevention, preparedness, that is the key to success. Obstetrics is a bloody field, and PPH being the major contributor. So we have to really predict, though majority of the cases can be unpredictable. I think from our side, we have to be ready with all these steps. And definitely, when we talk about the bleeding, the amount of bleeding, the estimation of blood loss, that is one major hassle in the management of this. So early detection and prompt treatment. Management of various types, as you have said, the tone, trauma, tissue, and thrombin. It's not only one type of PPH one patient can have. Even though you feel that the tone is not good, yes, when you're managing the tone, you have to explore the patient, look for trauma simultaneously, send the lab, see whether there are any coagulation abnormalities. So everything has to be done simultaneously, see that the uterus is emptied. So all these things have to be done simultaneously, and early detection and prompt management can definitely reduce the morbidity and the mortality associated with PPH. So I think that's the only message, very clear-cut message we all obstetricians should have. Once again, hearty congratulations, Dr. Ashish.
Thank you, ma'am.
Congratulations, Ashish. And I would like to inform to the House that Dr. Ashish is continuously involved in spreading awareness of PPH by making videos, conducting many PPH drills at various hospitals and places, writing articles about PPH. We appreciate your work, Ashish. Thank you very much.
Now I request our chairpersons to felicitate Dr. Ashish sir. Anjali Jama ma'am, please join the stage. We also request Sujata Darvi ma'am to join the stage. I request Anjali Jama ma'am to felicitate our chairpersons. We shall now begin with our keynote address. I request Dr. Milind Shah sir, Dr. Prabhalad ma'am and Secretary Dr. Archana Khare ma'am to chair the session. Dr. Milind Shah sir is President ISOPAP, Deputy Secretary FAOPS. Sir has authored many books and he is a very well-known personality of our society. Dr. Prabhalad ma'am is Director at Lard Maternity. Dr. Prabhavati Lard ma'am is Director at Lard Maternity General Hospital, Barshi. She is practicing since last 17 years. Her area of interest are infertility. Dr. Archana Khare ma'am, she is consultant OGCN at Tapasya Nursing Home. She has completed her MRCOG recently. She is Honorary Secretary of SOGS 22-23. Now I hand over mic to our chairpersons.
Well, friends, good morning to all of you, and I'm so happy that first session and still there is so much crowd in the hall. I'm really happy about it. We know that intrapartum fetal death or fresh stillbirth, what it causes is a mess, and we have witnessed that few years before as well. And that's why I'm really happy to receive Dr. Neeraj Nagpal, a very famous and well-known faculty in this field of medico-legal era, who is a consultant physician and GI endoscopist. He's chairman and managing trustee of Medico-Legal Action Group, and that's how many of us, we receive actually his advice on various issues in various WhatsApp group. And since then I wanted Dr. Neeraj to please visit the Solapur to speak with all of us about this particular issue. He is the ex-president of IMA Chandigarh State Branch, director of Hope Gastrointestinal Diagnostic Clinic Chandigarh. He is a member of various organizations. He is a fellow of International Medical Science Academy and Indian Society of Gastroenterology. He is affiliate of Institute of Medicine and Law, and that's why he is expert not only in medicine, also in law. I know it's a very, very long biodata, but definitely you deserve that, because we know that so much work he has put in this particular field. He has filed multiple PILs, SLPs, for the benefit of the doctors as well as the society. And that is a really appreciable work, because we need to have some sort of solutions to certain situations in the clinical practice. So with these words, I present in front of you Dr. Neeraj Nagpal, who has traveled all the way from Chandigarh to come and meet us. Dr. Neeraj, please.
Thank you very much, Dr. Shah. Thank you, Solapur Obs and Gynae Society. I'm really honored to have been invited here for the keynote address. Uh, I personally, because I go to neurosurgery conferences, I go to pediatric surgery conferences, gastroenterology, gynae, you name it, ENT. My regard for obstetricians and gynecologists and their awareness, not because my wife is a gynecologist, even otherwise, has risen tremendously. The amount of awareness you people have generated among your members and the activism I see among OBGs, again, exception of my wife, because every time she says, Ki, you are there, so you will take care, so she hardly takes any interest. But overall, I find the gynecologists as one of the most aware in this. And part of the reason is because the problem has been faced maximally by the obstetricians and gynecologists, because you are the ones who deal with two lives at once. And this is where the most critical element of this talk is. So the topic given to me today was medico-legal issues of intrauterine death. I don't know whether the time allotted is sufficient, but I have a tendency to overshoot because my wife doesn't give me time to speak at home. So bear with me and be ready to push me off stage whenever you feel like it. So don't be afraid of my size. So when we look at the number of cases which have happened in India on intrauterine death, I'll just rush through some examples. This was from State Commission Delhi, in which the child had ARM and liquor was stained with meconium, but the CTG was normal. Now this was a CGHS patient, and probably there was a delay in conducting the cesarean, and compensation was awarded in this case. Another case against a hospital. This is a government hospital now. The head of the unit, the associate professor, the assistant professor, the senior resident, the junior resident, 3 junior residents, and an anesthetist. Why I am bringing this issue? Most people will encourage their residents to become members of FOXY. Most HODs will encourage their residents to become members of their professional organizations, maybe because they want their votes for the elections. But they do not encourage them to take indemnity insurance. I fail to understand why this is so. You have 3 junior residents in this case who have been involved. There is 1 senior resident. I have cases against interns, and the hospital has totally washed its hands off. So my request with folded hands, please encourage your resident doctors to take indemnity insurance. It is dirt cheap in India, and not doing that, you are not doing justice to your position as their guide, as their teacher, as their head of department. I am a person with very, very clear words, and my talks are then criticized for this reason also. But in this case, what happened? Having conceived for the second time after having lost the first child, the parents were very, very concerned, and they followed exactly what the doctors had been telling them. So she was admitted for delivery. On the second day of admission, was informed that there is a need for urgent cesarean section at 8:10 a.m. This was done by the junior resident. Now the surgery, she made her lie down on the left side, oxygen, CTG monitoring, all that was advised. This is a government hospital, mind you. The surgery could be done only at 11:10 or 11:16 a.m. Why? Because the anesthetist did not come in time. Those of us who have worked in institutions like PGI, who have worked in institutions, in government institutions, these kinds of delay, the kind of politics which goes on between the surgeons and the anesthetists, and the anesthetists have an impression that gynecologists to hamesha halla karte rehte hain, hamesha inko emergency lagi rehti hai. It is, whatever the reasons may be, the lady developed intrauterine death and delivered a dead child. Of course, in this case, the penalty was awarded to the hospital as well as to the anesthetist and not to the residents, but I have sufficient number of cases where even interns have been penalized. Nurses have been penalized. So do not be under this impression that it is only consultants and not the residents who require to take care. Intrauterine death followed by maternal death. This was a 2022, just November, 3rd November this news came. The patient had been going around with IUD for 5 days. She went to primary health center, was referred to district hospital by the A&M. The doctor on duty was not a gynecologist. She examined, did not prescribe any medicine, did not refer to gynecologist. For whatever reason, some pressure or some complaint was made, and the gynecologist visited the patient at her home. Next day, she was admitted in labor room, where again she was left unattended, and finally the patient also died. So Orissa High Court admitted the petition filed by the father-in-law of the patient. The husband was a drunkard, and he was least bothered what is happening. And the State Commission for Women concluded that there was gross negligence. And finally, 10 lakhs was awarded in this particular case, and the High Court gave very stringent observations. And in these kind of cases, mostly the courts ask the government to pay, but they give a leeway to the government to recover the amount from whoever is responsible. That means government doctors will need to pay the compensation to their employer, the government, in case they are negligent. Another similar case, Arun Kumar Chaudhary versus Samandar. At 36 weeks gestation, patient suddenly started feeling no movements, but the complaint was ignored. Now, these are things which are very difficult to prove. The patient says, I don't feel any movements, and I had told the doctor. The doctor sometimes says, this was never communicated to me. This was 3 days later, she was sent for an ultrasound outside, and no portable ultrasound was arranged despite patient being on absolute bed rest. So this patient was already hospitalized. The ultrasonologist had to be requested to open his center and do it as an emergency. Intrauterine death was diagnosed. Ultrasonologist claimed he gave handwritten report without films. Patient was taken up for emergency LSCS on the basis of telephonic report as per the obstetrician. No blood was arranged as per complainant. 1 unit was arranged as per the doctors. IUD diagnosis was provisional as per the ultrasonologist, and it required clinical correlation. Opposite party, along with 2 other doctors, again checked the patient and could not dispel the confusion between fetal heart sound, phoenix offal, and uterine offal. The patient also had multiple fibroids in the uterus. Finally, when they went ahead and did the cesarean, of course, the child was dead. They had to cut through a fibroid which was in the way of the LSCS. Patient had massive bleeding and died. Total 8 units were transfused. Ultrasonologist was fined for not taking films. Obstetrician was penalized for belated advice for ultrasound and belated acquisition of blood. The point is, there are innumerable cases I can refer. This is another recent news. Baby dies in womb and family alleges medical negligence. Doctors have been booked. Criminal cases have been filed. Hysterectomy following antepartum hemorrhage and IUD. This was a male baby. The previous delivery was of the same lady in the same nursing home, and that was perfect. They had come for a second delivery. There was placenta previa, bleeding PV, hospitalized, asked to arrange 2 units blood from outside, stillbirth. Hysterectomy needed to be done because of postpartum hemorrhage, and during hysterectomy, there was damage to the urinary bladder. So all these cases, again, 2013, state of Karnataka, this was again a criminal case. Patient was admitted in nursing home for normal delivery, found to have IUD next day due to retroplacental clot. The point is, doctors are not penalized only when they have to pay compensation. The very process, the very judicial process, the very process of undergoing that litigation is penalty enough for most of us. The harassment of 10 years which it takes for justice to be delivered is more than enough. It is in fact less than the 2 lakh or 10 lakh penalty which is awarded finally. I would be much happier if you decide straight away and give a table, intrauterine death, 2 lakh compensation, like you have for railway accidents. You lose your arm, this is the compensation. You lose your leg, this is the compensation. Fine. At least the harassment of the judicial accusations will not be there. Then there is an issue of autopsy of the newborn. This is the case from Jipmer, Pondicherry. Now the patient says IUD occurred, delivery occurred, we asked for an autopsy, the hospital did not do it. The hospital says we advised autopsy to know the cause of IUD, the patients refused and the body was handed over. The issue arose and the decision was taken on the basis that in the records, there were 2 different times which were written for when the body was handed over. So the court said, we will not believe the version of the hospital, we will believe the version of the complainants, because your medical records are poor and they are conflicting. So again, compensation was awarded there. And this issue, whether compensation can be awarded for death of an unborn child, this was decided because you so far are giving compensation for physical injury, for death of patient, you are giving compensation for mental harassment, mental torture. Now, in Motor Accident Claim Tribunal, they have categorically stated that even an unborn child is to be given compensation for like for a live child. This is well established now. Multiple court judgments on this issue, and even including the High Court, Rajasthan High Court, including even the Supreme Court. Supreme Court also in this particular case has gone ahead. They have quantified the compensation that yes, for fetus, you may not need to give as much compensation as for a child of 7 years because there is love and affection involved over the years between the bond between the parent and the child is more. But compensation is acknowledged and to be awarded even for an unborn child's death. Very few examples, I have more than 200 or 250 examples of government hospitals covered under Consumer Protection Act. I find great vidwans among doctors who keep giving various messages on WhatsApp that doctors who are in government service are not covered. There was recently a judgment which was misinterpreted by doctors, and these kind of things create an impression among doctors that if you are working in a government hospital, you are secure. I would really like to know how many of you are working in a government hospital. Please raise your hands. Do you have an indemnity insurance, ma'am? Do you? No. Let me know your name and the hospital. I will come and instigate a patient, maybe share some compensation which is awarded. I'll give you one example. Government hospital, V. Krishna Kumar, state of Tamil Nadu. Premature baby, managed perfectly, free of cost. What is the compensation which was awarded in this case? 2.28 crores. I know you people are rich. You can afford to throw this kind of money around. But somehow, we doctors in Chandigarh are not this rich. And we need to keep on telling our friends and brethren, please take indemnity insurance. If you have not taken indemnity insurance, you are committing negligence, you are committing a crime against your own family. Forget the patient. ECHS, ESI patients. A lot of doctors have this impression that this is an insurance patient. Doesn't matter. Whether the patient pays a single rupee to you or not, the patient is a consumer. If in a government hospital, and all government hospitals today charge some money from some patients for some things, CT scan के लिए 500 charge कर लिया, only hospitals which do not charge anything from any patient. They are the ones who are spared from the agony of Consumer Protection Act. But they are not spared the agony of litigation. Because patient can still go to High Court or Supreme Court under Article 226 or Article 32 of Indian Constitution. And this is for violation of fundamental rights, and there are a number of Supreme Court judgments which say right to health care is now part of our fundamental rights, Article 21. So it is not that, but yes, any totally free hospital will not be as much in a problem as a routine government hospital where some charges are taken from some patients. So 99 patients you treat free of cost, one patient you charge. Your 99 patients remain your consumers and you will have to pay compensation if asked for. Look at this case, R&R hospital. We are not talking of government hospital anymore, we are talking of army. Most people think army doctors are not covered. I am giving you an example. They did not even bother to object that army hospitals are not covered under Consumer Protection Act. I have multiple cases from the army also. And I must excuse the government doctors for not taking indemnity insurance because army doctors absolutely don't consider it necessary, even the thought doesn't cross their mind. The problems for gynecologists under CPA, the CPA 2019 is 200 times worse than CPA 1986. If you don't know this, please go back and read. Have another session, maybe of a full day, when I will be in a position to explain why CPA 2019 is 200 times worse than 1986. The number of cases is going to increase. The quantum of compensation being asked is going to increase exponentially. If you can pay this 11.6 crores compensation or 2.24 crore compensation from your pocket, all right, no issue, no need to listen to this talk. Then, there is a new thing which has come. Every judgment which is given now says there is an interest which is to be paid over and above the compensation. And this interest can be payable from the day of the judgment or the day of the incident or the day when the patient approached the court. And what is the quantum of this interest? Is it 6%? Is it 12%? Is it 7%? It is 9%? 18%? Well, it is dependent on which side of the bed the judge got up from. Because there is no fixed criteria. Whether you have approached the court wearing a tie or not, whether he is in a good mood or not, whether he has fought with his wife that day or not. You have cases where 12% has been awarded, even 18% has been awarded as interest. Kunal Saha judgment, only 6% was awarded. And then from 5 point some crore compensation, the total amount came to 11.6. Just imagine if 18% had been awarded, where the compensation would have been. And sometimes, at least I have had 7 doctors who have consulted me over the past 25, 26 years that I am working in this field. I remember 7 doctors who came and told me across my table, "Ki Neeraj, I want to commit suicide." Well, my message to you, you are harassed by the judicial process, you are harassed by the police, there is a case which has gone wrong. Your committing suicide does not end the case. If your husband is a non-doctor, he will have to continue fighting the case. If the children are non-doctors, they will have to continue defending your case without the knowledge which you have. And any compensation awarded will have to be paid by the legal heirs or by selling off the estate of the doctor concerned. So suicide is not an option. This is a very clear message I want to give. And if people have some doubt, these are the references. This is the CPA 1986, 2002 amendment which had said that death of the doctor will not abate the claim. and 2019, which says death does not, the first schedule of Code of Civil Procedure 1908 will apply, and what that says is death of plaintiff or defendant shall not cause the suit to abate if right to sue survives. So this is something you have to understand very, very clearly. The issue is the quantum of compensation which can be awarded is unlimited. Patient can today ask for a compensation of 200 crore when the patient has paid you 500 rupees consultation. And under 2019 CPA, the case will be taken up in district commission, not even in state or national commission. And district commission, the quality of the judicial officers sitting there is suspect, to say the least. So I can just quote the number of cases with high compensations: 2 crores, 1 crore, 11.6 crores, 9 crores. Recently, ophthalmologists were awarded, and this was in state of Tamil Nadu. So the courts have started feeling if the Supreme Court can award 11.6 crores, we can also award a few crores, it's all right. Then doctors in panic have started taking insurances of 4 crores and 5 crores and 2 crores. And when you give that 2 crore insurance in front of the judge feels very, very liberal. I have done a favor to the doctor, I have only awarded 80 lakhs, ye to doctor rich hai. That is why we say always, you take 2 or 3 indemnity insurances from the same insurer, not from different insurers, so that before the court you give only one indemnity insurance, which is of, let's say, 20 lakhs, 30 lakhs, 40 lakhs. In case the award is 2.5 crore, you can always add the other one and say, Doctor Sahab, we had written the number of these insurance policies, Judge Sahab, but unfortunately, typographically, the copies could not be attached. And the insurance company cannot deny because it is the same insurer. If you have taken different policies from different insurers, you are in trouble. And consumer complaints is one part. There are multiple other places where simultaneously cases are filed against you, and you have to appear on the same facts, same complainant, whether it is IUD or whatever. If you just go through the list, it is fantastic. And besides that list, that is the legal part. If you are treating the mother of a high court judge, even a CBI inquiry can be ordered against you. How long to keep medical records? Big confusion. IUD cases, the problem is your CTG tracings, how long are you going to keep it? This is a major problem, and there is no crystal clear message. You have different laws which mention different things. And in the Indu Sharma case, the National Consumer Dispute Redressal Commission has referred to Williams' textbook saying that CTGs should be stored for at least 25 years and hospitals should make adequate provision for safe storage and easy retrieval. So medical records to be stored for 25 years. Most of us stop working at 25 years. Consumer Protection Act normally says you had a problem, a case can be filed against you 2 years later. Here, the courts have applied something called discovery rule. When did the patient discover that you were negligent? If the patient discovered you were negligent 11 years later, then the patient has 13 years till the time he can file the complaint. The problem for doctors is how long are you going to keep maintaining the records? So at least before CPA 2019 and before Clinical Establishment Act, I always used to give this slide, this is the Nagpal's rule. Every year give an advertisement in 2 newspapers, one vernacular, one English. Both the newspapers should be such which nobody reads. The advertisement should say, I am going to destroy the medical records in my hospital more than 5 years old. Anybody wants those records can come and approach me within 30 days. After that, do not destroy the records. If a case is filed against you 20 years later, take your medical records and take your advertisements to your local medical legal expert or to your local advocate. If your records are well maintained, maybe like what Dr. Shah maintains, they will use those records to defend you. If the records are not maintained as well, then under those circumstances, they will use the advertisement and say, we gave an advertisement, nobody came for the record, so we destroyed them. So at least you have some defense. And remember, patient may have asked for compensation of 5 lakhs. It is not necessary. The court is limited by the amount. The court is free to award 50 lakhs. There is no such thing that they are limited by the amount of compensation which has been asked. Interest, I already told you, it can be anything. The legal aspects of CTG, again, it's a full talk in itself. And if you look at the NHS legal authority data, this is the total number of percentage of cases of clinical negligence, all other specialties and OB-GYN. OB-GYN only 20% cases of all other specialties. And when you look at the quantum of compensation, then you are talking of 49% is the total quantum of compensation which has been awarded. Of the total to all doctors, 49% is only against OB-GYN specialists. This is their 2021 to 22 data. On right side is the amount in pounds, which crosses 1 billion as compensation paid. If you look at the cerebral palsy and birth defects and non-cerebral palsy and birth defects and combine the two, the total works out to be more than 1 billion, which would probably be the GDP of a small country. So, misrepresentation, misinterpretation of the CTG, why the CTGs are misinterpreted, all this data is given. And all gynecologists, I will request you to go through the Indu Sharma versus Indraprastha Apollo Hospital case. The case was very simple. Patient was admitted for a long time, and the doctor said, we advise cesarean. The patient did not agree for cesarean. However, the nurse's sheet and the doctor's sheet, they said different things, and then finally, suddenly, they decided to do a cesarean, and there was cerebral hypoxic injury. So 1 crore 10 lakhs was awarded in this case, and so far for gynecologists, this is probably the most important case which should be read by everybody. There are a number of issues in this case, and again, as I said, we can have a full session on this particular case. Whenever a patient refuses cesarean, please get an informed refusal as a consent. If the patient is not willing to sign an informed refusal, you put that in the records that patient has refused cesarean, patient has refused to sign an informed refusal. Get it signed by whoever is available over there, need not be any independent witness, even a nurse will do. Just take some kind of this record keeping for CTGs, the recommendations are many. Even the FOGSI recommendations on how to monitor, how to induce should be followed, and these are what will save you in court unless you transgress these. We have had weird judgments. One of them was the doctor was awarded 3 years jail because he did not have a neonatal ICU in the nursing home. This was overturned later. But the harassment of the doctor, as I already said, is not only in the compensation or the penalty, it is the process which in itself is sufficient compensation, sufficient harassment. And when in obstetrics do medico-legal problems mostly occur? Death of mother due to amniotic fluid embolism, PPH, pulmonary embolism, death of newborn with birth asphyxia, forceps delivery causing focal neurological deficit, financial reasons at the time of billing. The allegations which have been made in different cases against gynecologists, again, this is the entire list. If the doctor has arrived late in the IUD, in this particular case, the court sided with the doctor that you had already come to the hospital with IUD. So whether the doctor came late or not is not a criteria. That did not cause the IUD. Recent High Court matter, in this particular case, doctor, due to personal reasons, preponed the delivery by about 11 days prior to EDD. Delivery could not be naturally done and a cesarean was performed. The claim was that doctor was in a rush to catch a train and therefore had performed a cesarean in a hasty and rash manner. Injury was caused on the forehead of the child, whereas actually this was a forceps injury. And another doctor, in order to absolve the doctors, is alleged to have issued a false certificate stating cause of death to be severe birth asphyxia. FIR was registered and the High Court upheld the FIR that the criminal prosecution should continue. Karnataka High Court, another cesarean, this was young cesarean, was taken up into the OT, and patient was developed a reaction to anesthesia as per the doctors, tried to revive, ultrasound done in OT, fetus was found dead, no cesarean done, declared patient dead. The patient party got a post-mortem done and it revealed a fracture sacroiliac joint with internal hemorrhage sufficient to be the cause of death. So there was no anesthetic reaction. While being shifted from the trolley to the OT table, the patient fell down. So when you try to manufacture records, when you try to fabricate records, this is what happens. And criminal case was to be continued. My problem is what the new generation is not being taught. We have been caught because we were trained in a particular way, and we have been caught in circumstances not our making. But it is our duty to train the next generation at least. That is something we are not doing, which is where the major problem lies. They are encouraged, I already covered this point, documentation, how to document, they are not taught. Science and art of taking consent, they are not taught. Communication skills, again not done. What is negligence? What is civil negligence? What is the difference between civil negligence and criminal negligence? Not taught what kind of indemnity insurance they should be taken. Not taught what to check while signing agreements with hospitals. When you are signing your agreements with corporate hospitals, there are certain things you need to be aware of. You need to know the consent for NVD is different from consent for forceps, different from consent for cesarean, for hysterectomy. You cannot have simply, I hereby give consent for dash, I have been explained all complications including death. This is an inadequate consent and it will be thrown out of the court. Consent has to be taken in language of the patient. It has to be taken from the patient and not relatives. It has to be real and valid, and only procedure which is consented for should be done. Consent has to be signed by the treating doctor and the junior doctor. Separate consent needed to give anesthesia and conscious sedation. Separate consent needed for blood transfusion. Mention in consent if particular facility is not available. Alternate methods of treatment need to be explained, and treatment to be provided by residents, junior doctors and trainees should be mentioned in the consent. We are taking consent in the name of the HOD and the delivery is being conducted by the resident. Please mention in the consent, this is the team which will do the procedure. Write down the name of the team or the team of Dr. X so-and-so or the green unit, whatever. If treating doctor is not going to be available after procedure, this should be mentioned in consent. However, we have made mistakes which have led us to this situation. First of which was we appeared in the NEET exam, completed MBBS, remained in medical profession, decided to remain in India, then decided to do post-graduation in gynae. Not retiring by 35 years of age and marrying a doctor instead of an IPS judge or a politician. Please befriend your area station house officer, befriend your neighboring advocate, befriend a local politician, befriend a pest reporter, befriend local IMA president secretary, besides listening to talks on how to manage PPH. And we are holding a whole day conference. This is the 9th Medical Legal Action Group annual conference being held on 12th of February in Chandigarh. I invite all of you to join us, and many things which I have skipped over, could not be covered. You will have speakers who are much better than me, who will be delivering talks at this, and you're all welcome there. Thank you so very much.
First of all, thank you organizing team for allowing us to chair the session. Thank you sir for the wonderful talk. I think every obstetrician wants mother and baby to be safe. But unfortunately, due to some unforeseen complication, we may land up into the complications. And again, the public blame us for everything. It's also necessary to make ourselves safe. And best key home message is documentation, empathetic approach toward the situation, involvement of the seniors and colleagues, and to buy a good indemnity insurance and consult always a good lawyer and good and informed consent. Thank you.
I request the chairpersons and Dr. Anjali ma'am to please felicitate Dr. Nagpal. I now request Dr. Anjali ma'am to please felicitate our chairpersons.
Without wasting much of a time, we now move forward to the next session. May I call on the chairpersons for the next session, Dr. Sharmila Gulam Madam and Dr. Sujata Kulkarni Madam, to chair the session. Phone करायचं तुम्हाला. Dr. Sharmila Gulam Madam is a consultant at Ankur Nursing Home. She has been a past SOGS president and she has also received the Best Society Award. Her areas of interest include high-risk obstetrics and NDVH. She is also a practicing consultant at Markande Sahakari Rugnalaya. I also invite the next chairperson, Dr. Sujata Kulkarni Madam. She is a consultant at Banshankari Hospital. We welcome both of you, ma'am, to chair the session.
Thank you so much. We'll start the session. It's my privilege to introduce our first speaker, Dr. Sujata Darvi Madam. Madam is a consultant obstetrics and gynecologist from Mumbai, Global Hospital, Saifi Hospital, Bhatia Hospital, St. Elizabeth Hospital, Ruxmani Jain Hospitals. At present, Madam is a secretary of AMOGS, that is Association of Maharashtra Obstetrics and Gynec Society, joint associate editor of JOGI, clinical secretary, Mumbai Obstetrics and Gynec Society. Madam is going to speak on preterm labor and PROM, optimizing prenatal outcome. Over to you, Madam.
Yeah. Thank you, Mrs. Guram, for a kind introduction. At an outset, I would like to thank the organizers, especially Dr. Anjali Jama, President SOGS, and Dr. Monica Umbadan, for giving me this opportunity to speak on this subject of preterm labor. And also PPROM. I would also like to acknowledge the efforts made by organizing chairperson Dr. Milin Shah, Dr. Manik Guram, for making this conference into a big success. And I would also like to see the efforts of the Dr. Nanda Magal and also Dr. Archana Khare being an organizing secretary for the same conference. We heard Dr. Nagpal speaking on medical legal issues. It made us little bit on the scarier side also, but at the same time it opened our eyes. And we in an obstetrician always feel we only get so many phone calls, but the number of phone calls he got it when he was talking, it means that medical legal consultants are in a big this thing and they are in a big demand as such. We'll speak on preterm labor. So as any doctor can tell you, what the most crucial step towards healing is having the right diagnosis, earlier diagnosis by appropriate screening test. If the disease is perfectly or precisely identified, a good resolution is far more likely. Conversely, a late diagnosis usually means a bad outcome, and no matter how skilled the physician is, which always happens in an obstetrics at time. So what exactly is a preterm labor? WHO defines preterm labor as births before 37 completed weeks of gestation or fewer than 259 days from the first day of women's last LMP. The preterm labor is also responsible, remember, for almost 75% of neonatal mortality. Preterm labor and preterm birth, it's a challenging obstetrician complications. It's a leading cause of infant morbidity and mortality. Lower the gestational age, the mortality and morbidity and the cost of treating these children also increases, and the long-term impact and also has a psychosocial, some sort of a burden. If you see the global prevalence of preterm labor, almost about 15 million babies are born too soon every year. 1 in 10 babies are born preterm, and over 1 million children die each year because of the preterm. If you see epidemiology, worldwide almost about 11.1% of infants are born preterm, and preterm birth is a leading cause of infant mortality and morbidity, and it's the second most cause of death after pneumonia, especially in children below the age of 5 years. If you see the epidemiology all over the world, you see India is a foremost so far as preterm births are concerned and so far as neonatal morbidity and mortality is concerned. So India ranks number 1 in the world preterm birth. So we need to make lots of efforts to decrease this rate of a preterm births as such. And India ranks number 2 in preterm specific neonatal death as compared to the rest of the countries. So these are the different stages of a preterm birth. Extremely preterm would be around 28 weeks. Very preterm is between 28 to 32 weeks. Moderately preterm between 32 to 34. And late preterm would be 34 to 37. So almost about 80% of the preterm births are moderate or late, and rest of them are very few of them, about 20% are extremely preterm or very preterm. If you go to see, the preterm could be a spontaneous, where approximately 40 to 50% of the births are spontaneous preterm with an intact membrane. About 25 to 40% are because of premature rupture of membranes, what we call it as a PPROM. There are few indicated interventions which are made because of some sort of an obstetric or a maternal indication. These forms are almost about 20 to 30% of the incidence of preterm. Pathophysiology, if you go to see, there could be an activation, chorion decidual, the reaction which takes place, this gets disrupted, which could be because of an activation of maternal or fetal HPA axis. It could be because of an inflammation or an infection. It can happen because of a residual hemorrhage or because of some pathogenic uterine distension like multifetal pregnancy, polyhydramnios, or some sort of an uterine anomaly, which can lead to a preterm birth. The causes of preterm could be uterotonic factors, could be premature uterine contractions, it could be premature rupture of membranes, it could be bacterial infection, or it could be PIs, that is preeclampsia, which can cause preterm labor. Risk factors could be previous preterm, patient with a history of previous preterm, likely to have preterm birth, short cervical length, uterine anomalies, which are either, even if they are corrected, they are still prone to have preterm births. Age less than 18 years, we don't find it, but age more than 35 years. Patient who has had vaginal bleeding all throughout the pregnancy, sometimes the cause is not evaluated, but she still has. Multifetal gestation, patients who have conceived with ART treatment, and patients who have had a premature preterm rupture of membranes as such. The other risk factors would be patient who has had a genital or lower urinary tract infection, vaginal bleeding I've already said, patients have had smoking, high or very low BMI, improper antenatal care, she has not followed up properly, patients occasionally from a low socioeconomic group, if fetal fibronectin is positive, and if any surgery which is done on the cervix and which has not got recorded, these are the patients who are likely to have preterm labor. The cause is, most of the preterm labors, the cause is unidentified in almost about 50% of the cases. Majority of women with the risk factors, because we take so much of care, sometimes they don't land up having a preterm labor as such, whereas women with a preterm labor, sometimes they don't have the risk factors. So it goes the other way around. 50%, as I already told you, are spontaneous with an intact membrane. 25 to 40% are with preterm premature rupture of membranes. So basically, if you go to see, preterm labor is difficult to screen, it's difficult to predict, it's difficult at times to prevent, and at times it's difficult to treat, you know. So depending upon when the patient comes to you, you need to take the treatment and you need to go ahead. The efforts could be in prediction and screening of preterm labor. So first of all, any high risk patients, you need to screen them. Then previous history of preterm labor, previous history of bleeding or urinary tract infection, these are the patients who need to be monitored little more proactively. Risk score fails to identify at times or to improve. Early antenatal care is very important in these patients, and effective perinatal service, that is, you need to have perinatal service even if the child is born preterm, you need to have services like a neonatal care unit to treat these babies as such. The diagnosis would be, you can predict preterm, but it's a very poor marker. One is from the clinical history. You need to go into the details and find out clinical examination. Then we have a sonography, which also forms a very important role, especially in the second trimester. Whenever a patient undergoes an anomaly scan, cervical length less than 2.5 centimeters, or if you have coning of the fetal sac, or an internal os is open, or it is closed, and more predictive value will be in case there is some detectable or palpable uterine contractions, premature rupture of membranes, or previous history of preterm labor. We do have this biochemical test like fetal fibronectin. It is still not available over here, but you do have something known as a detection of an cervicovaginal secretion, that is phosphorylated IgFBP, which is a protein marker which we can detect it by an actin Partas method. At least we can know whether the patient is leaking or no, or even a simple litmus test is good enough to find out whether the patient has a leaking fever, whether she has a premature rupture of membranes or no. Shorter cervical length, greater risk of preterm labor. You need to recommend a transvaginal sonography in these patients as such, and consider therapeutic intervention in case you find cervical length which is less than 2.5 centimeters, or if the internal os is opened as such, it's V-shaped, Y-shaped, or a U-shape, you need to have a rescue cerclage in these patients as such. So this is about the cervical length. If it is less than 2.5, which is detected between 19 and 20 weeks of gestation, these are the patients who are likely to have preterm labor. Rescue cerclage is in case of, I've already told you the indications, but do not offer a rescue cerclage if you find there are some signs of infection, there is active vaginal bleeding, or there is a presence of uterine contractions. You treat all these things and then only let the patient undergo a cerclage, otherwise that cerclage is not going to be effective for that particular patient. Then we do have a biochemical test. One is a fetal fibronectin, where you take cervicovaginal secretion, and also we have even an actin Partas, which is also a detection of a rupture of membranes as such, or leakage of liquor. Sensitivity is almost about 95%, and specificity 92%. These are the bedside results. They give you results in 5 minutes. Negative predictability is very important, and it is quite accurate. If you give a negative result, it means this patient is unlikely to go into preterm labor. If you get positive result, very likely that she could go into a preterm labor in next 2 weeks. So you need to treat the patient as such. Fetal fibronectin is, if you get a positive result, it's an inflammatory marker as such. This is how you do a fetal. In between, we had a trial when one pharma company had given us a fetal fibronectin detection kit. You could get the result in about 2 minutes as such. If you get, as what I said, negative result, it means patient is unlikely to go into preterm labor. If you get positive result, very likely that patient could go into a preterm labor in next 2 weeks as such. So you do have this fetal fibronectin test, which I've already told you. You do have this actin Partas, which is still available in the market. You have an actin Partas where you detect this phosphorylated form of an insulin-like growth factor binding protein. to rule out preterm labor, which is easy to do test, simple, accurate test, which is a one-step dipsticks as such. You just have to collect the posterior vaginal or cervico-vaginal secretion as such, put it into a test tube, just shake it and put that liquid which is there into how we do a urine pregnancy test, something of that sort. You just have to do it. If you get positive lines, means it is patient is likely to go into a preterm labor. If you get negative, then patient is unlikely to go into preterm labor. In case you don't get all this, simple litmus test will be able to tell you whether it is litmus positive. This is what we have: actin PR or PPROM and actin partus. These are the tests which are available, and we can at least predict whether patient is likely to go or not likely to go, and that way we can be little more proactive as such. Once you know that patient is in preterm labor, how do you prevent it? Do you use tocolytic agents or no? Whether tocolytic agents are useful or no? Cervical cerclage, I have already told you, if there is a presence of vaginal infection, then you need to treat this, especially bacterial vaginosis. If you feel there is a possibility of genital infection, which could be a reason, you need to treat it and reduce the physical activity to as much as possible. And sometimes all these things also you try to do it, and sometimes it fails to prevent a proper perinatal outcome. How do you manage these patients? These patients are admitted in the hospital for observation. Consider in case you feel that you don't have a facility for a neonate, or a neonatal facility is not there, it is better to transfer the patient in utero rather than delivering the patient in this hospital and transferring the neonate somewhere else. It is generally not preferable. Better to transfer the mother with the baby. Offer analgesia. Administration of steroids is very important. Measurement of transvaginal cervical length at around in the second trimester is important. Discuss the plan with the women, and documentation is very important, and clinical reassessment as and when patient is under observation. What is the importance of tocolysis? Apart from reducing the uterine contractions, it allows you a time to transfer the patient where the NICU facilities are available. It also allows the action of a steroid so that the fetal outcome will be much better. And if at all baby is less than 34 weeks, or maybe 32 weeks and less, then you can give magnesium sulfate as a neuroprotector, which will help in the neonatal outcome. Antenatal steroids, not going into the details, betamethasone or dexamethasone 12 milligrams intramuscularly 24 hours apart, or dexamethasone 6 milligrams intramuscularly 12 hours apart. Risk of preterm, including for those with a ruptured membrane, single dose if at all is sufficient enough. You can give an additional dose if at all it is required, that is after about 32 weeks, provided the pregnancy is prolonged up to that much time. It has found to be reducing the incidence of respiratory distress syndrome, ventricular hemorrhage as such, and even infection, but it has got a limited use in a patient with a multifetal pregnancy, obese patients, fetal growth retarded, and an early preterm as such. But antenatal steroid works wonder, and it is always better. Whatever may be the less time which is there, it is always better to give an antenatal steroid to these patients as such. Coming to the tocolytic agents, the commonest tocolytic agent which is used is a calcium channel blocker, that is nifedipine, which is easily available. It can be given oral and it is quite cheap. Dose is 20 milligrams stat. Wait for about 30 minutes to check if the uterine contractions are present or no, and then repeat the dose for at least the same dose for about 2 doses as such. Maintenance dose is 20 to 40 milligrams 6 hourly. Occasionally it can give rise to headache, dizziness, flushing, reflex tachycardia, and occasionally it does give rise to a hypertension as such, and it need not be administered with magnesium. So if at all you have given magnesium sulfate as neuroprotector, then maybe you need not give that much dose of an nifedipine as such. The commonest which we were using all these days is beta sympathomimetic drugs, which is isosuprene hydrochloride. It is available as oral and injectable. Injectable, everybody knows, 10 milligrams IV you can give it. Oral is 10 milligrams every 6 to 8 hours. Only side effect is hypertension and tachycardia for these patients as such. Tocolysis, terbutaline, not being very widely used, but there was a time people were using terbutaline as such at 6 hourly interval, subcutaneous dose. Again, the same side effect as rest of the beta sympathomimetic drugs. Prostaglandin synthetic inhibitors, that is indomethacin, was tried There are some people who still use indomethacin as such, but we at least don't use it. We generally stick to our calcium channel blockers or at the most beta sympathomimetic drugs. That is what we call it as an isosuprin hydrochloride. But this was also, there are some people who do use this. Now, oxytocin agonist, that is etosiban, this has come in the market, though it is little on the expensive side, but it works wonders, especially patients who is very high risk, patient who can afford, and patient who has got a strong uterine contraction. You need to use it only for 48 hours. Once the uterine contraction subsides, then maybe you can switch over to some other tocolytic agents as such. It is specifically developed, it acts only on the myometrium. Maternal and fetal safety profile is taken into consideration. It has got no side effects. It's the safest choice even in a patient of a multifetal pregnancy or a patient who have got anemia as such. Onset of action is within 10 minutes and uterus almost becomes quiet, but you need to give it at least for about 48 hours. You cannot just stop it because the uterine contraction has stopped it as such. Not going into the details of side effect as such. Loading dose, everybody knows it has to be given intravenously, 6.75 milligrams, that is 0.9 ml over 1 minute, followed by 300 micrograms per minute for 3 hours, and then 100 micrograms for up to 48 hours. You can either give it in 100 cc of normal saline or 500 cc of normal saline, depending upon whatever is available with you as such. Remember one thing, you have many tocolytic agents, but only one tocolytic agent has to be used at time. You cannot use combination of the two tocolytic agents. You will end up having more side effect than the effect of that tocolytic agent. In case you find patient with a vaginal infection, please start treating the vaginal infection. Even if you don't find it, it's always better to start treating the vaginal infection. You get good results with a combination of an antibiotics and a tocolytic agent. Now comes the role of progesterone. Once you feel that the uterine contractions have quietened down or the uterus has become quietened, you want the pregnancy to get prolonged, and here comes the role of a progesterone. By continuing tocolytic agent, there are some people who say there is no need to continue with tocolytic agent, but we all know we always continue with oral tocolytic agents even later on in spite of patient not having uterine contractions. But what is more important is a progesterone. You can use either an injectable progesterone or a natural micronized progesterone, which can be used either orally or vaginally. Different doses are available anywhere from 200 to 300 to 400. It relaxes the uterine myometrium, blocks the oxytocin action, and inhibits gap junction and anti-inflammatory effect. And this trial, that is a MEAS trial, in which they had taken a patient of a high-risk patient with a threatened preterm labor, and they had given weekly intramuscular progesterone, and they found good results when they've used progesterone. So progesterone, it decreases the conduction of contractions, it increases the threshold for stimulation, it decreases the spontaneous activity, decreases number of oxytocin receptors. Basically, it prevents the formation of gap junction. But mind you, progesterone does not act if a patient has got active uterine contraction. At that time, only your tocolysis will work, okay? Only when the uterus quietens down, you want pregnancy to get prolonged, you can use progesterone as such. There are some people who use progesterone as a prophylactic. That is, you have a patient with a previous history of preterm labor. As a prophylaxis, you continue with progesterone. You don't want patient to go into preterm labor. You have done some circular surgery in the second trimester. You don't want patient to go into a preterm labor. You continue as a prophylactic preterm labor. So that can be done. But when the uterus is actively into contraction, progesterone per se does not work out. This is another progesterone trial. This is also a meta-analysis of the same progesterone. These are the different trials of progesterone. So basically, for a high-risk patient with a threatened preterm labor, either you give intramuscular weekly 250 or 500, depending upon the weight of the patient. Natural micronized progesterone also can be given either vaginally or orally as such. High-risk patient for a preterm labor with a short cervix, you can give natural micronized progesterone. Here they say vaginal works out better than the oral. And arrested preterm labor, very important, you can give either intramuscular or a vaginal progesterone. Mind you, but progesterone is not useful in a patient with multiple pregnancies. A patient who has got multifetal pregnancy, if you give prophylactic progesterone, it does not work. It does not work to halt the labor. That is, a patient is in preterm labor, you give progesterone, it does not work. It can be used and cannot use it as an adjunct to tocolytic drugs as such. So whenever you are using tocolytics as a prime drug as such, there is no need to use progesterone. You can use it always later as such. So ACOG's recommendation in a singleton pregnancy with a previous stillbirth or a previous spontaneous preterm labor, progesterone regardless of the cervical length. So this is a prophylactic progesterone. Asymptomatic patients with a cervical length of less than 2 or 2.5 centimeters before 24 weeks, they said you can use vaginal progesterone. There is a study which says there is no need to do even a os tightening when the cervix is less than 2 centimeters also if you are using progesterone. But for all practical purpose, any cervix which is less than 2.5 centimeters, it is always better to do a cervical circlage and then put the patient on progesterone. Multifetal pregnancy, progesterone, there is no reduction in a preterm labor, so progesterone per se is not recommended as such, and there is an insufficient evidence for an additive effect of cerclage and a progesterone. So this was a study which they had conducted. One group was given cerclage with progesterone, other one was not given cerclage and progesterone, and then they found equal results. But mind you, for all practical purpose, it is always better to do a cerclage if you find cervical length which is less than 2.5 centimeters, at least in the second trimester, or if you find internal os which is either V-shaped or a U-shaped, something of that sort, it's always better to do. Now, role of magnesium sulfate, it's a neuroprotection for the baby to be given between 24 to almost about 34 weeks of gestation. It decreases the incidence of cervical palsy. You give the same dosage as what we give it for an eclamptic patient, that is 4 grams IV as a loading dose over 20 minutes, followed by 1 gram per hour till the birth, till whenever you're scheduling a patient for a C-section, it is better to start off at least about 12 hours or whatever time limit that you have it, it is better to start off with it, and you need to monitor the side effects. So ACOG's recommendation finally is to individualize the treatment depending upon the maternal condition. Tocolysis drug with a less of side effects to be used. Maybe atosiban, once the price comes down, maybe we can start using atosiban. It works out very well as such. There's no maintenance with tocolysis. It said the moment uterine contraction stops, there's no need to give tocolysis. You can continue giving progesterone, and success is to initiate the treatment as soon as possible. Administration of steroids is very important. Whatever leverage you have, please administer steroids, magnesium sulfate as a neuroprotector, and make arrangement to transfer the patient with an NICU facility as such. So thank you so much for patient hearing.
Thank you, madam. It was a very crisp lecture, and you have given all the take-home messages very clearly. I think the one which I liked is one tocolytic at a time.
Yes, that is
Yes,
true,
and,
because then we like to bombard because contraction is not ceasing. So, you know, everybody becomes little bit the patient's relative bothers you, patient bothers you, and you also get worked up. So you feel, Kichulu, if this is not working, let us put in something else. But you stop that or let the action reduce and then you add something else rather than, you know, adding the two things. That's all, nothing else, you know.
This fetal fibrinectin detection test, that
Yeah.
was something new to us. I mean,
Actually, it was there in Bombay, available for few months, but now they've taken it out as such. But you have this active partners and active PROM, which is still available. So that's a simple bedside test which can do it. In case it is not available, best thing is to do a litmus test and just find out whether there is, what you want to know is whether patient is leaking or not leaking, that's all. Even if patient is not leaking, you would still give antibiotics. Even if patient is leaking, you would still give antibiotics. But it is, you know for sure that because she is leaking, you try and see whether the leak stops or no, and then you give some prophylactic progesterone or whatever it is, so that the pregnancy gets little bit prolonged. In the meantime, you give steroids so that in case baby has to be delivered, the prognosis would be better. You decide about magnesium sulfate as and when you want to deliver the baby, not just prophylactic. There's no magnesium sulfate as a prophylaxis. In case you don't have facility to transfer, I mean, you don't have facility in your, that is, you have time to transfer the patient somewhere else. So these are all the stopgap arrangements which you need to do it. But never deliver a patient preterm if you don't have a facility for NICU, because as what doctor said, there are some medical legal cases which have cropped up saying that why did you deliver here when you didn't have a facility. So it's always better to shift the patient somewhere else where you have an NICU facilities. It is for our own safety rather than anything else, you know.
thank you. Thank you so much, madam.
Thank you.
Our next lecture is use of blood and blood products in the labor. Pregnancy is physiological, but when it turns into pathology, is most unpredictable. Various labor complications needs transfusion of blood and blood products in day-to-day practice. To know more about this, I invite Dr. Yogesh Rathod. He is consultant, intensivist and critical care physician at Yashodhara Hospital and Aadhar Super Speciality Private Hospital. Over to you, sir.
Should I start? Okay. So, hi, good morning everyone. I'm Dr. Yogesh Rathod. I'm working as a consultant critical care physician in Aadhar Super Speciality Critical and Critical Care Hospital. With the permission of moderators on the dais and wonderful audience on a Sunday morning, I would like to start one of the controversial topics that when to use and what to use in the blood and blood products in the labor. So this is one of the controversial topics because none of the societies or guidelines, they come on a conclusion that something has to be used in a specific way. So we are going to discuss about the basics of it first, and then we will come to one of the two countries which have done wonderful in the section of usage of blood and blood components in the labor. One is United Kingdom and other is Australia. Australia has got its own national blood authority, and UK has its own green top compendium of guidelines called as green top guidelines. So we will discuss about those guidelines as well. So the causes of maternal mortality, if we discuss globally, the commonest are either chronic anemia of pregnancy or obstetric hemorrhage. So why do transfuse in these situations? We'll directly come to the topic and we'll start discussing about that. So decision is based on whether we need to improve the tissue oxygen delivery, or whether we need to optimize the blood volume and red cell mass, or minimization of blood loss, or optimization of the patient's tolerance to the anemia. So when to transfusion? So we do need to understand a concept called as transfusion trigger. So everyone should have an idea about liberal and restrictive strategy of transfusion. So these days we have come to a conclusion that liberal strategy never helps, restrictive strategy helps, and we should have an idea about the transfusion trigger as well. So collectively, most of the international guidelines, they have said that with the basis of trick and twist trial that 7 gram per DL is considered as the transfusion trigger. Any patient who has got hemoglobin of less than 7 gram, we should consider transfusion of blood and blood products in these patients. So we should have an idea about the type of hemorrhages as well. So American College of Surgeons gives us idea about the 4 classes of hemorrhages. Class 1, 2, everyone is aware about these classes, but class 3 and class 4, we have an idea that these patients who come in class 3 and class 4 hemorrhages, they might need blood and blood components. So goals of transfusion. So we should be able to provide most appropriate blood product is the goal of transfusion, and to restore and maintain blood volume, adequate oxygen carrying capacity. We should be able to avoid hypoxia to the mother and baby. And we should be able to achieve hemostasis with the usage of adequate and appropriate blood components. So when I practice usage of blood and blood components in obstetric patient, I consider an acronym called as WAT acronym. So when we have this acronym, we have to have an idea about what is required, where W stands for what is required, which blood product is required. Second thing, how much it is required. A stands for actual component, if it is required or not, and time duration on which basis we are going to do the transfusion as well. So till the blood arranged, we should be able to maintain the blood volume. That's why we should be using few of the components like crystalloids and colloids. So crystalloid to blood transfusion ratio should be 3:1. Crystalloids can like Ringer's lactate, normal saline, balanced salt solutions like plasmolite can be used in these situations. Colloids like Heta starch or albumin can be considered. Albumin is controversial again, but multiple guidelines, they do consider using albumin as well in these situations. So we should be having an idea about the massive transfusion as well. So definition of massive transfusion says that 10 units of RBCs in one whole day or 24 hours is considered as massive transfusion, or 4 or 5 PRBCs transfusions within 1 hour, or replacement of 1/2 of patient's blood volume within 3 hours. So multiple guidelines, they have multiple definitions, but all of these, they give us an idea that patient's requirement of blood and usage of these blood components is very, very important in these patients. So massive hemorrhage needs coordinated effort between clinicians and the blood bank. Massive hemorrhage protocol at institutional level should be clear. Everyone should be aware about the massive transfusion protocol as well. Cross-match blood or Rh negative O group blood can be administered to prevent the risk of Rh sensitization as well. So types of blood products, everyone is aware about these things. So we can use whole blood, we can use packed red blood cells, which can be leukodepleted or non-leukodepleted. We can use FFPs, platelets, cryoprecipitates, and clotting factor concentrates. So let's talk about PRBCs. PRBCs contain red blood cells. Each unit of PRBC has 180 to 200 ml of RBCs, 50 to 70 ml of plasma. They improve oxygen carrying capacity if the hemoglobin is less than 6 grams. And type-specific and cross-match blood is required for usage of PRBCs. Platelets. 1 unit of platelet increases the platelet count by 5,000 to 10,000 cells per microliter in the absence of platelet destruction or dysfunction. Blood product most often associated with blood bacterial contamination is platelets because it is stored at 20 degrees Celsius and it may cause bacterial contamination. So microvascular bleeding with platelet count of less than 50,000 is imminent. So we can consider usage of these platelets in patients who are coagulopathic or who have platelet dysfunction. So possibility of transfusing ABO incompatible platelet we can use ABO incompatible platelets, but in the patients who have chances of having RH immunization, in that we at least should consider that RH status in those platelets. So fresh frozen plasma, all plasma proteins and clotting factors will be in the fresh frozen plasmas except factor 8 and von Willebrand factor. So microvascular bleeding due to the clotting factor deficiencies, and in a situation where INR is more than the 2 times of the normal one, we can use FFPs. Massive transfusion with coagulation abnormalities. So dilutional coagulopathy is a thing which can happen in obstetric situations. So we should consider giving FFPs when we are actually giving massive transfusions. So it should be allowed or after thawing only. So cryoprecipitates. Cryoprecipitates are nothing but factor 8 and fibrinogen. In the situations where we are actually thinking that there might be a fibrinogen deficiency, we can consider using cryoprecipitates as well. Or conditions where congenital anomalies are there and patients are lacking fibrinogen or fibrinogen function. So I have collected Green Top Compendium guidelines from Royal College of Obstetrician. Those say that obstetric conditions needing blood transfusion need to actually lead to morbidity and mortality. So the important issues in blood transfusion are adverse events in the transfusion, including potential infection, rising costs, and the possible future problems of availability. The aim of these guidelines are neither to compromise the affected woman nor to expose her to the unnecessary risks by giving unnecessary products. So we should discuss the strategies to maximize the hemoglobin level at the delivery as well as to minimize the blood loss. So let us talk about the antenatal management. We should consider that in stages of labor, before stages of labor, we do have these ANC visits. In those ANC visits, we should consider if a patient is at risk. So we should identify such patients. We should discuss and clarify the usage of blood, anticipated usage of blood products in the labor. Then we should have this consultant-led care. We should be able to discuss these things with patient and patient's relatives also. We should be having optimal location, as madam has discussed in the previous lecture, that it should be an optimal location for delivery with good tie-up with the blood bank. We should be able to minimize other causes of anemia and blood loss. We should be able to optimize hemoglobin, iron, B12, and iron stores. We should be able to minimize the blood losses during the obstetric situations, and there should be a restrictive strategy. Antiplatelet and anticoagulant drugs can cause problems, so they should be withheld. So, management of active hemorrhage. Before discussing the practice points, I would like to talk about the principles. The principles are early definitive management. We should be able to obtain hemostasis as quickly as possible. We should be able to record ongoing losses. So early definitive management comprises of operative interventions, cell salvage technique, which is very rare, but people do use cell salvage techniques also. Pharmacological agents like tranexamic acid, recombinant factor 7, and topical hemostats also can be used. Cryoprecipitate, fibrinogen concentrate, or prothrombin complex concentrates also can be used. So let us discuss about the practice points from the RCOG and as well as National Blood Authority of Australia. When we are considering red blood transfusion, major blood loss can develop rapidly around the time of giving birth in the absence of hemodynamic compromise. Hence, close monitoring of all women should be considered. In maternity patients requiring massive transfusion, the use of RBC and other blood components may be life-saving. So, however, in non-maternity patients, transfusion of RBC and other blood components is independently associated with mortality and morbidity. In maternity patients with critical bleeding, a structured approach is needed. In maternity patients who are not actively bleeding, RBC transfusion should not be dictated by hemoglobin concentration alone. Clinical status and patient's condition is also very important. In maternity patients who are not actively bleeding, non-transfusion therapies, including iron, should be considered as part of treatment of anemia preemptively. So, in maternity patients who are not actively bleeding, where transfusion is indicated, single unit of RBC followed by clinical reassessment to determine the need of further transfusion is appropriate. It has been traditionally said that if there is a need of one RBC, might as well reassess and reevaluate whether you actually need that one PC or one PRBC. In maternity patients, the risk of RBC alloimmunization and potential clinical impact should be considered when balancing the risks and benefits of RBC transfusion. Direct evidence of efficacy of RBC transfusion for treatment of anemia is not available in maternity patients. So hemoglobin concentration of more than 90, you can actually consider that giving RBCs in this patient might be inappropriate. Hemoglobin concentration between 70 to 90, you have to consider the patient's situation, and then you have to take a call whether you need to give one PRBC or more than that. In hemoglobin concentration having less than 70 gram per liter, RBC transfusion may be associated with reduced mortality and may be appropriate. As I have discussed about the transfusion trigger, considering transfusion trigger of less than 7 is a good idea. So, practice points in bleeding maternity patients. So, all providers of birthing services should develop a plan to manage obstetric hemorrhages. The plan should give consideration to local resources, transport and access to relevant specialist advice like hematologists and transfusion specialists. So in women with major obstetric hemorrhage, in addition to clinical observations, the following parameters should be considered. Temperature of the patient, acid-base status, ionized calcium, hemoglobin, platelet count, PT and INR, and APTT and fibrinogen level. If we can get a fibrinogen level, in few of the institutes, fibrinogen level is readily available, but in smaller nursing homes, it becomes difficult to get those fibrinogen levels easily. So with successful treatment, values should be trend towards normal. In situations where we actually need to just treat the numbers, you should treat the numbers. So values indicative of critical physiologic derangement are temperature less than 35 degrees Celsius, pH of less than 7.2, where base excesses are worse than -6, lactates are more than 4 millimoles, ionized calcium is less than 1.1 millimole, platelet count is less than 50, PT is more than 1.5 times, INR is more than 1.5, APTT is more than 1.5 times the normal, and fibrinogen levels are less than 2.0 grams per liter. So in women with major obstetric hemorrhage requiring massive transfusion, suggested doses of blood components are FFP. In India, we practice 10 to 15, but internationally they have suggested that 15 ml per kg body weight we should consider. In platelet should be given as one adult therapeutic dose. Cryoprecipitates as 3 to 4 grams, or if we are going to calculate it by volume, they should also be considered as 10 to 15 ml per kg body weight, or as directed by hematologist or a transfusion specialist. So practice points for coagulopathic patients at risk of bleeding. So the patients who are not actually bleeding but are coagulopathic according to the numbers, in such patients, A platelet count of more or equal to 50,000 is considered acceptable for vaginal or cesarean birth. However, lower platelet counts may be tolerated. In maternity patients with abnormal coagulation tests who are not bleeding, like concealed bleeding should not be excluded. The routine use of cryoprecipitate or FFP is not supported. There was no evidence to define a threshold fibrinogen level because it cannot be practiced on an ethical level. In maternity patients, underlying cause of coagulopathy should be assessed and treated, where transfusion of platelets, cryoprecipitate, or FFP is considered necessary. The risks and benefits should be considered for each patient and expert guidance should be sought. Maternity patients with pre-existing hematological conditions like thrombocytopenia, inherited or acquired, should have their condition optimized before giving birth and have a multidisciplinary approach, again considering experts' advices. So, practice points in intraoperative cell salvage. The institutes who have these techniques, they should use these things in maternity patients. Cell salvage should be considered if anticipated blood volume loss is likely to result in transfusion. So if there is an anticipated transfusion, might as well consider before the intervention that cell salvage can be done. In maternity patients who are at increased risk of bleeding and in whom transfusion is not an option, cell salvage should be considered, like Jehovah's Witness or patient who refuse to take blood. Cell salvage requires a local procedural guideline that should include patient selection, use of equipment and reinfusion, and all staff operating cell salvage devices should receive appropriate training to ensure that they are familiar with the proficient technique. See, in RHD negative maternity patients receiving salvaged blood where the cord blood group is RHD positive, a dose of RHD immunoglobulin should be considered. So practice points in interventional radiology where you cannot consider it just by treating the numbers. Preventive interventional radiology may be appropriate in few patients, but the risk of complications from the procedure should also be considered. Although the role of therapeutic IR in the treatment of major obstetric hemorrhage is unknown, it may be considered in the overall approach as well. So usage of tranexamic acid. In maternity patients with significant blood loss, the early use of within 3 hours of tranexamic acid is considered, and it had shown good results as well, considering the results of CRASH 1, CRASH 2 and CRASH 3 trial. Even though it was used for trauma, but it has got wonderful extrapolations in obstetric patients as well. Tranexamic acid should only be administered in the context of overall patient management. The protocol should include strict attention to the control of bleeding, physiological and metabolic parameters, coagulation status and temperature maintenance. So usage of newer drugs like recombinant activated factor 7. The administration of recombinant factor 7A may be considered in patients with life-threatening hemorrhages, but only after conventional measures, including surgical hemostasis and appropriate blood component therapy have failed. Ideally, recombinant factor only be considered to maternity patients as part of locally adapted massive transfusion protocol. The MTP should include strict attention to the control of bleeding, physiological and metabolic parameters, coagulation status and temperature maintenance. When recombinant factor is administered to patients with life-threatening hemorrhages, an initial dose of 90 microgram per kg is suggested. So I have taken these references as I have spoken from National Blood Authority, Australia and Royal College of Obstetricians and Gynecologists. So my conclusion is do practice guidelines. Thank you.
Thank you, sir, for your valuable guidance and for informative inputs. Thank you. Thank you.
Thank you. We are lucky to have Kumtekar sir's lecture in our session. It's my privilege to introduce sir. Sir is a consulting obstetrician, gynecologist, infertility specialist and medico-legal consultant. Sir is always there to help us to give the right advice. He is in professional practice since last 31 years, in medico-legal practice since 20 years, infertility practice since 15 years, partner in state-of-art center in Solapur since 15 years at Navjivan Hospital, owns his own 12-bedded maternity hospital in city of Solapur, convener medico-legal cell IMA Solapur, member medico-legal and ethical committee FOXY, past member of medico-legal committee IMA state branch, past president of Solapur OBGY Society, and the list is endless.
Yes, thank you.
Over to you, sir.
Thank you, sir. Nobody needs this much long. Anyways, sorry for this intervention because I have some other commitment to go and I have to go. And sorry for this intervention when I'm going to speak against intervention. Anyway, thank you very much, Solapur OBGY Society, for giving me this opportunity to talk on a topic which is very close to my heart and which I have practiced in my obstetric practice. After Dr. Nagpal's lecture, everybody has very much fear in mind and heart about the progress of labor and all these things. I'll try to allay this anxiety and follow the practice protocols which have been recommended by SOGS on how to safely prevent primary cesarean section. The print on 13 December 2019, cesarean deliveries have become an epidemic in India. Record 300% jump in last decade. Since 2008-9, cesarean deliveries, also known as C-section, have doubled in India at both government and private hospitals. C-sections have, however, become increasingly common in both developed and developing countries, including India, where experts call trend an epidemic, blaming it on an unregulated market, financial incentives, an increasing trend of women opting for it. All the three realities, but let us see how to tackle with them. Why one must be worried about the increasing rate of cesarean section? Just one day before, we had a discussion for public that cesarean is very safe. Is it? Alarming increase in CS rate uniformly all over India. Unwarranted indications of CS, I am coming to that. Assumption that CS is safe and counseling the patient accordingly. I will also explain this. Failure to understand the natural progression of labor because we don't know the applied physiology of labor, normal labor. Ignorance about long-term implications on the health of women. This is the most disregarded aspect of taking the patient for cesarean section, which are now coming up. Obstetric complications directly related to previous seizure and changed lifestyle and fallout of ART complications. Assuming that all ART conceptions required cesarean section is a wrong assumption. Balancing the risk as benefit. So this is a very, maybe it is difficult to read, so I will read it to you. Is really cesarean section really safe? As you can see from the table, it is against vaginal delivery and cesarean delivery. Overall, severe morbidity and mortality is 8.6% in vaginal delivery against 9.2% in cesarean sections. Maternal mortality 3.6 per lakh against 13.3 per 1 lakh. It's not safe. Amniotic fluid embolism 3.3% against 15.8% in cesarean section. Do you really believe cesarean section prevents amniotic embolism? It's exactly opposite. Third degree or fourth degree tear not applicable to cesarean section. Placental abnormalities increase with prior cesarean delivery versus vaginal delivery, and risk continues to increase with each subsequent cesarean section. But Dr. Patil, if he is here in mic for you, the explosive, okay, fine. Can you hear me now? Okay. In our third tertiary setup, consecutively for 4 days, we had placenta acrita, placenta previa patients consecutively for 4 days, which were attributed to previous cesarean section. Urinary incontinence, no difference between vaginal delivery and cesarean delivery after 2 years follow-up. And postpartum depression, no difference between both. Lacerations and all these things, fetal injuries, I will not go into the details. But believe me, the figures tell you clearly, cesarean is no more safe. Vaginal delivery is always safer option. These are the indications for primary CS, as you can see. Are the obstetric indications: preeclampsia, labor arrest, malpresentation, maternal fetal problem. Maternal request is 3%, multiple gestation 7%. As against the newer indications which have come up in the modern obstetrics, which I don't call it the modern obstetrics, but the prevalent obstetrics. Oligohydramnios, the worst possible indication for cesarean section. Cord around neck. As you know, in normal deliveries, around 30% of the babies deliver with cord around neck with no untoward incidents. PROM, ART pregnancy, misconception that all ART pregnancies require cesarean section. On-demand CS, well, a debatable question. Neighbors envy, one more important factor, and vitamin M. In brief, we'll go with a bit of physiology of labor, and then we'll discuss how to prevent, how to safely prevent. And these are all SOG recommendations and nothing new or from my own thoughts, but it's all the SOG recommendations. Latent phase extends up to 20 hours in primary and 14 hours in multipara. The definitions of prolonged latent phase are still based on data from Friedman and modern investigators, and modern investigators are particularly focused on the latent phase of labor. So it's still the Friedman's curve. Most women with a prolonged latent phase ultimately will enter the active phase with expectant management, which we are lacking at present. Thus, a prolonged latent phase that is greater than 20 hours in nullipara or greater than 14 hours in multipara should not be an indication for cesarean section. First stage of labor and arrest. First stage extends up to full dilatation of the cervix. From what point of time? Before 6 centimeter dilatation is achieved, standards of active phase of labor should not be applied. And we in our practice are worried from 1 finger dilatation. Arrest of labor in the first stage, spontaneous labor more than or equal to 6 centimeter dilation with membrane rupture or one of the following: 4 hours or more of adequate contractions, more than 200 Montevideo, or 6 hours or more of inadequate contractions and no cervical change. That is where you tend to label it the arrest of second stage of labor. First stage of labor, sorry. Second stage may extend up to 3 hours. Now, after full dilatation, even if it is 10-15 minutes, we are upset, we are worried, we are anxious. It can be extended up to 3 hours. Before diagnosing arrest of labor in the second stage and in the maternal and fetal condition permits, at least 2 hours of pushing in multiparous women and at least 3 hours of pushing in nulliparous women should be allowed. Longer durations may be appropriate on an individualized basis. So, to safely prevent cesarean section, you can allow more than 3 hours provided individualized, all the use of epidural analgesia or fetal malposition as long as progress is being documented. Very weird to hear these recommendations, but they practically were, believe me. Management options to reduce cesarean section delivery in second stage, operative vaginal delivery, which is a lacking art. People are not ready to use vacuum forceps. They should learn the art. Many of the cesarean sections just can be avoided with vacuum extraction. Our teacher, Madam Sardesai, is here. We were working, Dr. Rajiv Dabde is here. In our times, we were working with vacuum. So many vacuum deliveries we have done without any untoward incidents. Comparison of the outcomes of operative vaginal deliveries and unplanned cesarean deliveries shows no difference in serious neonatal morbidity, that is intracerebral hemorrhage or death. And manual rotation of fetal exit, which you have forgotten this art. Of course, you need a cautious hand to perform this, but believe me, this can be performed. We have done it in our early days. Try to learn manual rotation of occiput from posterior or maybe lateral to or transverse to anterior, and you will find that the patients deliver normally. Recommendations with gradation, then this is again very difficult, but these are the SOG recommendations. I'll read them from you, and they depend on the grade of recommendations from 1A to 3. First stage, a prolonged latent phase greater than 20 hours, I already told it, should not be an indication for cesarean. Slow but progressive labor in the first stage of labor should not be an indication for cesarean. Cervical dilation of 6 cm should be considered threshold for active phase. Thus, before 6 cm dilation is achieved, standard of active phase should not be applied. It has a strong evidence. Cesarean delivery for active phase arrest in the first stage of labor should be reserved for women at or beyond 6 cm dilatation with ruptured membranes who fail to progress despite 4 hours of adequate uterine contractions or at least 6 hours of oxytocin administration. We are in a hurry. After 1 hour of oxytocin, we will look at the CTG and we take the patient procedure that allows 6 hours. And with this, believe me, Western world has reduced the cesarean section rates to up to around 15% without any untoward perinatal or maternal complications. Second stage, a specific absolute maximum length of time spent in the second stage of labor beyond which all women should undergo operative delivery has not been identified. So whether it is half hour for me or 4 hours for you is a different, it is not identified, but it has strong recommendation that you should wait. Before diagnosing arrest of labor in the second stage, at least 2 hours, if this is repetition, 2 hours of pushing and 3 hours of pushing in nullipara. Longer durations appropriate, individualized. Operative, it is again a strong evidence. Operative delivery, again a strong evidence, strong recommendation. Manual rotation, strong recommendation. Fetal heart monitoring, amniofusion for repetitive variable fetal heart rate deceleration may safely reduce the rate of cesarean delivery. Don't rely much upon CTG. Actually, I should point out that the last time the Fernandez protocols were, or the workshop was being undertaken, when she was telling about the antepartum fetal surveillance, if you could read in between the lines, every recommendation, there was a unprinted message that caesarean section is not required, or don't rely upon this report, or be very specific about this report. Be very conservative, or have a lot of reservations about these reports, and CTG is one of them. In Japan, when they started, when the caesarean section rate went up 25%, retrospectively they started studying why it should be, and they blamed it all on electronic fetal monitoring. Too much reliance upon electronic fetal monitoring. Scalp stimulation can be used as a means of assessing fetal acid base status, which is not admitted as a strong recommendation. Induction of labor. Before 41 weeks of gestation, induction of labor generally should be performed based on maternal and fetal medical indications. Inductions at 41 weeks or gestation and beyond should be performed to reduce the risk of caesarean delivery. It should be performed to reduce the risk of caesarean delivery. This is a message in this recommendation, and the risk of potential morbidity and mortality, which I already explained. Cervical ripening method should be used when labor is induced in women with an unfavorable cervix. They must be unperformed. Now, there is again a rider. We put in a cervical cream gel, wait for 3 hours, nothing is happening, we take the patient for cesarean section. Absolutely not indicated, intervention is not required. You should give sufficient time for cervical ripening. 3 hours or 6 hours is nothing. Cervical ripening method should be used when labor is induced in women with an unfavorable cervix. Strong recommendation, if maternal and fetal status allow, caesarean delays for failed induction of labor in the latent phase can be avoided by allowing longer durations of the latent phase up to 24 hours or longer, and requiring that oxytocin be administered for at least 12 to 18 hours after membrane rupture before deeming induction a failure. What a strong message, dear friends. We are not following this applied physiology of labor. Other recommendations, fetal heart rate tracing, how much importance to give? You had enough lessons yesterday. Induction of labor, you had enough lessons yesterday also. Fetal malpresentations, well, try external versions, try them. Suspected fetal macrosomia, absolutely a myth. In Western countries, they allow up to 5 kg. After 5 kg, it is labeled as fetal macrosomia. In our country, 3.5 kg, we label it as a macrosomia, and we just take the patient for elective surgery. Dear friends, we need to review this decision. Suspected excessive maternal weight gain, again. Twin gestation, if the first is by vertex, allow natural delivery. Herpes simplex, if treated, or if under antiretroviral therapy, or if declared immune, no need of caesarean section. Continuous labor and delay support, that is being given the most importance in Western world, and we should follow it. Patient must be counseled, must be given references, must be given, told about natural delivery and all these things. Counseling is important. Just shift her is not the advice. Labor management protocols, I am coming to last 2-3 slides. So these are recommended by various protocol committees and all these things, and ACOG and all this. An orderly and systematic approach of labor management results in reproducible beneficial maternal and perinatal outcomes. Overall, it reduces the rate of caesarean sections, may not be palatable, acceptable to majority of us. Active management of labor with amniotomy and oxytocin are widely used. Dilatation rates of 1 to 2 cm per hour are accepted as evidence of progress after satisfactory uterine activity has been established with oxytocin. This can require up to 8 hours or more before CS is performed for dystocia. These labor interventions and relatively infrequent use of caesarean section did not jeopardize the newborn. We are worried about the medical girl, but it doesn't make difference. Obstetric Care Consensus Committee, this is taken directly from the ACOG and reprinted by Williams in its latest edition. 4 recommendations, repetition of what I have previously said. The first admonishes against caesarean delivery in the latent phase of labor. Specifically, a prolonged latent phase is not an indication for cesarean delivery. This guideline is not new and is traceable to the work of Friedman, on which traditional tenets are based. The second directive too is conventional practice. It recommends against cesarean delivery if labor is progressive but slow, a protraction disorder. This instance is typically managed with observation, assessment of uterine activity and stimulation of contractions as needed. A third instruction addresses the cervical dilatation threshold that serves to herald active labor, namely a cervical dilatation of 6 centimeters and not 4 centimeters, is now the recommended threshold. Thus, before this threshold, standards for active phase should not be applied. A forced stimulation notes that the cesarean delivery for active phase arrest should be reserved for women at or beyond 6 centimeter dilatation with ruptured membranes who fail to progress despite 4 hours of adequate uterine activity or at least 6 hours of oxytocin administration with inadequate contractions and no cervical change. Dear friends, thank you very much for listening to this. This slide I use it very much because most of us, I don't blame anybody, the circumstantial, medical legal threat, neighbor's envy, vitamin M, or these are the minor factors, but the fear in our mind or non-application of applied or non-application of physiology of labor and the rest of the audiences, we are the rest also, we are sleeping on the physiology of labor. While the middle one person is confused what after my talk, where I should go. Well, be individualized. But it's my sincere appeal, before running a knife, before taking an incision, think twice. The younger generation particularly is going to be in lot of trouble because of primary cesarean sections, secondary cesarean sections, tertiary cesarean sections or second, third, fourth are going to be much more difficult for you people. They are going to put you in lot of trouble, placentations, abnormalities and all these things. And you are in trouble besides patients' morbidity and increased patients' morbidity and mortality. Thank you for this opportunity and thank you for this intervention in the schedule of which in which I have talked against intervention. Thank you very much.
Thank you, sir. Actually, I would like to call your lecture the title lecture. Title song असायचं ना, तसं title lecture of our theme of the conference, revisiting the journey of labor.
Thank you.
Failure to understand the natural progression of labor. कधी we forgot, and patience, vacuum, forceps. This also needs to be re-emphasized. Are there any questions?
Is NST required to, is there a medical legal implication as the previous talk they have mentioned?
Yes. Now, if you mix up the messages given, medical legal always gives do be safe, do whatever maximum you can do. But you have to decide, it is a case based. Just because one decision went again, because there was no CTG, doesn't mean that you are in deep trouble. Fernandez protocol has given enough information when CTG is to be taken. I should go back, I am sure Anjali is going to post the whole conference on YouTube. Visit Fernandez protocol. As I have told you, in every sentence they had an encrypted message that helps you to prevent cesarean section. Take the message positively to prevent cesarean section rather than negatively to do cesarean section. And you will have your answers.
Can I ask one?
Yes.
Not a question as such, but comment. I had an opportunity to talk on this subject in Solapur, as to shift in cesarean section, paradigm in the pattern of cesarean section. And that time, while going through a book, I came across a very good this thing, and it is very necessary to avoid this primary cesarean section. And one thing which came is to please leave low risk patients on their own.
Yeah.
Ask them to come in active labor. If you ask them, you must have seen patients coming with 5 centimeter, 6 centimeter dilatation will hardly require a cesarean section. By the she comes, you prepare her, she is full dilatation and she delivers. So if we want to reduce the cesarean section rate, primary cesarean section rate, ask the patients. I am leaving aside the high risk cases. low risk cases.
Yes.
I think it will be 20% high risk cases.
Yes.
80% are low risk
Low
cases.
risk.
And these low risk cases, primi-gravidas, should be asked to come in active labor.
Right.
To ask them चांगल्या कळा सुरू. I'll give you this thing. In Australia, you all know that there is a very shortage of manpower. Our own student, Preetam Ganu, who is an obstetrician there, she herself said that there, unless the cervical dilatation is 4 centimeter, 5 centimeter, they don't admit
them.
To her own, she said, myself, I had so many contractions. My mother started, let's go to hospital. She said, no, unless I'm inactive, they will not. If you go, they refuse and send the patient back home.
Back to home.
Because they don't have people to cater these women because manpower is so short. So that is why ask them to come in active phase of labor.
Right.
So चांगल्या कळा सुरू झाल्यावर तू ये, low risk cases. I am not about.
Yes.
So
Even
that,
this, yes.
to some extent, is going to
Reduce the
cut down
cesarean section.
this, primary cesarean section.
And these recommendations basically for non-complicated cases only, believe me. Complicated is a case-based, it is how much complicated or how much risk is there, you have to decide. But these are mostly, as madam said, 80% are uncomplicated cases. This is, these patients deserve this trial. Thank you very much.
Thank you so much, sir.
Thank you, sir. Thank you, Sardesai madam.
I now request the chairpersons to please felicitate. Yes, sorry, sir.
Whatever I am going to say right now will create another controversy. WHO has said that any country should not have cesarean section rate more than 10%. If it is occurring, something is wrong. Yesterday we had a very reputed Fernandez Hospital statistics, and the madam said that in low risk cases we are having 40% incidence of cesarean section, and in high cases it goes to 60 to 65%. In medical college, in 3 medical colleges I have opportunity to work as a professor and HOD. It started with 25% to 35% right now, currently it is. I had also association with private medical practitioners through OB-GYN Society of Latur, and my wife also practices. So I have that statistic also available, and the rate is rising, and it has gone to 65% to 70% in private hospitals. What Nagpal sir told today morning really disheartened to practice obstetrics.
I told you, these were, Sanjay, these were only few of the cases.
Yeah.
You don't know the 90 cases which have been acquitted.
Yeah.
These are the positive cases which harm our mentality.
They do
That's
more
it.
harm than
Yes.
encourage us to
But believe me,
practice a beautiful branch of obstetrics.
in my own practice, I didn't have these guidelines, but believe me, in my own practice, I'm not boasting. Anybody can come to me and inspect my statistics. My cesarean section rate never went up 10%. Never more than 10%. 50% of my deliveries were primi, and hardly there was any cesarean in primies. So all these years, sincerely, I have tried to avoid primary cesarean section.
In fact, I would like to congratulate Solapur OB-GYN Society to have a conference of revisiting the journey of birth, where everything is flooded with endoscopy, infertility, and all other things. We are happy we shall be when we learn our ABC. So this is our ABC. We have to revisit it. Thank you.
Thank you, Sanjay.
Yes, thank you organizers for giving us opportunity to chair this session. Thank you, Jamma madam, Magai madam, Monica, Archana.
I request Madam Milind Shah sir and Guram sir to please come on the stage, and I request the chairpersons to please felicitate the speakers of this session. Can I request the chairpersons to felicitate Dr. Kumtekar sir, please? Dr. Yogesh Rathod and Dr. Sujata Dalvi madam. Madam. I request the chairpersons to please felicitate the chairpersons for the session, Dr. Sharmila Madam and Sujata Kulkarni Madam. Madam. Madam, wait karo na photo. आता तूच आहे ना आता एमओसी तू आहे ना हां मी अनाउन्स करते तुला देते Yes, thank you, sir. I now request Dr. Prajakta Shitole and Dr. Nisha Kotwal to please take over for the next session.
Thank you, Monica. We move on to our third session. I would like to invite our chairpersons on the dais, Dr. Vidya Karvekar Madam and Dr. Meena Gunzotikar Madam. Dr. Vidya Karvekar Madam is a consultant gynecologist and owner of Karvekar Hospital for past 28 years. She was a consultant at Muscat for 8 years, past president SOGS since in the year 2000, was a faculty on topics like LSCS and CS cervix. And she is a very beautiful painter. I welcome you, madam.
I welcome Dr. Meena Gunjotikar Madam. She is MBBS MD Gynec. She is consultant of Gunjotikar Nursing Home, consultant SSNJ Ayurvedic Hospital since 18 years. We welcome you, ma'am.
Initially, I would like to thank the organizers to chair this session.
A very good morning to one and all. We have a very interesting session, that is a debate. The debate is something which everyone looks forward to in every conference. I don't think anyone sleeps during these sessions. Today we have two debates. For the first one, we have two eminent gynecologists who will debate on a very burning topic, that is VBAC versus elective cesarean. To talk on VBAC, we have with us Dr. Bakul Jagirdar. She is a consultant obstetrician and gynecologist at Chitale Hospital for the past 18 years. She is consultant at Ashwini Sarkari Rugnalaya Solapur, and she has presented papers in state and poster in national conference. Her special interest is in high-risk obstetrics. And then, so she will be talking on VBAC. And our next proponent for the elective cesarean, we have an equally strong proponent, Dr. Sadhna Deshmukh. She is a consultant at Suyash Nursing Home for the past 30 years, and she is working at Ashwini Hospital, Solapur. So brace yourself, friends, to hear what they have to say. Now over to Dr. Bakul.
First of all, I would like to thank Kumtekar sir from bottom of my heart to shift his presentation earlier. He has done half the job I wanted to do. Thank you so much. So we have a debate on the burning topic of vaginal birth after a cesarean section versus elective repeat cesarean delivery. I will be speaking for VBAC, and my dear fierce warrior friend Sadhna madam is ready with her sword for ERCD. So the terminologies we will be using in our presentation are TOLAC, that is trial of labor after a cesarean section. It can culminate into either successful delivery, which is VBAC, or the TOLAC can fail and lead to emergency cesarean delivery. ERCD is the elective repeat cesarean delivery when cesarean section is done without giving a trial at 39 completed weeks. Now, if we see the first documented successful record of cesarean section dates back to as way back as in 1500s AD, when a Jacob Newman, not a doctor, a butcher, did a successful cesarean section on his wife who was in obstructed labor for days together to save her life. The interesting fact is, not only the woman and the child lived, but she subsequently gave birth vaginally to 5 more children. Friends, there is a first successful record of VBAC in 1500s, and we say that in 2100 it is, in 21st century it is not possible. How we can say that? Now I want to ask every one of you, what do you think is good for your patient? A normal delivery or a cesarean section? Given a choice, what would you choose? Anybody would choose a normal delivery. Then why not after a cesarean section? What is there to fear so much about TOLAC? The single word to explain the response of all the obstetricians towards TOLAC is fear. Let us define this fear. Fear of what? Fear of scar dehiscence, scar rupture, perinatal mortality, morbidity, medico-legal liabilities, as we have heard so much in the morning. But any fear is wrong because it makes you makes you go do the suboptimal choices. So it is necessary to get our fears and act rationally. Now, what is the biggest fear that comes to mind when we think of trial of labor? That is scar rupture. Now let us face this fear head on. Let us see whether the rupture of scar is really in reality, is it a real fear, or is it an exaggerated perception of us that it is there? So what the international studies say, these are studies with a very large sample size of 17 to 20,000 patients. All of them worldwide are saying that there is a 70 to 80% success rate. And what is the rate of uterine rupture? Can we see that over there? 0.1 to 0.3. Now everybody will say, those are the international standards. Madam will say that there is such a state-of-art facility and manpower and everything is available over there. What about us? Let us see the Indian experience. Our own consultant from Ashwini Hospital, Dr. Pradeep Patil, he has done a study on VBAC in 2004. And he and the other people in India are saying that 70 to 80% success rate of VBAC. 20 to 30% failure does not mean the uterus ruptures every single time. It happens in less than 1% of the patients. Okay, perinatal mortality everywhere was comparable. Let us say about what happens in rural India. Everybody says that TOLAC has to be in a district place, in a big setup, in a tertiary care center. Kangra is a small village in the Himachal Pradesh. The Soni et al. Has done a study of 400 patients of TOLAC. Let's see what he wants to say. He says that under strict supervision, TOLAC is a reasonable option even in rural India. Are we going to listen to it or not? The study of NICHD done in 1999-2000 with a comparative study of TOLAC and ECD, elective section. It is used to project the exaggerated fears about the TOLAC. Why? Because it quotes a uterine rupture figure of 124. Well, the fear of uterine rupture in TOLAC group might be more, but are we going to see the other complications? They are comparable in ERCD and TOLAC. I want you to concentrate on maternal death. Maternal death in TOLAC group, in that study is 3 and it is double in ERCD group. How can you say, madam, that ERCD is going to be a safer option for us? We can't. What about the neonatal mortality and morbidity? Do you see a 0 over there? I don't. So nothing is completely safe. It is how safe we can make it for the patients that matters. Now, how to reduce this complication rate so that we can actually make it more acceptable worldwide for betterment of the patients? Very nice guidelines are given by IRCOG. Green Top Guideline 2015 and ACOG in 2017. They emphasize on antenatal counseling, informed consent, case selection, antepartum checklist and triaging, and intrapartum monitoring and management protocols which are to be strictly adhered to. Now, patient counseling. It's a very interesting thing. It depends upon what you tell the patient. If I say that I can give you a trial, but you know, in the process your uterus can rupture, your baby can die, you also can die, even I will get scared. So it, sorry. It depends upon what we tell the patients. So let us not scare them off. We have to be unbiased and we have to be unprejudiced. Evidence-based information should be given to the patient by giving information leaflet in antenatal period. And the patient and the family has to be taken in confidence, time given to them, for 2 extra minutes given to them for counseling their fears. And whatever decision is taken has to be documented in antenatal records. That is very important, so that when she comes in labor, especially institutes, it is very clear what they want to do. Informed consent, well, it cannot be overemphasized, the importance of it. Are the patients making an informed decision? Is the study done worldwide, from the most advanced country like America to the least advanced country like Kenya? Let us see what those studies said. The studies were about doctors' approach towards TOLAC and patients' perception of doctors' approach. Okay, they say that recommendations done by doctors exert strong influence on patients' decision. Not even 50% women knew that the risk of uterine rupture in TOLAC was minimal. They thought that they were counseled against TOLAC by the doctors. So why patients? I think we doctors need to be counseled first. What is the most important factor in successful TOLAC is the case selection. The cases have to be selected very, very carefully in order to not to fail, because the complication rate, if we see, of failed TOLAC are more than either a successful TOLAC or an elective repeat cesarean section delivery. So we want as less failure rates of our TOLAC as possible in order to reduce the complications. The factors favoring success are lesser the age, more it is better for the patient, the less the BMI, previous transverse lower segment cesarean scar, vertex presentation, singleton pregnancy, adequate pelvis, indication of previous cesarean section. It has to be non-recurrent indication. Delivery interval of more than 1 year is important. And all these factors will help us to have good success in TOLAC VBAC we are giving. History of previous vaginal delivery, well, sone pe suhaga, 90% success rate. So they have to be given a chance to deliver vaginally. Most important is skill and experience of obstetrician. Now, my esteemed opponent is not only senior, but she is extremely skilled at vaginal deliveries and induction. I am a witness to that. I have failed to understand why she is so scared in this issue, or maybe she lacks some confidence because of some other perceptions. Maybe after the end of this lecture, she will be convinced to otherwise. What is important is earliest recognition of complication so that it doesn't become grave. So earliest recognition of impending scar rupture is mandatory. Abnormal CTG pattern, non-reassuring fetal heart rate trace, and maternal tachycardia are one of the earliest indicators. We have to train our staff. We have to get trained, and we have a high index of suspicion when a case comes in labor to see these signs. Don't wait for the vaginal bleeding and hematuria and all. The labor delivery considerations should be strictly seen. Spontaneous labor preferred. Scoring system like Flam, Grobman will give us an idea how much success we are going to get in this particular patient. Amniotomy is safe. It is a age-old gold standard method of augmentation of labor. Why we have lost faith in that? Our teacher like Sadesai ma'am is there right in front of us. I want to ask her, when she started her practice in her early days, was oxytocin used such rampantly? So were the patients not delivering vaginally at that time? So if it was good for those patients, well, the human being has stayed same throughout the years. It has to be good for us as well. Oxytocin use can be used, but the dose-related risk is there. So it has to be used in smaller doses. PG even contraindicated. PGE2 controversial, very, very cautiously used. So PGE2 plus oxytocin, same approach. Epidural analgesia, well, there are a lot of controversial studies, but ACOG says it is safe to use. The most important thing that is going to save us and the patient in the long run and going to bring a success of TOLAC is decision to delivery time less than 20 to 30 minutes. It will reduce the chances of complications which we are so much worried about. So is it possible? Everybody, now madam will say that, see, I have such a busy OPD, who is going to wait with the patient? Itna time hai kya? Anesthetist doesn't come so fast, and what if the neonatologist doesn't arrive? What should I do then? But I want to ask every one of you one simple question. Are we not dealing with placenta previas at our centers? Are we not dealing with abruptions and eclampsia at our centers? Do they need a late response? Don't they need a swift response? You have a case of PPH. Can you say that I have a OPD and I can't go and attend that case? PPH is not even 20 to 30 minutes. PPH needs 5 minutes. So what about that? If we are prepared, then why we are making such a big hue and cry about this 20 to 30 minutes time? I will share my experience at Chitaya Clinic with you. I practiced TOLAC. Since last 18 years, I had 2 cases of scar adhesions, no scar rupture. What have saved us is early detection and swift action. See, till antenatal period, we are safe because we are deciding, we are triaging, we are taking consent, we are counseling, everything is done by us. But in labor, we have to make a team, and the approach has to be a team approach. We cannot work individually. So upgradation of the skill of your team is very, very important. This senior staff has to be constantly present with the patient. The obstetrician should be readily available. What is wrong in being available at our own institution readily? I have no clue. Anyway, half of the time we are there only. Then all the PV examinations are to be done by obstetricians. I reassess the patient when the patient comes in labor and see the cervical dilatation, effacement, the station and the scar. If it is not favorable, I don't insist on the continuation of the trial. It has to be a judicious trial, not a strong-headed. The staff has to be trained to identify the red flags of maternal early signs of rupture and the fetal compromise. Active phase of labor, now we have to keep one OT ready in order to avail it if something goes wrong suddenly. Now, people might say that, is it possible to do it 24/7 all the time? How can it be that we are on the guard 24/7? But we are not talking about 24/7. 6 hours is the time we are talking about. Because
Dr.
that is the time.
Please try to conclude.
Okay. And swift action has to be taken so that the patient is saved and the baby is saved. If that is adhered to, we can definitely attend less than 20 minutes. These are so many disadvantages with elective cesarean section. Amniotic fluid embolism and placenta previa accreta, really bad ones. We have had a very bad experience at Ashwini Hospital in last 1 year. 10 cases, 8 belong to 2 sections. Only 1 to previous 1 section. That is very important to prevent that second scar on the uterus. If we continue like this, 33% section rates today, tomorrow time will come when we'll see the news like that in paper that Padma Shri awarded for vaginal delivery. Do we want to wait till that time? Now I want all of us to think very hard and sincerely about the fact, what should govern our decisions? Fear or science? Is it right to stay in our own comfort zone and push the patients in danger zone? In conclusion, I would like to say, VBAC is clinically safe choice for majority of the women with single previous lower segment cesarean section. NIH, ACOG, RCOG are saying it. Who are we to deny that? At least try it. Masterly inactivity and watchful expectancy and swift, timely action is the key. VBAC is not a myth. It is not a havoc. It is a pure science. Evidence-based practice will benefit both obstetrician and patients in the long run, as Kumthekar sir just told us. Most of all, it is morally, ethically, medically, financially, and above all, humanly wrong to make the patients fight battles for your own fears. I learned that courage was not the absence of fear, but the triumph over it. The brave man is not he who does not feel afraid, but he who conquers that fear. Thank you so much.
A very good justification of your support for VBAC, Dr. Bakul. The proper selection of case for TOLAC gives a very good success rate. Indication of the previous seizure is also very important. and not all cases are recurrent indications. So we can give a trial for VBAC. That is what I feel. Now I request Dr. Sadhna to give her reasons for preferring an elective LSCS.
Respected guests, my teachers, colleagues, and my bubbly and agitated opponent, Dr. Bakul. One request to the chairpersons. My opponent has consumed 15 minutes to fight, so it's my request, please consider that time for me also. Bakul, congratulations for your study. I do this before I start my fight. Now, I'm sure I need to protect myself from some bruises and injuries during my next 10 minutes. So next minute. We all know, I'll just use TOLAC and ERCD for, to save the time. Now, coming to the history, we all know the history, how the rise of caesarean section has occurred. It's a worldwide matter of concern and all those. And there came the judicious use of VBAC and ERCD. Craigen once said, once a caesarean section, always a caesarean. It is true to some extent. I give respect to him and bow in front of him. You can see the Caesar rates. Coming to the history of VBAC, in 1980, TOLAC got encouragement, and then ACOG put up the guidelines, and the Public Health Service proposed a goal of C-section, the rate was 15 and VBAC rate was so on. Pitkin in 1991 said, without any doubt, most remarkable change in our jobs over the last decade was managing a woman with prior caesarean delivery. Am I true? Are you all stressed out and so worried and you know everything is at stake when a prior caesarean is for VBAC? Now the paradigm shift on C-section has occurred. New evidence came and medico-legal factors have led to decline in clinicians offering and women accepting VBAC in countries like US and UK. So it is the ignorance or improper counseling in India, I feel, which is with studies have come up and Bakul has supported all this. So, my dear friends, my opinion is no TOLAC. I am against it. We are going to see the results of TOLAC and ERCD. I would like to tell why TOLAC is risky and why we must opt for ERCD. Now we all know what are the prerequisites for TOLAC. We have to review details of previous LSCS, rule out the contraindications, predict the VBAC, decision making is to be done, and then comes the intrapartum support. So it is a big and long process. Okay. Patient counseling, patient's decision is heavily influenced by obstetricians, I agree. But I would like each and everyone to ask, do you take written consent? Bakul, do you take it? You do counseling, when do you start counseling? Do you do a VBAC checklist and you have it attached to all the papers? And patient, they should not be, put into fear that your uterus may rupture, but they have to be told that there is a chance of rupture and perinatal morbidity and mortality which is more than the ERCDs. So proper knowledge must be conveyed to the patient, just not because you want more practice and you want to be successful and bold to do VBAC. Now, you have to tell the patient predictors of successful TOLAC. It is important to know because maternal mortality is less in VBAC. But in any caesarean section, it would be the same as elective repeat. Let me tell you regarding bleeding or anesthesia complications, etc. It is not only after, first caesarean. There is a scoring system devised based on age, BMI, ethnicity, previous delivery, etc. So I want to ask, are we using this scoring system? Anybody in the audience is using this scoring system? Everybody knows it and is documenting and telling her that your prediction for VBAC is so and so. Is there anyone who is doing this scoring system? Please raise your hands. No, see, just look. This is the scoring system. We are not, no Indians are doing this, okay? It is easy to tell about studies happening in UK and US and all those things and the success, but the other things are hidden. So the decision making, a final decision for mode of birth should be agreed between woman and obstetrician around 36 weeks after prior counseling from mid-trimester. Women should be informed about chances of VBAC is 50 to 70%. But what about those 30 to 40%? So we have to tell her that 30 to 40% chances are that you may go in emergency cesarean section. And are we going to tell her if it is late, this is going to happen? Then we have to plan for spontaneous and induction. Induction again have more risk than spontaneous labor. So to wait for spontaneous, chances of stillbirth are there. Intrapartum support, where and how should a VBAC be considered? It is suitably staffed unit with continuous monitoring. Is everyone having this? Okay. Factors influencing are recommendations of opinion leader and professional guidelines, the hospital facilities, the reimbursement policies, medical liabilities, and the most important thing is the patient level ERCD on maternal request. This is very important factor and then filters the patient for TOLAC. Now see the contraindications for TOLAC. Do you know how is the scar? Where the cesarean section was done? Do you get discharge cards from all the patients? There are so many malpresentations, short inter-delivery interval. Again, this is a big list. And the biggest thing is inability to perform emergency LSAs due to insufficient staffing facilities. May I ask a question to all who all are practicing in small nursing homes of their own and who are in the institutions? I'm sure 80% of the people are here who run one-man show in the hospital where there are no in-house anesthetists and pediatricians. Now, ACOG has said VBAC is undertaken in a good setup, but not small hospitals. You have to refer your patients to a facility with available resources. So you have to lose your previous LSS patients for TOLAC to some other institutions. Are you going to do that? Now, I'm sure Bakul has already exaggerated the contraindication, the complications of ERCD and underrated the complications of TOLAC as you have all seen. So many advantages of ERCD. Bakul madam, please look at the list. We can plan the date and time convenient for all. We can keep the blood components ready. Patients are NBM. No labor trouble. Less perinatal mortality. No risk of uterine rupture. No risk of pelvic floor laxity. No risk of traumatic tears. The option of sterilization, though this is a small point, best option is further children is not required. Now, disadvantage of TOLAC. Need of emergency LSAs. You are going to get up just rubbing your eyes at the midnight and then you are to see, are you sitting by the side of the patient continuously monitoring? Is your staff that much trained? Increased incidence of uterine rupture. She has quoted less than 1%, but to me it is 1 to 2%, which turns into catastrophic events. Increased instrumental deliveries and tears and increases chance of stillbirth. Now, TOLAC is successful in spontaneous labors, but for spontaneous you have to wait at least till 40 weeks and it has been documented that after 39 weeks, the risk of stillbirth increases. Again, need stringent monitoring, cannot use oxytocics like misoprostol, PG gel and pitocin with caution. May I know who is using prostaglandin gel, pitocin for previous LSCS? Please raise your hands. 1, 2, 3. Here I think there are 100%. So, to say it is very easy, but if till 40 weeks patients doesn't go in spontaneous labor, are we going to put in a gel? Are only amniotomy and spontaneous delivery is the option safest to all the VBAC doers. So it is very important to ask this question. Again, you cannot predict success. And after exclusion criteria, there are very small number of patients left. Nowadays there are BOH, there are malpresentations, there are high risk, there are elderlies, there are macrosomics, obese patients. No adequate RCTs are available. The numbers are not that big in India to draw conclusions. And there is no long-term data, maybe after 5-10 years, how is the child doing and what has happened to mothers. Whether they have landed in PID and all these things. So reasons for TOLAC success, if you have followed strict protocols in well-equipped hospital, it shows 60 to 70, but it will create havoc if these are not followed. Moreover, just listen to this carefully. Moreover, small setups don't present their data. Has anyone in small setups who are practicing for maybe 20-25 years presented their data against TOLAC and ERCD? And therefore, the TOLAC represents the tip of the iceberg. The studies do not come up. So we cannot deny these pitfalls in country like India or all developing countries. Now, I would just like to highlight a few complications. Look at the perinatal deaths, hypoxic encephalopathies in TOLAC. Stillbirths, neonatal deaths and HIEs are much more in TOLACs. So even if you do, Bakul madam, just listen, even if you do immediate LSCS within 20-25 minutes, after FHR changes, you are going to do it after FHR changes, not after bleeding. It does not always prevent neonatal complications, and you have to tell this to the patients. Here are the studies, I need not quote, all the figures are high. Then coming to the uterine rupture, see, most dreaded consequence leading to a fetal cascade and maternal cascade of complications. I have seen myself in my hospital in early labor when anesthesia was given, 2 babies popped up in front of me when I was draping, and that was a nightmare for me. So long-term studies are not available. Uterine rupture, can we get all the details of previous LSCS? We are subjecting to TOLAC. We do not have discharge cards. We do not know the gestation. Patients do not give proper single or double layer. Inter-pregnancy interval, of course, we can do. And whether previous was an early, it was a planned section, it was in labor, at what dilatation, what was the scar thickness, are we all measuring myometrial scar thickness? Please, I would like to ask the audience, how many are measuring scar thickness and predicting LSCS rates? Again, only 3, 4, 5 hands amongst 100. So, does it truly predict the outcome? Many times we have clinical scar tenderness and the scars are very thick. Some patients no scar tenderness and you find dehiscence. So, this is, really it can't be predicted. So, decision delivery interval, I would like to say in all studies in developed countries, 18 minutes was the cutoff for a good Apgar and better outcome, but more than 30 is poor outcome. So rapid delivery by cesarean section also cannot prevent metabolic acidosis and serious complications, though the life of the child is saved. So really we cannot afford, unless you have anesthetists and pediatricians sitting in your theaters. Then only you can do it. However close they stay, they cannot come down within 5 minutes, give anesthesia, even if GA is given. Here I would say that all should defer spinal anesthesia. See the figures in red, you can see. They are all more dreadful complications in TOLAC. Blood transfusions, I agree to some extent they may need, but any cesarean, that stands for any cesarean sections, but we can always keep blood ready rather than have it at emergencies, you may not get it. Endometritis, the incidence is more and infection may further lead to long-term complications.
Madam, sorry, time equal to Bakul is finished.
Oh, okay. Just last slide. RN family size is ready. I want to ask questions. How many patients produce previous records? Is there an in-house? Is there a training staff? What is the DDI? How is your setup? Are you going to refer? What about rural settings and government hospitals where there is huge crowd? How much time do we have for such patient in our busy practice? So my opinion is it is easy to talk about studies, but practically difficult to face the complications. We are hesitant to try TOLAC in ourselves and our kins. May I know anybody going VBAC after first cesarean section amongst this crowd? Medico-legal safety is different. I wish safe and happy motherhood. Here I would like to say that every now and then we cannot call Kumthekar sir for help for any small medical implication. One litigation, gone is our reputation. So now, take home message. The rise in LSCS is mainly due to IVF conceptions, increased awareness, small families and precious pregnancies, changing lifestyle and increasing maternal request for LSCS. Only way to reduce is reduce the primary LSCS. Be careful while encouraging patients. We cannot afford any morbidity and mortality. Thank you so much. Look at the smiling baby coming out there. And so I think these questions to be answered by the audience and my dear opponent. Thank you so much.
Thank you very much, madam. It was very nice and eye-opening to all. After hearing both the sides, we must say all that the decision depends on individual case only whether to go for trial or not, as we do usually. Now we will shift to the next debate.
Achha, no problem. Sorry. No, it's okay. Time up.
Time? Okay, only 2 minutes.
Madam, you really presented it well. Just for the sake of debate, I think you opposed me. Cragin's mention is really unfortunate, and I am disappointed because it was in 1916 and there itself it belongs in history, because the cesarean section at that time were classical, vertical scar. This is transverse scar we are talking about right now. Can we give that much time to patients? We have to. That is our commitment to patients. If we have busy OPDs, we should take help from people. We should take good people to work with us. Take more housemaids, madam. They will help you. In today's...
I need to take obstetricians.
You,
Senior,
madam,
that too.
with your OPD and practice, you can employ me and people like me. In today's world, when patients and legal system expect unrealistic standards from people like us, it is not okay to be resource limited. We cannot get away with not having basic facilities for NST and basic facilities we have to have. Because of the one adverse outcome, don't seal the fate of thousands of other women. It would be like Amitabh Bachchan, because of his first film was flopped and he will go back again to Allahabad, he would not have become a legend today. I want to tell you that it is the platforms like this where the consensus among doctors is built. So it has to be taken very seriously, debate or no debate. There has to be a clear take-home message from here. And let us not exaggerate the risks and let us not overlook the advantages also. So I think we'll have to take a balanced decision about this.
Thanks, Bakul.
Thank you.
Thanks, I will not argue because short of time. I'll talk to you later. But anyway, the scenario of Indian obstetric practice currently is different, and maybe in future it will change, and then we can give it a thought. Thank you.
I request all the audience to raise the hand who are in favor of VBAC. Thank you. Now please raise the hands who are in favor of elective LSCs. See? Thank you. Now we will move to the next debate. I call upon for the next debate Dr. Sulbha Zamre Madam and Dr. Pratibha Baldava. Dr. Sulbha Zamre Madam worked as lecturer in Dr. VM Medical College. She actually needs no introduction. She is very senior member, worked in Railway Hospital and Chirgupkar Hospital, consultant in Zamre Nursing Home since 35 years, past president OBGY Society, worked in various capacities in arranging various conferences, given lectures in radio and general public. Areas of interest are ultrasonography and high-risk obstetrics. Madam is going to give a lecture on the favor of Serviprime as a use for the induction of labor. Madam, the time is 10 minutes.
Yes, I will not take even 10 minutes because the message is so clear. Therefore, I will not take even 10 minutes to tell me what I am saying is absolutely safe for the patient. That is the first thing. Second thing, I request all our chairperson to listen properly and ask the proper opinion from everybody. The things which are being told for last 3 days, like yesterday we started with the induction by a Fernandez group of the people, and they have given a clear message that whenever they want to induce the patient, the induction reasons will come to, that have given a clear message what they prefer is the preferred by a Serviprime gel. They are using a pacers, but anyway it is a prostaglandin E2 that is they using. Second thing, today's lecture, Dr. Nagpal has told what are things we face with the medical patient having one intrauterine death, one neurological problem, what a whole thing of that career of that obstetrician can be ruined with the one case. And that is the reason we want a very safe drug for induction of the labor, which will have a less of a maternal mortality, less of a fetal morbidity, and therefore I think I am going to talk a lot about Serviprime gel. Not only I am talking just because I want to talk. I am practicing since 1982. I think almost now 30 years I am practicing. The era before the prostaglandin came, the era after the prostaglandin. And these are the prostaglandin which we have helped. I have induced all my patients with the Serviprime gel only. In few cases, I started in between because Cerviprime came first. When it as a prostaglandin, therefore we are very eager. First of all, we are very frightened. Use it because of hyperstimulation, whatever may be the drug. We know the prostaglandins are fantastic drugs. They are very, very useful for induction of labor. But the way which creates the complication, we that also know. When the patient getting hypertonus and patient getting changes in the CTG, what adrenaline surge we get, I think amongst all of you must have experienced this. Therefore, I did started with Cerviprime gel. Then I switch over when misoprostol came in the market. I thought it will be little better. It will have less hypertonus and all that. Therefore, I started. But unfortunately, Pratibha, I have stopped using misoprostol for induction labor at the term, not about a second trimester abortion. I have completely stopped the Cerviprime gel, the misoprostol at the term. We know that the induction of the labor become an integral part of a modern obstetrics. We need, everybody amongst us, we know the very safe agent for this induction of the labor. Almost 95 to 33.7% of our pregnancies, they need induction. Therefore, when so many patients are required, we want a safe drug, which is to be effective, which has to be simple and non-invasive. Everybody knows, everybody amongst us knows, when we are using oxytocin on unripe cervix, when we didn't have any agent, good agent, we used to have catheters, we used to have many other pharmacological agents which we are using. But when the unripe cervix induction used to become either a failure or leading to the instrumental deliveries, having a more maternal mortality, maternal morbidity as well as the fetal morbidity. Therefore, we started using an agent, the prostaglandin, which came in really it is a wonderful drug. They all prostaglandin, even a misoprostol. I do agree, Pratibha, that's a very good drug, but the slides which subsequently come sometimes fears me to use a misoprostol. It's a very true story. Therefore, I feel that I am the person who is for dinoprostol, which is a synthetic analog of prostaglandin E2. You know the way in which it acts more on the unripe cervix. It causes the shortening, the effacement and dilatation of the cervix, which is called cervical ripening, as well as it stimulates the uterine smooth muscles. Now, everybody knows what is the mechanism, how does it act. This is because of, the cervix is made of fibrous connective tissue and surrounding collagenous tissue. It breaks down this collagen tissue and causes a ripening. And I observed the ripening of the cervix become much better when you are using a Cerviprime gel as compared to the Primiprost or misoprostol. Now, very important, how you use it. I think that is the way where we, maybe a Pratibha differing from me for using a misoprostol for induction, that it has to be very properly used. I see in the patient people using diprostol, putting it in this and then just pushing it. It may enter the uterine cavity. Therefore, be very, very proper in using, select the patient. First of all, proper selection of the patient is very important. Use a dinoprostol gel which comes in the pre-filled syringe of 0.5 milligram. It has to be kept in a refrigerator on temperature of 2 to 8 degrees, and it always has to be intracervical. It has been found, if you haven't put an intravaginal Cerviprime gel, it have a more of a hypertonus activity of the Cerviprime if you put. Therefore, the intracervical, be sure that whatever gel you are putting is just below the internal os. If suppose if the cervix is short and some amount of left behind, put it in the vagina, but not go inside the uterus and put it in the lower vaginal segment. After putting a Cerviprime gel, this should be lie down for 10 to 30 minutes in left lateral position. We know the indication, and the indication will be same for both group of the depth. Therefore, I am skipping these slides. Even the contraindications for using a prostaglandin as a gel, a prostaglandin gel for induction of the labor when I have a previous cesarean scar, CPD and grand multipara. Now, the very, very important about a side effect, whenever we are using any drug, because these both drugs are very good, very potent prostaglandins, which are very used, everybody of us are using this drug, but we must know what are the side effects. Side effects which is more common, like going to for the mother as well as the fetus. concerning the nausea, vomiting, diarrhea, more goes with the primipros than the vaginal gel. Vaginal gel, patient hardly experience this. Not even they do not experience much of the temperature difference. Where some patients do, you have to consider it before. And remaining part, that about hypertension for the maternal, uterine rupture, fetal distress, precipitate labor, and other increased PPH, all more, it has in the literature that the problems or the complications in the maternal mother is more with the misoprostol. Now this is a study. This is a study in the Australian-New Zealand Journal of Obstetric Gynecology, May 2001, where they have compared the misoprostol with the dinoprost. In latent phase, induction to active phase, induction delivery interval, cesarean section rate, almost both of the things, they compete each other. They may be little more better in misoprostol group. I do agree with it because they have said the cesarean section 10% or 50%. But the hyperstimulation and the fetal distress, which has been quoted, is more with the misoprostol group rather than the dinoprostol group. Neonatal outcome is same. See, everybody, we are practicing in a private practice, everybody amongst us. So do you allow to have a patient with a hyperstimulus? You are busy in OPD, just like Sadhana told me, it is not possible to go and see in the labor. See, any prostaglandin you use, you have to have an intense follow-up of the intense observation when you are monitoring the labor. CTG has to go. You have to monitor the fetal heart. You have to monitor the patient pulse and BP, everything. Really, in a practice, is it not possible to all time sit beyond the patient? I do agree, we can hire our doctors, but ultimately it is very difficult in private practice to get a houseman, forget about getting an obstetrician. Therefore, it is very difficult. Therefore, I think we should select the drug which will be a safe, which will be effective, which will be better to give a better results also. But doesn't matter, you have little cesarean section rate going up. Active delivery and interval time may be little more, nobody is going to bother for that because they are ready for getting that much of pain and everything. Now this is another study of International Journal of Obstetric Gynecology published by Dr. Wing and Johns. Article on comparison of same concludes saying that vaginal administration of misoprostol is an effective agent for cervical ripening, but it is associated with the higher prevalence of tachysystole and meconium passage compared to dinoprostol. One baby going to the NICU, I know how it disturbs the all economics of patient. They will not pay our bill, forget about it, but it is very difficult for them to face the problem. Therefore, it's better, I think, it's better to choose a drug which is more safe for us. Another study of Department of Obstetric Gynecology, BLD University. This is the research article by Ramaya D. and Jaju. They have seen the 150 patient out of which half of the patient they induced with a 50 microgram misoprostol and another one with a cerviprime gel. They conclude in their article, says the both agents are safe and effective. I do agree. Induction delivery interval was less with meso group, but more side effects. Number of doses required are less as compared with the PGE2. The failure of induction of PGE2 and the fetal distress were more with the misoprostol group. At the end, I conclude that prostaglandin E2 induction, it is effective, it is safe, it is acceptable in women with the unfavorable cervix. It shortens the application delivery interval, decreases the cesarean section rate, it has the less maternal and the neonatal morbidity. And to tell you, in my data, in my hospital, I have induced almost 95% of patients who needed induction with the cerviprime gel, and I'm happy. And I think after listening this, I think Pratibha also will get agree that the misoprostol good it is for a second trimester abortion, but not for the induction of the labor at the term. Thank you.
Thank you, madam. We have heard the side of madam about cerviprime used for the induction. Now we will hear Dr. Pratibha Baldava for the misoprostol used for the induction of labor. Pratibha Baldava, very young and dynamic gynecologist in SS Baldava Hospital, Solapur, treasurer SOGS 17-18, honorary secretary 18-19. 12 national papers in Indian Health Journal, research clinics, international paper on successful fetal outcome of 95 COVID positive pregnant patients in January 22, received first prize for paper presentation at AMOG's annual conference 2015, Pune. finalist at Mahesh Idol 20. Over to you, Pratibha.
There will definitely be some technical problems, but I know how to tackle them. Madam, I congratulate you for delivering that initial lecture very promptly and in a smooth manner. But I would like to tell you that you have dug your grave yourself. Let me elaborate today's topic and make it a little simplified for you. Induction of labor and technique of preparing the cervix using misoprostol. Audience, please look. I have not written induction of labor with misoprostol. I have written preparing of the cervix using misoprostol. Madam, pessimist complains about the wind. The optimist expects it to change. But the realist adjusts the sails. Madam, become a realist. Let us go through the basics and clear the BMR. Oh, you must be wondering what is BMR. BMR is basics mein rada. So let me clear your basics mein rada. What is induction of labor? Induction of labor is actually initiating uterine contractions by either medical or surgical means before the onset of spontaneous labor. So when we are inducing somebody, we are actually trying to prepare the cervix, which is thick and resilient, to become soft and give up or efface, that is thin out, and to start the process of labor. This is with the intention of accomplishing a vaginal delivery. When I counsel a patient that I am going to induce her, I have to tell her that I am doing this so that I will deliver you vaginally. What is the purpose of induction if we fail in completing the procedure? What is Bishop's score? Bishop's scoring system takes into account the dilatation, the position, the effacement of the cervix, the station, and cervical consistency. When the Bishop's score is 8 or more, there are more chances that she will have a spontaneous vaginal delivery, but when the score is less than 6, she is less likely to deliver vaginally. I will also take you through some definitions right in the beginning so that there is no confusion. Madam, you said misoprostol causes tachysystole or causes hyperuterine contractions. But may I know what do you define by hyperuterine contractions? Tachysystole means when the contraction frequency is more than 5 within 10 minutes, or when there are 2 consecutive contractions in a 10-minute period. Uterine hyperstimulation is exaggerated uterine response with late fetal heart rate decelerations or fetal tachycardia greater than 160 beats per minute or some worrisome fetal heart rate changes. Abnormal fetal heart pattern means either fetal tachycardia, fetal bradycardia, late decelerations, or a moderate to severe deceleration of fetal heart rate. What virtually every mother wants. She wants a safe, easy, and mind you, a short vaginal delivery. She doesn't want to be in the labor room for 12 hours. She doesn't want to be undergoing that pain for a very long time. So we better use an agent which will hasten the delivery and be better safe so that we hand over a safe child to the safe mother. Vaginal delivery is indeed one of the greatest gifts to a pregnant woman and to their families. The aim is again a shorter and an easier route, less long-term risk to the mother, and a lower need to cesarean section. So we should not give up that gift lightly. What are the indications for pre-induction? Usually we do it for post-dated patients, PROM, bad obstetric history, IUGR, and hypertension. I introduce to you the one and only misoprostol. It is a bomb in chota packet which will definitely cause a bada dhamaka. So how was this prostaglandin found out? Prostaglandin was accidentally found out when we were doing intrauterine insemination, and this semen had prostaglandins which started causing uterine contractions. So when they found out, we found out PGE2, PGF2 and other prostaglandins. Misoprostol is PGE1, which because of its different component is different from PGE2. The main advantage of misoprostol is that it is available in various doses. Madam, as you said, that misoprostol causes hypercontractions, but let me tell you that misoprostol is now available in doses of 25 microgram as well. Doses of 200 microgram, 600 microgram, and the main advantage of having a 25 microgram tablet is that we can serially induce with low dose of misoprostol over a rate of 4 hours up to 24 hours till uterine contractions start, and this does not cause uterine hypocontractions or it does not affect the fetal heart rate. It is safe, it is inexpensive, but the only drawback sometimes maybe, which is dose dependent. How does it act? It acts by reducing the cyclic AMP. It causes entry of calcium into the calcium channels, and therefore it causes increase in the intracellular calcium levels and causes uterine contractions. Let us go to the pharmacology. It is available in various routes: oral, buccal, sublingual, and vaginal. Let me make it very clear that we are using vaginal route of misoprostol for induction of labor. The dose recommended is only 25 microgram at an interval of 4 hours or 6 hours to ripen the cervix and then to initiate uterine contractions. Even Ferring Pharmaceuticals says that it's a novel drug which is designed for induction of labor and is faster than the vaginal route of dinoprostol. Look at this slide very carefully, my dear friends. The mean time to peak interval is somewhere around 3 to 4 hours, and this goes down, that is, the effect of misoprostol in blood remains for a short time and then it goes away from the plasma. So, we don't have a long-term effect of misoprostol in the blood as compared to dinoprostol gel, which once introduced, we cannot revert back or we cannot take it back out. The mean uterine activity by the 4 routes, as we see, by vaginal route, which is in the blue color, you can see the effect remains only for hardly 60 minutes, that is the peak is around in 1 hour, and then it goes down. Whereas it is not the case with dinoprostol. Once one introduced, the activity of the Sarovar gel will remain for 6 hours. The onset of action with vaginal misoprostol is within 20 minutes and the duration of action is only for 4 hours. This slide again shows that the single oral dose will increase the tonus, whereas repeated oral doses will cause regular uterine contractions. A single vaginal dose will produce regular contractions, increase the tonus more rapid and produce a more pronounced effect. So we prefer a vaginal route of misoprostol rather than oral route. Knowledge without application is like a book that is never read, as correctly said by Christopher Coward. Misoprostol, therefore, as compared to dinoprostol gel, is inexpensive. It has different routes of administration. There are different doses, and, madam, unlike Sarovar gel, it does not require a refrigerator. It is stable at room temperature. It can be kept outside, is easy to store and transport. Thus, I would like to say a safe single dose of vaginal misoprostol is safe, as you also agree that it is safe in up to the 2nd trimester for induction of abortions, for IUFD cases. Similarly, a dose of only 25 microgram is safe for induction of labor at term also. There are risks, I agree, but for every positive value has its price and negative terms. For example, the genius of Einstein also led to Hiroshima. These are the various doses and the dosage schedule in the first, second, third trimester. Also, misoprostol is helpful in postpartum period to prevent PPH. This is again the dosage schedule. The WHO, the NICE, and even the ACOG guidelines recommend prostaglandin, that is misoprostol in a dose of 25 microgram every 4 hourly, or vaginal prostaglandin in the dose of every 6 hourly. For IUFD, I would say misoprostol is the first choice and not Serviprime, because we have to just give it orally to the patient. We need not do repeated PVs, which will increase the risk of infections in a case of IUFD. This is a very important study and a meta-analysis by Sanson, Ramos and colleagues, which significantly said that misoprostol is associated with a significantly lower cesarean section rate. You yourself in your slide said that misoprostol, the time for induction to delivery is only 6 hours, whereas with Serviprime it is 10 hours. And the rate of cesarean section with misoprostol, you said, is only 10%, whereas with Serviprime it is 15%. So you yourself have agreed that misoprostol is definitely better than Serviprime. We have a choice of lowering the dose of misoprostol, but can anyone do that with Serviprime?
Please conclude.
Okay. So there is absence of hyperstimulation if we lower the dose, and we can decrease the interval to delivery. Thank you. Thank you so much.
Thank you. We all know the misoprostol is definitely good up to second trimester termination, but it is a very trending debate that Serviprime and misoprostol, they both have very nicely elaborated. We have to decide according to everybody's clinical application and experience. Yeah.
Dear Pratibha, you took 2 to 3 minutes more than me, because you have to show something to tell that how the misoprostol is better than yes. Of course, you take it 2 minutes more. I finish it in 8 minutes. Yes. Anyway, that is the one thing. I think you forget the debate was not with the root of a misoprostol. We are not bothered whether you give it vaginally, whether you give it orally, whether you give it. The debate was whether misoprostol, Serviprime is better than the misoprostol for induction. Third point which I object, that about ripening of the cervix. See, when you say induction, it includes the ripening. It doesn't mean that you haven't started uterine contraction and deliver. The ripening is the prime necessity or prime importance of the prostaglandin. Forget about meso or any prostaglandins are a better ripening agent, and therefore that even the misoprostol, I didn't much insist because both of them doing the same work. Why to say? I only want to convey my message, Pratibha, that this is more safe, more effective, and in a private practice, I think we are the person, we are the people, don't mind having 3 hours more for a delivery, having a 2% section. Now we heard elective section from Sadhna, why it is important. Then why to bother about 2% more cesarean section, but have a safe and effective delivery. Thank you very much, Pratibha.
Thank you, madam. Now I again request audience to raise the hand about Serviprime, in favor of Serviprime. All the hands are up. Now in favor of Pratibha, misoprostol. Okay. Thank you. Thank you, organizers.
I request our chairpersons to please felicitate our speakers, Dr. Bakul Jagirdar ma'am, Dr. Sadhna Deshmukh madam, Dr. Sulba Zamre madam, and Dr. Pratibha Baldava ma'am. Dr. Bakul Jagirdar ma'am and Dr. Sadhna Deshmukh ma'am. Dr. Sulba Samre Madam and Dr. Pratibha Baldava Ma'am. I request our President Ma'am to please felicitate our chairpersons, Dr. Vidya Karvekar Madam and Dr. Gunzotikar Madam. Thank you, Jama Ma'am. Now we move on to our fourth session. I request our chairpersons to please come on the dais. Dr. Vaishali Datal Madam. She is a president of Latur OBGY Society, practicing gynecologist since last 20 years, director of Sarthak Hospital, a past treasurer and secretary of LOGS, conducted numerous tubectomy camps at PHCs, and various educational workshops, special interest in infertility and high-risk pregnancies. I welcome you, Madam. Dr. Vandana Gandhi, Madam. She is a consultant OBGYN sonologist, endoscopic surgeon, founder of Female Fetus Protection and Save Girls Counseling Center, Aklus, founder of AOGS 2013, President AOGS 2018-19, member of Contraception and Family Planning Committee of AMOX in 2018-20. I welcome you, Madam. And Dr. Supriya Zadhav. She is an obstetrician and gynecologist at Sanjeevani Nursing Home and clinical secretary of SOGS. Welcome you, Supriya Zadhav, Madam.
Hello. Good afternoon, everyone. First of all, thank you, Dr. Anjali Jama ma'am, Dr. Monica Umbardhan madam, and Dr. Pratibha Baldava ma'am for giving me the opportunity to chair the session. Now, after a debate, it is very important to move further, and today's topic of discussion is placenta accreta spectrum disorders, diagnosis and management. I take the honor of inviting Dr. Manik Guram sir. He was past president IMS Solapur and past president Solapur OBGY Society and got Best Society Award. He is a director at Shri Markandeya Solapur Sahakari Rugnalay, 300 bedded hospital. He is chairman at Markandeya Medical Trust and Boli Blood Bank. To his credit, he is zonal coordinator at AMOX 2017 and 2022 and got Best Zonal Coordinator Award. He is practicing at Ankur Guram Nursing Home at Solapur. His special interest is in laparoscopy and NDBH by bipolar. Now I request Dr. Manik Guram sir to move further.
Good afternoon, everybody. Since morning we are listening about the cesarean section rates, VBAC, but the important thing, I think this is the ultimate salam to motherhood. पुढचं तिकडे चेंज कर तू चेंज कर बरं मी करतो मैं करता हूँ या प्लासेंटा एक्रेटा स्पेक्ट्रम डिसऑर्डर डायग्नोसिस एंड मैनेजमेंट. Yes, these are the cases which we might have come across in many years, and these are very dreadful. And these cases are unforgettable. You can recall the scenario you faced at any time. In last 25 days, I came across 3 cases of placenta accreta. I will cover this topic in 3 aspects. First, can we predict? Second, how to manage? And last is how to prevent. I will advise a vaccination at the end to prevention of this placenta accreta. It is an abnormal attachment of placenta villi directly to the myometrium due to an absence of deciduum basalis and an incomplete development of fibrinoid layer. Placenta accreta, no deciduum, increta, penetration of the villi into myometrium, and percreta, penetration up to the serosa layer. You all are aware of these types, placenta accreta, increta, percreta. But the worst prognosis is when the percreta is anteriorly and it encourages the bladder, there is a bladder invasion. And that is something which must find out for dealing it methodically. The trophoblast invading the myometrium is a basic pathology. Primary deficient devascularization seen in cases of placenta previa, excessive curettage, radiation and chemotherapy in patient. Over-invasion of trophoblast, and this is the evident by some markers. They are strongly positive epidermal growth factors receptors, reduced vascular endothelial growth factor 2 receptors, radial and arcuate arteries show loss of muscular and elastic, strong positive reduced vascular endothelial growth factor factor 2 type radial and arcuate arteries show loss of muscular and elastic tissue, making them unresponsive to vasospasm and leading to torrential hemorrhage. Yeah, you can see in this picture, when it is on this side there is a normal placenta and there is a accreta, there is completely invasion. So, this is a disease of 20th century. There is a tenfold increase in last 50 years. The incidence is increasing steadily in this century due to increase in the incidence of LSCS, increase in the maternal age. But both these are independent risk factors. Along with that, there are other factors responsible are increase in uterine surgeries like myomectomy, anomaly corrective surgeries, in vitro fertilization, endometrial thermal ablation, chemotherapy and radiotherapy. Forewarned about accreta is what we needed to deal with these cases. We can't prevent, but forewarned about accreta is needed. And prenatal diagnosis with imaging modalities necessary for good outcome. Antepartum diagnosis is of paramount importance. The multiple studies demonstrate improved maternal outcome with antepartum versus intrapartum diagnosis. When we diagnosed it early, then there is a decrease in hemorrhage and overall decrease in maternal morbidity. But exclusion of diagnosis is equally important. It prevents iatrogenic prematurity, reduce invasive maternal procedures and appropriate allocation of resources adherent to placenta. Ultrasound is a gold standard diagnosis. Standardized scoring is now available as placenta accreta index. The imaging modalities which help to make diagnosis are routine grayscale, which will predict 51%. Color Doppler alone will predict 47%. 3D power Doppler that will predict 76%. So we combine all these, the diagnosis is almost certain by ultrasonography. Ultrasound findings predicting morbid adhesions are loss of hypoechoic retroplacental myometrial zone, thinning of myometrium, disruption of serosa bladder interface, and increased vascularity at uterine bladder interface and increased intraplacental vascular lacunae. You can see here these are the lacunae and thinning of myometrium. Yes. What are lacunae? Lacunae are irregular shaped sonolucent spaces in placental are lacunae. This gives a Swiss cheese pattern appearance. The vascular spaces in placenta are graded, and greater the grade, more chances of adherent placenta. So what are these grades? Grade 0 placenta, no lacunae. I am talking about the grades of lacunae. Grade 0, no lacunae. When you will see 1 to 3 lacunae, that is grade 1. When you see 4 to 6 lacunae, that is grade 2, and more than 6, grade 3. And irregular lacunae, 100% sensitive in predicting abnormal vasculature of color Doppler ultrasonography. The sensitivity of 87% with grade 1 lacunae, while sensitivity of prediction of placenta accreta is 100% with grade 3 lacunae. So look for grade 3 lacunae. So on Doppler examination, you will see this turbulent flow. Increase the vascularity in interface between placenta or bladder are suggestive of placenta accreta. Sonographic findings, morbidity around placenta in first trimester. Only women with prior cesarean delivery were included in this study. The transabdominal and transvaginal images from these first trimester studies were reviewed for following factors. And what are those factors? Those are distance from inferior border of the gestational tract to the external cervical os, location of the deciduum basalis, presence of anechoic areas, uterine bladder interface irregularity, and smallest anterior myometrial thickness. The morbidly adherent placentation was confirmed on histological examination of hysterectomy specimen afterwards. And then these two are correlated, and you can see the results. The sonographic finding here, the schematic illustration of sagittal transverse image. You can see this is the sagittal transverse image. Here it is 10 millimeter. So chances of myometric image is less, but here it is 2.3 millimeter. So here there is a chances of placenta accreta. At the same time, from this gestational sac to the external cervical os, if the length is less, then there are chances of placenta accreta and scar ectopic. So here I quote all the ultrasound findings which can predict morbid adhesions of placenta. In first trimester, gestational sac located in the lower segment, presence of caesarean ectopic. In second trimester, multiple vascular lacunae with grade 2 or grade 3, and in third trimester, Swiss cheese pattern, loss of hypoechoic retroplacental zone, turbulent blood flow, and extension toward bladder, bulging of placenta into bladder almost confirms the diagnosis of placenta accreta. So here you can see all the ultrasound finding which I just narrated. Here you can see the bridging vessels, then loss of retroperitoneal space, turbulent flow, irregularity of uterine bladder interface, and these are the lacunae. So these ultrasound findings to be kept in mind. Yes, this is the on 3D ultrasonography how it will look. So here comes the most important factor, that is the placenta accreta index. This is a scoring system to predict the placenta accreta where following parameters are considered. 1. Number of caesarean section. 2. Grades of lacunae. 3. Sagittal smallest myometrial thickness. Then 4. Either the placenta is anterior or posterior. So there is a point given to anterior placenta. And 5th is the bridging vessels. And this is the placenta accreta index calculation. 2 caesarean section, the score is 3. In lacunae, if grade 3, 3.5. Grade 2, 1. Then sagittal smallest myometrial thickness, less than 1 millimeter, 1. Less than, more than 3, but less than 5 millimeter, 0.25. Anterior placenta previa, 1. Bridging vessels, 0.5. And then, you can see here, if all, with considering all these parameters, if the placenta accreta index is less than 0, the probability of invasion is only 5%. The sensitivity is 100%. But as the score increasing, if more than 8, then the probability of invasion is 96%, sensitivity is 17%, specificity is 100%. So always whenever a placenta previous cesarean section patient comes to you, while doing ultrasonography, look for this placenta accreta index. Then what is the role of MRI? Yes, it's an additional diagnostic information in equivocal cases, and that too in a posterior placenta MRI is having role. The sensitivity is 78 to 93% and specificity is 77 to 100%. But the drawbacks here require radiologist expertise in placental imaging. At later gestation age 28 to 32 weeks posterior placenta it is possible, and maternal discomfort and cost. And the most important thing, whenever we send the patient to MRI, now comes there is a role of PCP and DT. If that MRI, they are not ready to do ultrasonography of a gravid uterus. MRI of the gravid uterus. So now after prediction, we go to management. The management goals are, the management goals are antepartum diagnosis before 30 weeks, balance risk of prematurity while avoiding need for emergency delivery due to labor or bleeding, proper arrangements of blood and blood products, team placenta accreta, intact referral and intervention radiology. These are the management goals. Considerations for the uterine conservation. No clear consensus or best practice often considered. There are various things: uterotonics, prophylactic uterine artery embolization, antibiotic therapy, methotrexate administration, inpatient versus outpatient, serial lab assessment, interval to hysterectomy, but appropriate for focal or limited disease, where a curettage or wedge resection, desired future fertility, at least a 20% recurrence and in a extreme prakrita and unresectable disease. So conservative management is not possible. So leave the placenta alone. Many times it is said, can you leave the placenta alone and give methotrexate? Absolute no. The ICU admission after 24 hours, there are more chances, massive transfusion, coagulopathy, ureteral injury and early reoperative. Yes, methotrexate, no. Maternal morbidity with conservative management. These are the various studies, and you can see here 60% delayed hysterectomy and 40% emergency hysterectomy. That's why conservative management should not be done. Then comes the vessel occlusion. So this is we needed. The goal is decrease the uterine perfusion accomplished with balloon occlusion or embolization of uterine or internal iliac artery. Controversial is critics cite collateral uterine blood flow and risk of complication, arterial rupture and pseudoaneurysm formation after this. But still that is possible. The most important thing is the triple P procedure in placenta accreta. This is a 3-step conservative treatment involving obstetricians, anesthetists, intervention radiologists to prevent the significant hemorrhage and peripartum hysterectomy. The 3 steps are perioperative location of the placenta and deliver with the fetus by an incision above the upper border of placenta. Pelvic devascularization by inflating radiologically pre-placed occlusion balloons in both internal iliac arteries. Here you can also do internal iliac ligation, or with a vascular clamp you can apply at both sides. The placental non-separation with myometrial excision and reconstruction of the uterine wall. So here there is actually internal iliac balloon, how it is done, but this requires a cath lab. There is a video, but I will skip that video. And that requires a cardiologist or intervention radiologist. So last 4 slides, management. The patient to be informed about the severity of diagnosis and requirement of the blood. The warning signs of immediate hospital evaluation prior to scheduled delivery. The most important thing is this leapfrog technique, that is for autologous blood transfusion. So patient can give blood. Yes, patient can give 8 weeks back, then that should be given after 4 weeks. Then at 6 weeks take one blood, that to be given after 2 weeks. but at the same time remove two bloods. So at the end you will get autologous 4 blood. So in placenta accreta, this is the best way to give the autologous blood for that patient. Unexpected intraoperative diagnosis at laparotomy. You don't know about the placenta accreta, and at laparotomy there comes the unexpected placenta accreta. Distorted and distended lower uterine segment, blood vessels visible, no bleeding, stable mother and fetus, no facility available with you, stop. Cover uterus with warm packs, ask for assistant, blood product, and then proceed for hysterectomy or intervention. If the facility is not available, or a urologist or surgeon is not available, close the facial incision, skin close with few stitch, and transfer to the placenta caring center, accreta management center with expertise. Active bleeding, patient is unstable. At that time, it is not possible to send the patient to the other center. Then apply local pressure to the bleeding areas. If required, suture vessels on both sides and prepare for hysterectomy and delivery, followed by definitive management of placenta accreta. But always ask help from surgeon or urosurgeon. So the take home message.
Sir, last 1 minute.
Yeah, thank you. Take home message. Clinical history is important, PIS scoring system is important, multidisciplinary care, urosurgeon, oncosurgeon, ICU for mother and fetus, leave placenta alone, avoid methotrexate therapy. These slides, it completes, all my talk is completed in this slide. And last but not the least, is there any prevention method to avoid the placental morbid adhesions? Yes. There is a trial vaccine for primary, and that is known as Trivac, where it is available. This trial vaccine for primary is nothing but judicious and optious use of incision on primary uterus. This can act like a vaccine and prevent future morbid adherent placenta. The caesarean birth is an unusual method of natural birth that should be last but not the first choice. Go for green to save the earth. Just now, we heard from our teacher and mother of obstetrics, in no-risk primary, don't admit early. She should come at 3-2 centimeter, 4 centimeter, 5 centimeter. This will definitely decrease the LSCS in primaries. Hence, I say go for natural birth to prevent the further. WHO also tells with non-clinical interventions to reduce unnecessarily cesarean section. Try them to adopt. Thanks organizer for giving me opportunity. If you really want to say Ma Tujhe Salam, always think of, before putting a knife on the primary patient, think whether this is really needed. Thank you very much.
Thank you, sir. Sir, one question, sir. What is the treatment protocol in placenta percreta when placenta is eroded over bladder?
When it is eroded in the bladder,
yes,
definitely at that time, whatever I told, triple P procedure, where you have to take the incision, the level above the, till the placenta is there, up to that period, up to that section, don't take the incision. First deliver the baby, keep that cord should be clamped or with a barber it should be closed, keep it inside. Then here comes the role of urologist, because the urologist, now he will put the ureteric stent on both sides and then he will try to release that bladder from that uterus, and if accidentally if there is any injury, that should be taken care of. And when the bladder is completely taken away, and then you go for hysterectomy. But in this case, if you keep with a cath lab, if you keep uterine balloons, definitely the blood loss can be avoided.
Okay.
So this is the treatment for
and
placenta
where to
accreta,
take
which
the
is invading
incision?
The bladder.
Where to take the incision on uterus?
You can take the just classical incision above.
Okay.
That is the best way. In fact, I have said 3 cases I have done. In all 3, in 2 cases, I have taken the classical incision.
Okay, sir.
I removed by breech and then obstetric hysterectomy also.
Okay. Thank you, sir. 1 minute.
One more question, Manik. Just as a curiosity, have you ever witnessed a case of placenta previa which is posterior with posterior adhesions? Not always we get bladder adhesions. Means accreta or percreta through posterior part.
I have not come across the posterior placenta accreta, but the percentage is almost negligible for posterior placenta accreta. It is seen in most of the time due to scar, it is placenta. In that cases, MRI is needed. Posterior placenta. In that case, the diagnosis is confirmed by MRI. Yeah, previously it is said that placenta
not previously. What I am trying to say is that since Solapur is getting so many placenta accreta cases nowadays, why not to try and leave the placenta just like that? What will happen?
Yeah. If you keep the placenta inside, you have to give methotrexate, right? Or not?
You can wait for natural disintegration of the placenta.
So chances
methotrexate,
of, yeah, no problem.
You quoted that methotrexate was not found to be useful, so agreed.
If you have kept the placenta inside and closed the uterus above, the chances of hysterectomy, patient needed ICU admissions, infection are more. And nowadays, in a triple P procedure or placenta accreta index, who are doing the placenta accreta cases, the recommendation is don't keep placenta inside. That should be removed along with the uterus. Along with the uterus. Even if it is a primi and if it is a placenta accreta percreta invading the bladder, remove along with the uterus. That will definitely decrease the morbidity and mortality of the mother.
Thank you, Dr. Guram, sir.
Avoid cesarean section in a primi.
Thank you, Dr. Guram, sir, for all minute but clear details, which I am sure will be a great help to all the gynecologists here today. Thank you.
Now we move on to the most interesting part of this special session on cesarean section. We know it is the most commonly performed OBGY surgery, and nowadays it is a topic of hot concern because of the rising rates. We are concerned with this journey of human birth. With co-passengers, we are 3 mother, unborn fetus as well as placenta. You will all agree that our aim is and the dream is to see a smiling mother and a crying baby in her lap. So our adrenaline surge will be lesser if we are technically sound and expert and confident. To discuss about this technological aspect of a popular surgery like cesarean section, today we have an iconic figure from Indian gynecologist, Dr. Mandakini Meg Madam. I am really happy to introduce her, who is joining us online because of technical failure of travel. She couldn't come, so we are inviting Dr. Mandakini Meg online. To introduce her in brief, she is a chairperson of ICOG FOXY. She is International Vice President of Medical Women's International Association Central Asia. She is Vice President of Medical Association of Women of India Central Council. She is National Vice President of FOXY. She has been National Vice President of FOXY in 2013. She has been past President of Indian Federation of Ultrasound in Medicine and Biology. She has been past Dean of Indian College of Medical Ultrasound and Chairperson of Imaging Science Committee FOXY. She is Executive Member of Mumbai OBGY last 25 years. She is member of FIGO Committee on Infections During Pregnancy. Is she joined? Okay. We welcome you, Mandakini Meg Madam. And now the dais is yours.
Yeah. So good afternoon, everyone. And speaking from Chennai, from the TNFO All Tamil Nadu Conference, and respected chairperson and all the organizing committee of such a wonderful conference. It was my dream to come to Solapur. But from Bhagalpur, 12-hour journey to Patna to Kolkata, and middle of the night I landed up at the Chennai. So thank you very much for the patience and making, me a part of this wonderful Solapur OBGY, which is my home society. Next. 1 minute. Not going. 1 minute. So, as the chairperson has mentioned very correctly, that cesarean delivery is the very hot topic. It is hot topic from the beginning because we are saving mothers, we are saving babies to the best of our clinical knowledge. But now, because of the interference, because of the government policies, it has become much more hot topic because there is a rising rate of cesarean section. So now today I am going to talk on the cesarean sections and the long term outcome. Also I am going to talk a little bit on the cesarean section, what is the government update and what we are supposed to do in these circumstances. So cesarean section delivery is the most commonly performed major operation. We are all aware, and also it is around millions of neonates born worldwide in 2015. Approximately 1.1 million cesarean sections were performed in the USA, and also the two previous systematic reviews summarize that the meta-analysis that the around 1960 to 2012 a specific technical aspect of cesarean section using identical search criteria. We have located an additional 216 papers. And what does they say? That, that institutions seeking efficiency in healthcare delivery for resident trainee learning this important surgery, researcher who study an aspect of the surgery difference should offer and based standardized cesarean delivery informed in 370 places. So why we have to standardize the cesarean delivery? I think everybody has got all the obstetricians who are listening here. They got their standard method. Everybody does with a proper surgical technique. But in the emergency, we try to do as my previous speaker has mentioned how he has delivered. So many times you have to take decisions delivering by breach and so on. So we have to standardize the cesarean delivery surgical technique. So it is a absolute vaginal atresia, advanced carcinoma of cervix, cervical, broad ligament fibroids, severe degree of contracted pelvis. There are other these things also, cephalopelvic disproportion, previous uterine scar, fetal distress. All these indications I am not going to enumerate because we all know, we are all expert, and fetal indications are definitely the indications for the cesarean sections. So lower segment cesarean section, the lower segment of the uterus is less muscular and the upper segment of the uterus, and that is why the transverse incision is made in the lower segment, and this is very fast successfully than incision in the upper segment. There is a less muscle and more fiber. So we take this financial incision, no doubt about it, but so many times somebody asks me, suppose it is impacted, suppose there is no liquor, in that case we tend to extend or give a little T-shape so that the baby delivery becomes easy. Then what is classical cesarean section? There was a time, say 30-40 years back, when there was a time when there were anesthesia facilities were not there. We have to deliver the patient in emergency. There was a super fast cesarean section. So that time, so many times, even I have performed so many classical cesarean section in order to save the mother and also fetus. So in this, fetus is extracted through the incision made in the segment and is rarely performed nowadays. An operation is done only in certain circumstances, such as the, nowadays the cervical carcinoma, big fibroid, the obstruction in the lower segment, difficulty. So in that rare circumstances, nowadays we perform. And we have seen the long-term sequelae of such patient where the rupture uterus was invariably there in olden days when the cesarean section was performed by the classical cesarean sections. So here you can see the incision here, that we are giving the vertical incision in the uterus. And also these are the other this financial incision. Then we have this George Collins incision, Maillard's incision, and medical midline incision is there. So now the financial incision is a transverse incision. I think I should not tell the August audience here, but the extension in the both the directions. There are studies that we should do the blunt dissection. Once you give, there should be little blunt dissection by the fingers, because there is a tendency to go a little further and go up to the uterine in case if you don't do it properly. Then this Joe-Cohen's incision is a skin incision used for the cesarean section, in which a 3 centimeter below the line of joining both interior superior iliac spine and superior to the financial incision. Another commonly used incision in the obstetric surgery. And Maillard incision is a surgical incision in which a transverse cut is given in the rectus abdomen sheath to allow the wider space. There are places when there is any fibroid, any other macrosomia, or any, so wider access to the pelvic cavity. Incision is made 5 to 8 centimeter above the symphysis pubis. Abdomen is opened and the loose folds of the peritoneum are covered, and the operator continues to incise the further fundus of the bladder, which is then pushed down, and the surgeon dissects the fetal head. So these are the types of the low transverse, then low vertical, classical, inverted. All these incisions are given. The standardized approach to clinical practice consists of the associated with the improved outcomes. The outpatient setting, protocols, checklist, reduce the patient harm through the increased standardization. The science of this utilization surgery remains infancy, but may be particularly beneficial. Then oxytocin may be given by the anesthetist after delivery of the baby, and clamping the cord after delivery of the fetus, placenta, peritoneum, then be closed. So this is a standard procedure. Double layer closure, there are papers and papers of written how to ideally to close the this double layer or single layer. So many times in emergency they tend to close it a single layer, the first layer of the suture, and also the simple running suture or a running lock. The suture is more hemostatic. Second layer in this overlaying should hide the first layer beneath it, which is closed. Closure, this, the rectus sheath is closed and the layers of fat. Finally, the skin is sutured with the surgeon's choice of material, commonly vicryl or braided polyglatin used. And skin can be sutured with simple suture or matrix suture or subcular. So this is a myometrium, second layer, first layer, and the decidual layer. Now, a step forward in operating techniques in obstetric. Stark and colleague implemented this new technique, cesarean, at the General Hospital in the Jerusalem, and this already strong evidence that standardization aspects of the cesarean surgery is associated with a less surgical site infection. So, a systematic review of meta-analysis found similar surgical sites reduction in the post-operative antibiotic prophylaxis. So, these are the few papers here. Now, when a skin, subcutaneous tissue, fascia, peritoneum, and studies have reported that approaches the abdominal were associated with the specific procedures. Since 2013, there have been 6 additional or Cochrane review on which this technique primary outcome, including the operative time, analgesia requirement, febrile morbidity, and the techniques that incorporated sharp dissection, very important, sharp dissection, tissue expansion, entry were favored, and as per this Cochrane review. Bladder flap development method, that previously bladder flap development was recommended with a moderate level of certainty, and now the omission of bladder flap significantly reduces the operative time as well as the short term. So nowadays, the bladder symptoms with no difference in the intraoperative bladder injury. Uterine incision expansion already talked about. Placental removal, I think, except the placenta accreta and other, such adherent placenta, we have a standard technique of removal of the placenta, intrauterine wiping, routine cervical dilatation, and uterine repair in situ. Sometimes we are supposed to take the uterus outside when sometimes, we tend to take the uterus outside and then suture it in certain conditions similar to the prior studies. And also in the most recent systemic review, that extraperitoneization appeared. Now, this is 1 minute because these are the slides. Subcute factors for the safety. Factors responsible are increased safety of operation, improved anesthesia, availability of blood transfusion, increased awareness of fetal well-being, and identification factors have caused reduction in difficult operation and manipulative vaginal deliveries. Oxytocin may be given by, this is, I'm sorry, this is being repeated by, the wrong thing. Presentation is given here. 1 minute, please just bear with me. Now come to the post-operative care. Immediate recovery with the blood pressure recorded every 2 hours. Wound must be inspected. Trachea and general anesthesia. Women is nursed literally and recovery position. And also IV fluids and all this. I think I should not tell this August audience. Complications, we are aware that postpartum hemorrhage, shock related to the blood loss, anesthetic hazard, sepsis, secondary PPH, thrombo, and lead complications may be seen here. And uterine dehiscence involve the myometrial separation at the site of uterine scar from previous surgery and uterine cirrhosis. Most importantly, what can be followed by the cesarean section may be ectopic pregnancy or cesarean scar pregnancy, which can be dealt, at length. And we have to be very aware of this important complication after cesarean. Also, the early placenta accreta pathologically also, is a complication. Also, the placenta previa. So next, pregnancy and scar dehiscence. Here I will definitely like to mention about the scar rupture, silent scar rupture, which in many cases I have seen, and then repaired because there is a silent rupture, just the amniotic fluid and everything is coming out, and slowly baby is coming out. Sometimes baby is already inside. Then the scar rupture is there and total uterine rupture is there. In that case, I think I have previous lecture, I already mentioned there was a not only rupture of the uterus, but rupture of the dome of the bladder was also there. So we can have this kind of serious sequelae to the lot of morbidity and sometimes the mortality. Then we have cesarean scar ectopic pregnancy after these complications, and also the cesarean scar ectopic pregnancy seen here, electroscopic image revealing the cesarean section scar ectopic pregnancy. Also, in the long-term sequelae, if you see the non-pregnant abdominal uterine bleeding due to presence of congested and fold polyps in the scar recession, uterine scar may cause. And today I had a wonderful lecture. This scar endometriosis is also very important. Ramni Devi was talking about, and how to deal with this endometriosis after the scar. This thing is also very, very important. It leads to the chronic pelvic pain, then dull sensation, dyspareunia, and so many other long-term sequelae are there. Dysmenorrhea, unexplained infertility, endometriosis, adhesions of the intestines, bladder, etc. And sometimes it may be frozen pelvis also in some cases. A potentially high risk of complication may and difficult gynecological procedures such as uterine evacuation. Now, the last part of my talk is maintaining the lower, apart from our regular this thing, how to maintain the low cesarean rate and how challenging it is for us. So WHO has advocated the rate not more than 15%, but today we had the discussion here also that almost, Dr. Kurian was talking, almost in their private facility, they are having 45%, cesarean section rate, but it is advocated that our juniors and other people should be skilled to perform some, suction, this thing, vacuum, and also the low forceps, so that at least 15 to 20% of the cesarean rate may be come down by improving the skills of the junior, as well as also giving them the confidence and assisting them is the only solution for lowering the cesarean section rate. American College of Obstetrician and Gynecology established 15.5. WHO proposes a Robson classification. I think this has been discussed at length in the FOXY and at every places, and government of Maharashtra, especially Solapur people, we are from Maharashtra, you have that circular in which Dr. Archana Patil was additional director. She has given that why we are having so much, and everybody should report to that, that circular. I think you all know, by assessing and monitoring, comparing the cesarean section within the health facility over a time. So proportion of CS at the population level is a measure of access to the and to use of intervention. It serves as a guidelines for the policymakers and government. So these are the few of the highlights. And cesarean section is not without the risk both to the mother and infant and considered low when the medical indication is concerned. Also, what is the challenge for us that we should do for the proper indication? And there is a paradox. Suppose we don't do, then also we face the court cases. If we do, then that time they say that you are doing excessive cesarean section. Also, doctor's perspective also change, patient's perspective. And
Madam,
we are
sorry to
scared of-
interrupt. There is only 1 minute for the session.
Yes, it has finished, almost finished. It was little almost finished. Thank you. And this cesarean sections rate has to be, so there should be, doctor's perspective, decline in the operative delivery. These are the main determinants of increasing the cesarean section. So thank you very much, friends. These are a lot of studies, and take home messages will be every effort should be made to provide cesarean section to women in need, rather than striving to achieve a specific rate. It is your prime duty to take the decision in the best interest of the patient and the child, and maintain the cesarean section rate low by optimizing, doing the this is changing the strategy at the national level, institutional level, and the proper counseling. So thank you very much for the patient listening. And also I request all our participants in the organizer to please support me and vote for me as a FOXY president. I'm your own candidate from Maharashtra, and please help me with the this election and support. Thank you very much. And sorry
Thank
to
you, madam.
sorry for overshooting the time. बंद करो.
Thank you, madam. Thank you very much for this elaborative talk on the technological aspect. We are missing you here, but please accept our e-greetings, e-felicitation
question is there, then
from
I can
Solapur
answer
OBGY
straight away.
Society. Any questions from audience? Please accept this token of felicitation.
Thank you very much.
Thank you, madam.
Please go ahead with your program.
I request our chairperson to please felicitate Dr. Manik Guram, sir. Sir, please come on stage.
I request Jama ma'am, please felicitate our chairpersons.
One minute, I want to pay my this thing to Dr. Jamma, Dr. Monica, Dr. Gurram, and all the senior and all my chairperson for doing such a wonderful conference, and really missing you. Thank you very much, Anjali and Monica, for this wonderful conference. Thank you.
Let's move toward the next session. I request Dr. Manik Guram sir and Dr. Archana Shah ma'am to chair the session. Manik Guram sir does not need any introduction. He is the Manik and gem of our society. Dr. Archana Shah, she is renowned gynecologist and obstetrician of our town. Welcome you, ma'am.
Now we are moving to the keynote session. The topic of the session is HDU setup for high-risk pregnancy. To deliver the talk on this topic, I call Dr. Prakash Mehta on the dais. Dr. Mehta is a Chief Division of Maternal Fetal Medicine and Head of Department of OBGY, Bhagwan Mahavir Jain Hospital, Bangalore. Is a postgraduate and post-PG fellowship teacher and examiner in maternal fetal medicine and OBGY, obstetric and gynecology. He has numerous articles in various journals. He has contributed to chapters on maternal fetal medicine in many books. He has delivered oration in field of maternal fetal medicine at various places. He is president of Society for Maternal Fetal Medicine, and he is organizing chairperson ISSHP 2023 International Conference. He was past president Bangalore Society of OBGYN, past joint secretary of FOXY, and he is a coordinator for FOXY UNICEF protocols in obstetrics and Laksh mentorship. Over to you, sir.
It's indeed a pleasure to be in Solapur. I've got quite a few old friends here, and I'm interacting with them, I think, after quite some time, thanks to COVID maybe. Now, before I begin my talk, if I may be indulged for a moment, I would take this opportunity to welcome you all to attend the International Society for Study of Hypertension in Pregnancy, the ISSHP World Congress in September 2023 in Bengaluru. We are having the conference from 24 to 27, and who's who in the world in the field of hypertension will be present in that conference, so please be there. Now, before I go further, how many of you are used to a HDU? How many of the hospitals here? Okay, we have a few here and there. Great. I think another few years and we will not be able to practice obstetrics without an HDU. That is what is going to happen. Few years back, no, maybe about 10 years back, with Alpesh Gandhi and me, we were in a meeting with many vice chancellors of the universities across India, and we were trying to bring in the concept of HDU. And they said, no, mothers are dying because of lack of iron. What are you talking about high-tech HDUs? But I think we have definitely moved on from them, and now the government of India has come out with a recommendation that most of the government hospitals will not only have obstetric HDU, but they are going to also have an obstetric ICU. Now, I'm just going to give you a little bit of difference as we move along as to what is the difference between obstetrics HDU and an obstetric ICU. So we know that our goal is always a healthy mother and healthy baby. Now, what happens in obstetrics is that when you hear hoof beats, like supposing outside on this road you hear the hoof beats, obviously it's going to be a horse. That is what we presume. But once in a way, it might be a zebra. So this is exactly what happens in the obstetrics when you least expect a problem to come in, that the problem really comes in. Now, majority of the women during their pregnancy, labor, postnatal period require care that can be met through routine obstetric care. It's only a few, but a very significant number of women who will require a critical care. Now, this critical care may be related to pregnancy itself, maybe aggravation of a pre-existing illness in the mother, or it could be a complication of the delivery. Now, when we resuscitate a mother, a pregnant lady, we need to remember that we are resuscitating two patients, both the mother and the fetus. Hence, our task is much more difficult as compared to in a routine ICU. But the good point about our obstetric patients is they are generally young and healthy and recover rapidly. Just the previous evening, I would have told the relatives that your patient may not survive. And next day morning, the patient is sitting and having a breakfast. So that is the kind of dramatic recovery we get, and which is, of course, very fulfilling when we treat these young patients. Now, the basic principles in high-risk obstetric care, which we are going to follow in a high-dependency unit also, would be prevention, early recognition, and prompt aggressive intervention. Unfortunately, we are lacking in all the three because there are no clear-cut signs and symptoms. There's nothing, nothing is written on that patient's forehead that I'm going to give you trouble. She's going to just come in as a routine patient to you and then she has problems. Now, we also know that the pregnancy affects every system, and a thorough knowledge of the physiology of the mother and the fetus is very important to resuscitate these patients. And who has got the best knowledge of the mother and the fetus? The obstetrician. So we should be the ones who are looking after the sick patients. So where do you need a HDU to come in? Many things, like you have an accidental hemorrhage, you have the covalent uterus, preeclampsia, DIC, there is massive hemolysis occurring, or there could be adherent placenta, or a placenta accreta could be there. You may have a placenta succenturata. Occasionally, you have a ruptured ectopic with the patient going into shock, whom you have to shift to a HDU. Or you could have sepsis with a lot of additions and you're operating on her post-operative, she will require HDU. Burns during pregnancy. In Bengaluru, it has become a little less common. I do not know over here, how are your incidences of burns during pregnancy? It has come down? Okay. Or there could be a ruptured uterus or septic abortion. Even septic abortions have come down drastically, but still they do come with a regular frequency. So there could be bacterial colonization anywhere, or you are doing an obstetric hysterectomy, the patient needs much more care, or there could be uterine anomalies which could cause PPH or any other complication, and you need to put them in HDU. Or you could have associated medical disorders like jaundice in pregnancy, or you can have cardiac diseases like a mitral stenosis with atrial fibrillation that comes quite commonly during pregnancy. Or there could be an adult polycystic kidney disease which can result in an hypertension during pregnancy. You could also have fetal complications like hydramnios or the fetal anomaly, especially the cardiac anomalies. There could be an IUD, a long-standing IUD, we all know could result in a lot of complications, or a preterm baby. So basically, when we talk of admissions into an HDU, these are roughly the percentages that you are likely to have, and you could see that the hypertensive disorders takes the cake, 28% of all admissions. As a matter of fact, in my HDU, I would say 75 to 80% of all admissions are due to preeclampsia, because I get referrals of preeclampsia from all over South. So that is why I have a more number, but roughly on an average you'll have about 28%, and the postpartum hemorrhage, whom we have been talking about a lot, but fortunately it is coming down. So our next goal should be to tackle the hypertensive disorders and bring that incidence down. Then our maternal mortality would definitely come down. So what is the concept of HDU? A critically ill obstetric patient usually recovers rapidly with fewer specific interventions and a good overall prognosis. Okay, the patient is in a bad DIC. Her INR will be 2.3, 2.4, possibly because of a health syndrome that has come in. Deliver her, give her a lot of FFP, and by next day morning she's going to be fine. So that is the basic concept of this high dependency unit that we have. It's an area for patients who require more intense observation than provided on the floors. Now in your labor room, you have 5, 6 patients delivering one after another. How will you concentrate on a patient with preeclampsia in such a situation? You need to have her in a little bit of more intense place where you could monitor her. And it provides a standard of care intermediate between acute labor suite and a full ICU for high-risk obstetric patients and those with medical conditions. So it's not as technologically innovative as an ICU, but it's much more technologically advanced as compared to a regular labor suite. Now, in India, we always think in terms of cost, and HDU will definitely be cheaper as compared to ICU. In my own hospital, the HDU care per day comes to about 4,500 rupees, while in the ICU, even without ventilation, it is 18,000 rupees. If the patient goes on a ventilator, it comes to 25,000 rupees. And mind you, I'm in a trust hospital and we are the cheapest in the city of Bangalore. So that is how the costing also goes. And it provides high level of individual, medical, and more important, the psychological care. We are talking a lot of respectful maternity care now. Now, when you say respectful maternity care, it does not apply just to normal patients. It applies also to your sick patients. And delivered by a staff who understand physiology and pathology unique to obstetric patients. I do not know how many of you have ever delivered a patient in an ICU setup. Maybe you don't have an HDU, but you'd have delivered in ICU. Let me tell you, every time I finish delivering a patient in my ICU, not the obstetric ICU, the regular ICU, I come out drenched fully in sweat because those ICU girls do not know what is PPH, they do not know anything. Imagine the same thing happening where your labor room nurses or your midwives are present. Your life would be much more easier. So how do you manage a patient in an HDU? You do an initial assessment and resuscitation. The basic principles of critical care are same whether it's HDU or ICU. Maternal, you monitor organ function. Every single organ has to be monitored. Cardiovascular, renal, pulmonary, hepatic and cerebral. Unfortunately, over the years, we obstetricians have become such that we just carry our pocket Doppler. We have forgotten the stethoscope also. We just carry our pocket Doppler, look at the fetal heart, at the most do a PV and then we forget the rest of the thing. Okay, I've had, I'm very, very strict with my postgraduates and fellows. If they have not checked the heart of the patient, they invariably have to do many extra duties. That is the kind of punishment I give them because quite often, when you're busy, you say, there is nothing. Those are the patients where you will find that a mitral stenosis has missed by many, many doctors who have seen her before. I've had many such patients. So initiate baseline and specific investigations as indicated. Treat the primary condition. Most of the time we know it will be preeclampsia, hemorrhage and sepsis. These are our three common pillars that we generally look after. Check the fetal condition, a CTG, a Doppler and maintain uteroplacental oxygen delivery. Okay, do not allow the fetus to go into a distress stage. I do not know how many of you have managed a patient with dengue. There is gross oligamnios comes in and then you will start getting a cord compression pattern in this patients, and if you deliver the patient, God only help you, because in an active dengue, if you try to deliver the patient, there's going to be a massive torrential hemorrhage. So it is our duty at that stage to see that we give enough uteroplacental oxygen delivery is kept on in these patients. Fluid therapy, crystalloids, colloids, blood, monitor CVP, early urine output and lungs monitoring are all equally important. As obstetricians, we all have to be perfect in fluid management. Unfortunately, our training doesn't include so much of fluid management during our postgraduate days or even later, because the kind of crystalloid you use, the kind of colloid you use, how much you give, in which condition you give how much, these are all very, very important. And we need to involve appropriate clinicians from relevant specialities. Now, if I have an APKCD as a cause for hypertension, it is not that only I am going to monitor. No, I am going to have a team with me. I am going to have a nephrology coming in to see how the blood pressure is best controlled. Now, the basic therapy consists of fluid therapy and transfusion, the CVP, MAP and oxygen saturation, and mechanical ventilation SOS. Now, planning an obstetric HDU. Since many people do not have an obstetric HDU here, I thought this would be very useful. How much cost is going to come? How do you handle an obstetric ICU? Because, every town should have at least 1 or 2 centers of obstetric HDU where the patients can be shifted. So, there will be a cost of initial expenditure, purchase of new technology, recruitment of staff, and rolling annual cost and other indirect costs like training, consumables, IT facility and so on. So how do we overcome this kind of financial drawbacks? By pooling of cases and or early proper referrals, making it a viable unit. We all will have to learn to work with one another. We cannot say, I'm an island, I don't want my next street gynecologist to do well. That doesn't work at all. We all have to work in cooperation because the current medical legal climate is so bad that you just say one sentence to the relatives, they'll come and sue you. So that is one thing we all will have to learn, to make sure that we neither criticize but help each other in our fraternity. So we require space, the equipments, the personnel, protocols, audit, and education and training. All these will be required when you form a HDU. Now space, adequate space per bed as a part of labor suite or a floor near ICU or OT. If your labor room has a space, well and good. In my place, in my labor complex, I have my HDU, I have a labor OT also in my labor complex. But wherever you have a good space, but it should be nearer the OT. There should be at least one fully equipped obstetric theatre within the delivery suite. Where this is not possible, a lift which can be commanded for rapid transfer of women to the theatre must be available. It's very simple to say this. In my hospital, we have 6 elevators, but when you need them to shift a patient from the emergency room, which is on the ground floor of the other building, to the first floor of my labor room, oh, it's a exercise. So we need to be careful about that. I mean, it's a big hospital. I have a lot of manpower available. 2 of my postgraduates or fellows stay with the patient while being transferred. All of us cannot afford to do that because most of us have 1 or 2 staff in our place. So this becomes very important. And of course, a blood bank facility is a must. Now, this is a Government of India's recommendation. Up to 250 deliveries per month. If you require a minimum of 4 beds. Now, in private practice, I do not know, in Solapur, in Bengaluru, nobody ever has, in private practice, 250 deliveries a month. I do not know. Morning, you were telling me, no, Bhivandi, they have a lot of deliveries. Bhivandi there, yes. So, but in private practice, you cannot have 250 deliveries. I mean, you can't. Okay. So what we need to do, 3 or 4 hospitals join together, have it in one place. When there is a need to shift to that particular place. I mean, I think our egos will have to take a little bit of backbenching, then only we'll be successful. Now, the staff requirements per shift, this is per shift. And there are always 3 shifts. All of those who are running a hospital will know that there are 3 shifts plus 1 more extra shift people for covering for leave and things like that. So you need 4 sets of each, what I'm telling. So if you have a 4-bedded HDU, you need 2 dedicated nurses per shift. That means you need 2 3s are 6 plus 2. 8 nurses is what you will be requiring. And this again is a plan of the HDU and an obstetric ICU that is given by the Government of India. Government of India has done a very good work. I mean, if you just go to the Ministry of Health site and you will get all these details over there. Now, there are certain other important things, like we are basically interested in birthing only. So our cots must be birthing cum patient bed. You should be able to convert that cot into a birthing bed if required. Mattress should be washable in 3 parts of minimum 6 inches with perineal cut seat section. Again, those who have delivered in ICU will know that you don't have a perineal cut in the ICU beds, and it's a hell to bend down and get it, and ICU patients are sick. They may be on ventilator, they may be on heparin and they are delivering, and they bleed like hell, and you really don't know what to do at that particular time. Partition between the rooms for ensuring privacy of the patients, that's definitely very important. After having learned my lessons when our new ICU came in, our new ICU is also now 4 years old, I insisted that I need 2 glass cubicles where I can deliver the patient and where there should be a bed with a perineal cut. Each bed should have 2 oxygen, 1 air and 2 suction outlets and at least 10 central voltage stabilized power points. Now this all looks very mundane, but remember, voltage stabilized power points are very, very important. Otherwise your instruments are expensive, and if they are not voltage stabilized, you are going to lose them. Hand hygiene and prevention of infection, waste disposal and pollution control. laboratory backup facility of 24 hours, provision for fire safety, uninterrupted power supply, nurse calling system with central display and audiovisual alarm. Most important, lactation support. We know that in the ICU, a baby is not allowed inside. So, you are separating the mother from the baby and you're not giving lactation to the baby. You put them on the top feeds, which is a big no-no. Whereas if you deliver the patient in HDU, you can keep the baby with the mother and allow the mother to feed also. And of course, you should have an ambulance in case, all HDUs may not have an obstetric ICU. So if a respiratory support is required, we cannot give a ventilatory support in HDU. That is not allowed. If a patient requires ventilatory support or if a patient requires dialysis, you cannot have them in HDU. They have to be in the ICU. So basically, the obstetrician would be the full-time in charge of the HDU. Just imagine the amount of advantage because an obstetrician is in charge, because they know everything about the patient. Your nurses are trained in obstetrics. They know how to hand over an obstetric patient. Okay, we are not just interested in pulse and BP. Now we need cervical dilatation, effacement and everything else. So this is the kind of staff that you would require. This is just my ICU, my HDU rather. The entrance to the complex will be there. There is a triaging area. Then an HDU with all the display charts should be there. Because, whether it's a magnesium sulfate or whether it is postpartum hemorrhage, the turnover of the nurses is very high. So unless you have put up the charts, things are going to be difficult. You definitely need a septic labor room for maybe HPSAG positive or a HIV patient, even if you don't get septic abortion and things like that. A nursing station, a crash cart, and a HDU bed with all its equipments, including infusion pump, syringe pump, should be available. So these are the equipments you will require when you put up your HDU: the infusion pump, the syringe pump, a wall-mounted suction, a multipara monitor, a glucometer, a defibrillator, a ICU ventilator. You have one ventilator available in your HDU. You may not use it, but just for transfer at least, you need to stabilize the patient. So you need one ICU ventilator over there, and of course a well-equipped laboratory. Also remember that all your equipments being procured should be with warranty and annual maintenance contract at least for 3 to 5 years. We tend to forget this. We are very busy people. So we tend to forget all these small things. So we need to have a contract. Of course, the fetal surveillance equipments, fortunately, I think most of the labor rooms now have all these equipments. But if you don't have, you definitely need them. Now, personnel, of course, personnel are the most important in any situation. The equipments are needed, but the person is more important. And HDU working party consists of obstetricians, physicians, midwives, anesthetists, and neonatologists. With the nursing care of specifically trained nurses per bed, and HDU provides continuous observation. We know now that whenever there are sick patients, what we follow is EGDT. That is an early goal-directed therapy, whether it is septic shock or whether it is a PPH or whether it is a severe preeclampsia. We need to follow the early goal-directed therapy. So, and the system of bundles has all already come in. So we need various kinds of critical care bundles to come in. Bundle, I'm sure all of you are aware of what is a bundle. A bundle is a set of treatment protocols that you give to a patient. It's not a single thing. Like PPH, you just don't give oxytocin. You have a full set of bundles. So this set is called as a bundle, and in critical care, we are moved over into bundles for everything. Now, communication skills is very important because it should be accessible, it should be understandable, it should be perceived appropriately and attended to, it should be remembered, and it should be motivated to be acted upon. One thing I have made it a policy in my place is not to scold people. You need to train them and you need to tell them, look, this is not how you handle. You have to handle like this. Then the things are better. Okay. You need a smooth teamwork. not like a football where everybody falls over everybody else while trying to handle an emergency. You need it like a smooth choir which each one plays their own role. So your nurses, your IMRs, your anybody have to play their own roles. Of course, quality cycle is very important. You need to plan, do, check, and act. This will be required at every stage, even after your HDU comes in. And the protocols are very important. The management of major hemorrhages, management of preeclampsia, difficult intubation, antacid prophylaxis, oral intake during labor. For everything, you need to have a protocol which needs to be followed by everybody in your hospital.
Sir, last 2 minutes, please.
Yep. So patient information is again very, very important. You need to tell them properly what is going wrong. Counseling is a very important part. So basically these are the various aspects you will be doing for the patients when the patient is in HDU, starting from fluid balance onwards to non-invasive monitoring to inotropes. Inotropes are allowed to be given in the HDU. Only ventilation is not allowed. So there are certain times when you have to shift to ICU, mainly if the respiratory rate, pulse rate, or a urine output is not correct, or her GCS is not right, then you need to shift her to ICU. Okay, this would be the last slide, and advantages of HDU. A dedicated obstetric HDU with the knowledge, familiarity, experience, and expertise of an obstetrician and a specialist team would be the best place to monitor and treat critically ill obstetric patient. Allows continuity of the antenatal and postnatal care, and which is provided by the same team. Now, care in an obstetric HDU avoids exposure of the critically ill pregnant patient with altered cell-mediated immunity. Our pregnant patients have an altered cell-mediated immunity and high level of corticosteroids to potential hazardous ICU environment with the risk of hospital-acquired infection. All ICUs are zoos. How much ever clean you keep them, they're all zoos. You'll have all kinds of strange bacteria lurking in an ICU. Now, our pregnant patient, we have to be careful about it. Patient satisfaction may be increased since it is less noisy. All the meters are beeping everywhere in the ICU and it's scary. I hope none of you have ever stayed in an ICU, but the next bed making a noise really scares you up. And imagine a pregnant lady. And obstetric HDU allows for lactation support. So thank you very much, and I thank Solapur Obstetric Society once more for having me here.
Thank you, sir. As you have already elaborated all the things, and most importantly, you have given the tips how to set up this HDU and how it should be practically viable. Thank you very much.
I thank the organizing team for giving us the opportunity to chair this session.
Thank you, chairpersons. I request the chairpersons to please felicitate Mehta sir. I request Milind Shah sir and Jama ma'am to please join for the felicitation. I request Jama ma'am to please felicitate our chairpersons.
Now I request Dr. Rakhi Sarda, Dr. Lalita Shitole and Dr. Madan Kamble to chair the session. We are not taking the lunch break. We are continuing with the sessions. You can come with the plates in hall. Dr. Rakhi Sarda, she is a consultant at Latur, past secretary of Latur OBGY Society. Dr. Lalita Shitole ma'am, she is a senior most consultant, owner at Balaji Nursing Home. And Dr. Madan Kamble, he is the organizing secretary amongst Foxy Medical Legal Conference, past president of Akluz OBGY Society. Over to you, chairpersons.
Good afternoon, everybody. Before starting with our session of labor in non-communicable disease, I'd like to firstly at the outset, I'd like to thank the organizing members of Solapur OBGY Society for conducting this excellent conference, noble conference it is, full with academics feast. I'd like to thank Dr. Pratibha Valdava for inviting me for this conference. We will be starting with our first lecture by Dr. Sanjay Patil sir. I call upon dais Dr. Sanjay Patil sir. Patil sir is a professor and HOD of Department OBGY. He is at the Indore Medical College. He is an ex-professor and HOD at GMC Latur. In NDVH under the local since 1995. Sir has done his diploma in pelvic scopic surgery at the University of Kiel, Germany. Over to you, sir.
Congratulations to brave hearts who are remaining in the hall despite being hungry to listen to the most critical talk on eclampsia. So again, I congratulate you for being in the hall. At the beginning, I would like to thank Solapur OB-GYN Society for inviting me for this talk. Latur OB-GYN Society and Solapur OB-GYN Society has a long association, and I bring warm greetings from Latur OB-GYN Society. It has been always pleasure to be in Solapur, as I have close relations with this city, may it be a VM Medical College or having Sasural in this city. The love and affections of friends and the family I receive here is always overwhelming. Thank you, Solapur OB-GYN Society, especially Dr. Pratibha, for this invitation and honor. We all know that eclampsia is the third commonest cause of maternal death in India, responsible for 17% of the maternal deaths. Out of 50,000 maternal deaths, still 99% of the deaths are occurring in developing countries like us. No doubt, there is an improvement in statistic from 10% mortality in past to now 3% in cases, but still a long way to go. Despite in Azadi Ka Suvarna Mahotsav year, the future journey is steep one, as obstetric as a branch is slipping from our hands, and it is being dominated nowadays by BMS people. For reasons we all know, we are taking only filtered patients in our private setups. Very few private setups are venturing for high-risk obstetric. So my question to audience is eclampsia a collective failure of antenatal care model, or there are social, political and economical reasons behind it? Three things are certain. Majority of the patients are young primary gravidas, more than 60%, with poor socioeconomic status, more than 55%, and majority of them are ANC defaulters, around 2/3 of the patients. As far as etiology of eclampsia is concerned, Mayo Clinic's award for explaining etiology of PIH still remains unclaimed for last 5 decades. Immunological theory is the closest that can explain most of the observations seen in PIH on basis of host versus graft reactions based on immunological module. paternal gene expression due to inadequate production of blocking antibodies by mother resulting in activation of cell-mediated immunity is said to be the root cause of all cascading events. Research is on right now to synthesize these blocking antibodies artificially and may become available in not so distant future. Gene modulation can be another answer to this complex problem before conception in a susceptible patients. In nutshell, we can say PIH is a familial condition in which a faulty immune response gets triggered by a particular male partner or be predisposed by allergies or deficiencies of diet components like trace element. Along with the issues mentioned in the slide, another major problem exists in today's practice. And that problem is one's exposure to handle eclampsia. It is never to the level of perfection, as despite heavy clinical load in labor wards, for example, in our college around 1100 deliveries per month, eclampsia workload is far and few. We do not have dedicated teams working 24/7 to manage such critical cases due to multitasking expected from them, due to scarcity of manpower, of course. In wards, either JR or intern are usually opening batsmen for this World Cup final, that too at odd hours. Another dilemma that we face is when to start preventing anticonvulsant therapy in severe PIH patients. It is very difficult to predict eclampsia based on signs and symptoms. 17% patients did not have PIH. 23% patients had no or minimal hypertension. 19% had no proteinuria, and 33% had no edema found in large multicentric study of eclampsia. So, for most of us, presence of eclampsia comes as a googly. In two large observational studies done in USA recently, 2018, it was found that the average rate of eclampsia in 13,927 cases who received prophylactic magnesium sulfate was 0.26% against rate of 0.18% amongst 885 women who do not receive Maxel. Not much significant difference. Hence, it is important to redirect aim of treatment of PIH to control BP and have a proper fluid management, as they are the two main contributors to the maternal death. These are the principles which we all know from textbook: anticonvulsant therapy, blood pressure control, fluid management, investigations, delivery, and preventing postpartum hemorrhage. During act of convulsion, preventing self-injuries and securing airway are the two most important things, as this convulsion usually lasts for 2 to 3 minutes. Shifting the patient to eclampsia room, facial mask oxygenation, and Shifting the patient to eclampsia room, facial mask oxygenation, and lateral recumbent position to patient are the minimal things that one can do. One must not overreact or panic and should have philosophical approach to this in a way that this too shall pass, and apna time aayega for initiating treatment kind of attitude. Maxelp is the drug of choice, as it requires less need of ventilatory support, less requirement of ICU care, And obviously, with the use of Maxhelp, we have found that it reduces the maternal mortality. It acts as a vasodilator and membrane stabilizer. This reduces the cerebral ischemia and thus prevent the neurological damage. Maxhelp is also found to be the central anticonvulsant by blocking N-methyl D-aspartate receptors in the hippocampus. How to administer Maxhelp? We know IV is the preferred route, except if the patient is at periphery and you are shifting the patient to tertiary care hospital. At that time, it is expected that you give the loading dose of 10 grams in both buttocks and then shift the patient. Otherwise, IV is the preferred dose. I am glad Solapur has innovated this IV regime by respected Dr. Sardesai Madam, and it has been recognized internationally where low-dose magnesium sulfate therapy is rooted in our system, and we all follow that, especially in Marathwada region. And we have found that it works excellently. The IV dose given in the books is 4 gram intravenously over 5 to 10 minutes plus 10 gram intramuscularly, 5 grams in each buttocks. In case of recurrence, in the next 20 minutes, 2 grams of bolus can be given again. As far as monitoring of the Maxhelp therapy is concerned, simple observation of patellar reflex, urinary output and respiratory rate suffices. If there is a respiratory depression found, immediate correction with the help of 1 gram of calcium gluconate given over a period of 5 to 10 minutes should be sufficient. In case if the patient is having oliguria, that is less than 100 cc over a period of 4 hours, you can think about serum magnesium monitoring. Therapeutic levels usually needed to prevent the convulsions are 2 to 4 millimoles per hour. In rare cases, if the convulsions still persist, intravenous diazepam 10 mg or thiopentone 50 mg intravenously should be attempted. Intubation may require to protect the airway and ensure adequate oxygenation, as these patients have cellular hypoxia. If still convulsing, then in IPPV, intermittent positive pressure ventilation and muscle relaxants can be added. Usually, when such repeated convulsions occur, there is a strong possibility that patient is having underlying hypertension, and it should be addressed along with initiation of anticonvulsant therapy. While managing the hypertension, we all know that hydralazine is the drug of choice for acute control, where we give 5 mg IV bolus over a period of 3 to 4 minutes. If not reduced, give intramuscular every 30 minutes until BP is less than or equal to 170/90. Maximum dose that can be given is 20. If hydralazine is not available, give labetalol 10 mg IV. If inadequate response after 10 minutes, repeat 20 mg. If 10 minutes later still inadequate, increase to 40 mg, then 80 mg 10 minutes later if still inadequate. Maximum cumulative dose is 300 mg. Nifedipine, at least we prefer to use nifedipine 5 mg orally sublingually. If no response after 10 minutes, repeat dose after 10 minutes up to maximum 40 mg. However, it may exaggerate hypotensive response if the patient is receiving magnesium sulfate administration. A word of caution though, as we know, majority of the patients with PIH or heading towards eclampsia have got some component of cerebral edema, and cerebral edema itself increases intracranial pressure, and along with that causes a systemic response where there is a rise in blood pressure as a compensatory phenomena to ensure adequate cerebral perfusion. Hence, under these circumstances, bringing down the raised BP will increase the extent of cerebral ischemic damage, and it will be counterproductive. So, one has to be careful up to what level we are trying to bring the blood pressure down. Another critical management question comes, is routine CVP monitoring for fluid balance should be practiced? Routine use of CVP monitoring for fluid management is doubtful. Two things, there is a interstitial lung edema, and whatever levels that you find may be low or normal. So they don't actually help in routine management of fluid management. However, if you are determined to use CVP, levels are to be kept below 5 centimeters of water. Fluid challenges to try and improve fluid output should never be used, as this will aggravate already dangerous condition. Next important issue is the fluid management. Crystalloids are preferred as mainstay fluid therapy. Normal saline is preferred over lactate, as lactate along with phosphates formed during convulsion and sulfate from magnesium sulfate tend to increase the acidemia blood and aggravate cellular injury and oxygenation. Another word of caution here is to avoid temptation of giving soda bicarb for correcting acidemia. It crosses placental barrier and affects the fetal metabolic environment. In order to prevent pulmonary edema, left ventricular failure and adult respiratory distress syndrome, preventing fluid overload is a crucial step of management. Indwelling catheter in the bladder is mandatory, and hourly fluid balance chart is must. Lab studies, well, there should not be any confusion. We all know the drill. CBC, LFT, KFT, coagulation profile with platelet counts. In routine all cases, serum sodium, potassium, magnesium levels. In critical patients, whether to go for routine CT scan in uncomplicated cases. It's a controversial issue, I know, but Solapur prefers to do CT scan of all patients of eclampsia, but it is usually not indicated unless and until we are suspecting brain hemorrhage or a comatose patient or patients with focal neurological deficit.
Excuse me, sir, last 5 minutes.
Yeah, I will finish in 2, don't worry. The objective of the management is to save both the mother and the baby. It is therefore important that both should be monitored closely to ensure correct intervention in a timely manner. Whether it is intrapartum or antepartum, the goal of the therapy is to deliver the patient as soon as possible, because we know that petoplacental unit is the culprit of all causes that has occurred in the patient. But before that, the patient needs to be stabilized. No attempt should be made to deliver the mother either vaginally or by cesarean delivery until the acute phase of the seizure or coma has passed. Anesthesia. We all agree that giving anesthesia to eclamptic patient is a challenge. Epidural is considered safest nowadays as it does not affect cardiac output, improve the placental circulation, and helps in further control of the blood pressure. One word of caution though, as vasodilatation and pooling of the blood in lower extremities may cause hypovolemia. Preloading of the patient with 400 to 500 ml of colloids prior to anesthesia is must, and our good anesthetist always does that. Spinal anesthesia, being quick to administer, has added advantage in emergency. No ergometrin after delivery. Instead, oxytocin 40 international units per hour should be started after the delivery of the baby. To summarize, managing critical eclampsia patient, whether intrapartum or postpartum, is a teamwork of experienced obstetrician, intensivist, anesthesiologist, and a good, vigilant working staff. Wishing you good luck if you have one right now. Thank you.
Thank you, sir.
Thank
It
you.
was an excellent talk.
Can I ask one? Not
Yes, ma'am.
question. Doctor, we Solapur do not prefer to do CT scan in all patients. That was a study was done to know the
serious changes or changes in the brain in patients of eclampsia. Otherwise, nobody does CT scan as a routine in all cases of eclampsia. This wanted to clarify.
Okay.
It was done for a study purpose to
Okay.
know what are the changes that are taking place in cerebral region in patients of eclampsia in 110 consecutive cases, which turned out to be press.
Okay.
Otherwise, nobody does CT scan.
Because two medical colleges starting the same kind of investigation in eclamptic patients increased, rather roused my curiosity.
No, at least in Solapur I know.
Okay.
One more thing, if you refer a patient to neurologist,
Neurologist.
case of eclampsia, you refer them to neurologist, they are going to do CT scan. It is their purview.
Correct.
As an obstetrician, I think here all will agree, we never do CT scan as a routine. That what you are referring was a study that was done.
Okay. And it was found out that all the patients
had press.
Yeah.
So what most important thing is control of blood pressure is most important
Okay.
to control the convulsions. Giving anticonvulsant, any dose you give, low dose, Pritchard, Zuspan, whatever you give. But it is the control of control of blood pressure which is going to help the patient.
Correct. And one word of advice is to not to fear about cerebral edema. You know, brain has only three things. There is a brain matter 1400 cc, there is a CSF 150 cc, and there is a one blood 150 cc. So it is a play of three structures. One expanses, other compresses. So one should not be afraid. The medicinal line of treatment is fairly simple. Give mannitol, give decadron, then give magnesium sulfate to reduce the blood pressure. So one should not be afraid of treating Maxal before the physician comes to you. If you suspect Maxal, if you suspect the cerebral edema, start the treatment immediately. Yeah. Go to CT scan. CT scan. Okay.
Magnesium sulfate itself will relieve cerebral edema. If the cerebral edema is extensive, very refined, convulsions continue to occur in spite of giving Maxal for whatever you give, then you have to add mannitol
Correct.
along with Maxal to relieve that edema. Not every patient.
Not every patient. So thank you. Despite being hungry, we are asking questions at this moment. It was nice talking to you. Thank you.
Thank you, madam, for valuable inputs, and thank you, sir.
Sir, we want to felicitate you. I request the chairpersons, I request Anjali Jama madam to please go on stage. LOGS and SOGS looking good on stage together. Now we have the next lecture. It will be an online lecture by Dr. Kiran Pandey, madam. Chairpersons, over to you. The lunch has started. You all can get your plates inside and have lunch inside as well while listening to the online lecture.
I would like to introduce next speaker, Dr. Kiran Pandey. She is professor and ex-HOD, Department of OBGY at Medical College, Kanpur. She is chairperson, Medical Education Committee of FOXI, and also ICOG Governing Council member 21 to 23. She is chairperson IMA Women's Wing, Vice President UPCOG, and past President of KOGS and IMA. She is the recipient of many national awards and also many original research papers, more than 150 research papers. I would like to request ma'am to deliver the lecture. Thank you.
Thank you, chairpersons, and I'm
very much at the outset, I will say I'm thankful to Dr. Anjali Jama, Dr. Monica, to for giving me this opportunity. And let me share my screen with you. So, are you able to see my screen and hear me properly? Hello?
Yes, ma'am.
Are you able to hear me and are
Yes,
you
ma'am.
able
We are
to
Yes,
able
see
ma'am.
to
my
hear you.
screen?
Yes, you are audible.
Okay, okay, okay. Thank you very much. So, my topic is cardio. Just a minute, it is not moving. Yes. So the peripartum cardiomyopathy, as we all know, I'm starting without any introduction otherwise, because already the time is very short. Everybody is hungry and taking the lunch. So peripartum cardiomyopathy is a potentially life-threatening condition, and that's what is the nightmare for any obstetrician who faces it. Basically, it presents with a heart failure with the reduced ejection fraction. That is the main thing. Diagnosis is mainly exclusive, no prior history of heart disease, less than 1% of all cardiovascular incidents. 90% cases do occur within 2 months of pregnancy. Mortality rate is very high, 86 to 56%, and recurrence rate is also 20%. So you can understand how it behaves, it becomes a nightmare for the obstetrician. The basic the factors are, as just to emphasize it, heart failure, which is secondary to left ventricular systolic dysfunction, when LVEF is more than less than 45%. Sorry for this typographical mistake. Occurrence towards the end of pregnancy or in the months following delivery, mostly in the month following delivery. There are no other identifiable causes of the heart failure. Historically, it is termed variously. Some people said it is a toxic postpartum heart failure, MEDO syndrome, postpartum myocarditis, etc. But presently, it is called as PPCM, and the incidence varies according to ethnicity. It's more in the Nigeria and the South African women. Pathophysiology is quite complex, not completely understood. Basically, angiogenic, metabolic, hormonal, oxidative stress factors are responsible. Two-hit model is the main thing. Systemic angiogenic imbalance and host susceptibility. They are crucial. And the oxidative stress is mediates through the cleavage of prolactin hormone into the 16,6-kDa, and which is basically the key factor for endothelial damage. That is what the studies are coming out with it. Some 15 to 20% patients may also carry the mutations in the gene. Now, this slide can show you where the prolactin is being converted because of the oxidative stress. These oxidative factors, it is converting into 16-kDa, which is being responsible for endothelial dysfunction, apoptosis, and which response becomes responsible for cardiomyocyte ischemia, metabolic insufficiency, apoptosis. And this is the theory on the basis of which later on you will see the bromocriptine is being thought of to act here on this, according to this pathophysiology. In this slide, you can see the relative levels of the prolactin and SFLT1 by the red line and the black line showing the relative increase in the cardiac output. They are responsible for the increased incidence of the PPCM, and that you can see here is a huge bar, and this is just after the delivery 1 to 4 months, and mainly basically in first 1 month is the maximum. So this is the slide showing it. Now the factors, other factors which predispose to it: maternal age advanced, like more than 30 years, multiple pregnancies, African descent, malnutrition, prolonged protocolytic therapy, hypertensive disorders, maternal cocaine abuse, multiparity. These are basically thought to be predisposing factors. Women with PPCM have shown to have a high FLT1, and which is the implicated in the pathogenesis of preeclampsia, and that is why it is suggested there is an overlap, and that becomes the first differential diagnosis. So severe preeclampsia do present like PPCM, and we have to differentiate. Other cardiomyopathies like hypertrophic cardiomyopathy, HIV, AIDS myopathy, they may be a differential diagnosis, or the pre-existing congenital heart disease, pre-existing valvular heart disease, viral myocarditis, pulmonary embolism. These are the other conditions which we have to differentiate. The patient basically presents with the dyspnea, orthopnea, paroxysmal nocturnal dyspnea, pedal edema, cough, hemoptysis, any of the symptoms can be there. Along with the, when you examine it, you will see tachycardia, tachypnea, elevated or reverse jugular venous pressure, bilateral craps, third heart sound, murmur of the MR. So with these signs and symptoms have to be looked for it. Now, how do you further go for it? Investigations. ECG, it should be performed in all the cases. It is safe, inexpensive, though it doesn't give very specific pattern of PPCM. But ECG is rarely normal. It shows usually repolarization abnormalities. And left bundle branch block, long QTC interval, tachycardia may be found in 50% of the patient. So ECG is one of the important universal investigation. Second is echocardiography. This is basically done to diagnose make the diagnosis, or even pre-existing heart disease. Prognostication like PPCM, there will be LVF has to be measured, pulmonary hypertension have to be seen, and the complications have to be excluded like LV thrombus. Cardiac MRI has a very limited role only in the case of where you want to evaluate cardiac structure and function specifically. Now, the endomyocardial biopsy, it is not routinely recommended because it doesn't add much of the information, only to exclude the acute myocarditis or other viral infections, autoimmune and metabolic disorders. This can be done, but this is just a theoretical and research purpose. Now, the markers, biomarkers, they are again very important. The patients with acute PPCM have consistently elevated plasma concentration of natriuretic pro-BNP. I'm sorry, this should be more than 300 nanogram per DL. I had corrected, but somehow it is not showing up. So more than 300 nanogram per DL, or SFLT PIF GF ratio. If it is more than 85, then it suggests the PPCM. Now, this slide is very important to understand the basic thing. I hope our audience would focus on it. And the signs and symptoms I have already discussed. So if they are there, like orthopnea, dyspnea, cough, the tachycardia, tachypnea, etc., which we have discussed, then we go for 4 important investigations: natriuretic peptides, which I just showed you, biomarker, ECG, chest X-ray, echocardiography. Now, if natriuretic peptides are increased or left ventricular ejection fraction is less than 45%, the chances are the patient is an acute PPCM. We have to exclude the overt pre-existing heart diseases like congenital valvular heart diseases, hypertrophic cardiomyopathy, etc. Now, if natriuretic peptides are increased, but LVEF is more than 45%, that means the patient is probably having cardiac or extracardiac origin of symptoms. It can be a pulmonary embolism, it can be amniotic fluid embolism, or isolated dysfunctions, hypertensive disorder, eclampsia, sepsis, etc. Now, if natriuretic peptides are normal and LVEF is more than 45%, now the condition which have to be considered are the extracardiac origin of symptoms: anemia, pneumonia, hypertensive disorders, again, eclampsia, depression, physiological changes. So the basic thing is, if we go with this follow-up, we can easily reach to the only thing, index of suspicion has to be great. We have to think for it, and that's the important thing. Now, this slide again, I would like everybody to focus it because maximum summary you will get here. The PPCM can be mild, moderate, severe. And on the basis of that, actually, the patient has to be managed. Now, in those four things, I've showed you the important thing are one, clinical presentation, and four investigations. We are just simply focusing on that. Clinical presentation, if there is a subacute heart failure or hemodynamically, patient is stable. There are no specific changes in ECG. Chest X-ray showing pulmonary congestion, but it may be normal also. Peptides are increased. LVF is 30 to 45%. In these cases, if such as the condition, patient can be managed even into the normal ward. Ambulatory treatment can be selected. Patient is kept on oral heart failure drugs, oral diuretics if the overload is there, and bromocriptine can be given for 1 week. That is the latest theory, therapy which is being given. Now, the second, where the moderate, suppose the heart failure has become acute, hemodynamically patient is stable, but respiratory insufficiency has come. In these cases, ECG still no specific changes, or even tachycardia can be there. Pulmonary congestion has come, and cardiac celerity has increased. Peptides have further increased. LVF has further decreased 20 to 35%. And now this patient requires the care into the heart failure unit. Besides the other drugs, here we also have to give the if the BP is high, then vasorelaxants have to be given, supplemental oxygen has to be given, and sometimes even non-invasive ventilation is required. But inotropes, catecholamines have to be avoided. Once the condition further deteriorates, patient goes into the cardiogenic shock, hemodynamically unstable, and respiratory insufficiency, both are there. The tachycardia and ECG might be there. Besides the other findings, now pleural effusion has also been seen into the chest X-ray. Peptides further increased, LVF further decreased, LVF less than 25%, right ventricle dysfunction has now appeared, and the dilatation is possible. This patient specifically requires ICU care. So by this flow chart, we can decide which patient has to be treated into the normal ward, where it has to go to into the heart failure unit, or it has to go to the ICU, because that will depend, that will show over the prognosis. So here, besides the management into the intermoderate case, inotropes and catecholamines may also be required. Mechanical ventilation may also, the invasive ventilation may also be required. Even ECMO might be needed. And here the bromocriptine in these moderate and severe cases, it has to be given for 8 weeks besides oral heart failure drugs. Now the prognosis, good factors, that will be the thing. Early diagnosis, mild presentation, good response, ejection fraction more than 30%, mildly dilated chambers, and NT-proBNP less than 1000 nanogram. So these are the good factors, but as soon as we delay in the diagnosis, response is poor, LV and diastolic diameter becomes more than 60, ejection fraction further decreased to less than 25 to 30%, NT-proBNP more than 1000, African ancestry, obesity, thrombus has come, which is the complication I showed you into the echo, multiparity, age more than 35 years. Now these are the poor prognostic factors for the recovery. Now this patient's what all treatment it will require. Basically, this patient requires the multidisciplinary approach. All cardiologists, interventionists, obstetrician, pediatrician, intensive care unit, everybody has to be there. And the basic three principles, optimization of hemodynamics, preload and afterload both have to be reduced, cardiac contractility has to be increased. And this can, how it can be achieved? By the treatment of pulmonary congestion, control of hyper or hypotension, cardiac arrhythmia have to be treated, taken care immediately, and prevention of thromboembolic events. So these are in principle. Now, so the basically monitoring has to be done. Adjustment of medication, hamara treatment what comes, antiarrhythmic, anticoagulant, sometimes even implantable cardiovascular defibrillators have to be taken. And the medical investigational therapy, I said, because this is under trial, bromocriptine, although we have started giving, immunosuppressive therapy and intravenous immunoglobulin sometimes to give. Now, when do we have to give in these things? So the basic things are Acute, when the patient is in acute stage, oxygen, diuretic, vasodilators, antiarrhythmic, anticoagulant, bromocriptine. This is the main line of treatment. Once the patient goes into chronic, lifestyle modification has to be done. Diuretics have to be given for a long time. RAS blockers, beta blockers, cardiac resynchronization may be needed many times, and implantable defibrillators may be needed. But about that, I will tell you when. Now, anti-arrhythmia, as you know, ventricular tachycardia in 20 to 25 percent cases, atrial fibrillation in 10%. So they should be treated. Ventricular arrhythmias by class 3 antiarrhythmics, and I know treatment with inotropes should be directed by the invasive cardiac monitoring, not as such, dobutamine, etc., how they have to be given. Anticoagulant, they becomes very, very important when we are keeping the patient on bromocriptine especially. But if during pregnancy, they are sometimes in the late stage of antenatal period, PPCM manifests, and then in those cases, unfractionated heparin or LMWH can be given. Postnatal period, warfarin can be given, which is contraindicated into the antenatal period. I'm trying to be very simple and very point-wise, not going into the details, so it should not be any confusion. Now, what about the mechanical device syndrome? Mechanical circulatory support is only needed in those cases who are unresponsive to medical therapy with maximal inotropic support. But even after giving maximum dose, patient is not responding. Implantable cardioverter defibrillators may be needed, but we should refer it for 3 to 6 months, because 20 to 60% of the patient will have complete recovery by 6 months. So this is important. We should not hurry up, but we have to be ready with these things. Now, bromocriptine. I told you this is still investigation, but its use is when it works on the prolactin, and then the prolactin will not be converted into 16 kDa, and so the endothelial damage will be prevented. So that is the basis of giving it treatment. But once you give bromocriptine, the anticoagulation is important because to prevent the thromboembolic complications, and it is also I've told you the prolactin blockade, etc. Now, diuretics. Basically, we do not like in pregnancy, but sometimes we cannot avoid it. Which one? Loop diuretics and nitrated diuretics. These are the agents of choice for volume control. If the cardiac output is too much, there's a pressure of it. ACE1 or ARBs, they can be used in postpartum, but contraindicated in pregnancy. Beta blockers, they are safe in pregnancy. Bromocriptine, some studies still have not proven it, so we can say it is in experimental state. Anticoagulants, I have already told you. Now, the American Heart Association says that anticoagulant should be given if the EF is less than 30% during late pregnancy and up to 8 weeks postpartum. So they are recommending it clear cut. Warfarin, we know contraindicated, but LMWH can be used during pregnancy, and they are saved even during lactation. The novel ones we do not use in the pregnancy. Now, if we see in a summary, ACE inhibitors contraindicated, ARB contraindicated, beta blockers, they have to be used sometimes. So, but you have to remember that baby has to be watched for beta blockage for 24 to 48 hours. They can also cause IUGR, that has to be monitored. Loop diuretics use has to be done with caution because they affect or decrease the placental blood flow, but sometimes they have to be used because there's unavoidable.
Excuse me.
In lactation, yes. I'll take 1 minute. How many minutes? How many minutes?
1 minute, please.
Okay, I'll finish it. Lactation, ACE inhibitors, ARB, you have clear-cut written, ARB is avoided, the rest have to be used with a caution. The labor, the normal, this is in fact for every heart patient, it has to be done in lateral supine position. Effective pain control is important, IV fluids have to be restricted, antibiotics are very important. to avoid SABE. Patient should be kept as much as possible ambulatory, compression bandages in postpartum period to decrease the blood flow to the heart. Postpartum pulmonary edema is a very important problem to be taken care. So the patient is placed into the sitting position, so the venous return does not open suddenly to the heart patient. Prophylactically, if needed, second stage has to be cut short by the instrumental delivery. Intracardiac complications, arrhythmia have to be managed. Pulmonary edema has to be, we have already discussed it, fluid overload has to be taken care. Even if we need oxytocin drip, it has to be concentrated. Now, these patients, they do with advanced heart failure, prompt delivery of the fetus is indicated, but vaginal delivery is always preferred. Epidural analgesia. This is in all the pregnant cases with the heart patient, and the labor is important. Elective CS is only done either for obstetric indications or when there is an advanced heart failure and inotropic therapy or patient is on mechanical circulatory support. So vaginal delivery, as you all know, is the most important because it will avoid all our complications, bleeding, infection, traumatic complications, and the acute shift of the blood volume will be avoided. So these are the some still 40% patient do require LSCS, 25% cases preterm, 5.9% of small for it. The most important thing is counseling of these patients. There is a recurrence, so they should be. They have to. Those who have recovered from left ventricular heart failure, there is a further chance of recurrence. Therefore, those cases who have LVEF less than more than 25%, they can still think, but otherwise avoidance of subsequent pregnancy has to be avoided because to avoid the heart failure or the death. So the last slide, the contraception, what we have to say, you can see, I'm sorry for this slide is a photograph, so it is not very good. Combined hormonal contraceptives are totally red, no, not to be given, but they will need for because we don't want subsequent pregnancy. So emergency contraception, progesterone only contraception, and intrauterine devices. These are the three pillars on which we can work. And now these days, good progesterone only contraceptives are now coming up, so we can use them and give them a proper advice. Thank you very much for your patient listening, and I would once again like to thank the organizers, Dr. Anjali Jama and Dr. Monika Umaban, and also Dr. Sneha Bhuyar, who has encouraged me and told me to go ahead with it. So I'm very thankful. She's there or not, but please convey my message. Thank you very much. And respected chairpersons, I'm highly recognized for giving me this opportunity.
Thank you so much, ma'am, for covering this vast topic in a very short and precise time, covering right from the pathology to the management. Thank you so much. On
Thank you. Any
behalf
questions?
of organizing society, we will like to give a trophy to you, ma'am. Kindly accept from the society. Thank you.
Thank you so much. Thank you. Thank you. Thank you. Thank you very much for the kind trophy. I think there are no questions. Is there? Well, I know it is a rare topic and very less incidents, but once you deal it, then becomes a problem. So this, one should know it, and specifically the postgraduates and the young obstetricians have to take care of it.
Thank you, madam. Next speaker is Dr. Vaishali Korde Nayak. She is a professor and head of the Department of Mymar Medical College, Pune, consultant, critical care obstetrician, and she is also working at Ruby Hall Clinic, Pune. She is a fellow maternal and fetal medicine in US, Singapore. She is university examiner for
UG and PG exams. She is international examiner for Royal College of Surgeons, London. Master trainer of Foxy Violence Against Women's Cell, conducted many national workshops working with Dhira, contributed articles and many books and journals and various publications in national and international journals. Over to you, Dr. Vaishali Kode Nayak, Madam.
Thank you, chairpersons. Thank you for that kind introduction. May I share my presentation? Hope I am audible. Should I start?
Yes.
Thank you. At the outset, I would like to thank all the organizers for giving this opportunity. Dr. Anjali Madam, Dr. Monica, thank you so much for this session and this opportunity. And Solapur Society is always very close. Dr. Miling sir, Dr. Manik sir, thank you so much. Would have loved to meet you in person, but couldn't come down. With this, I would start the topic which is given to me, and that is management of GDM in labor. I bring you all greetings from Pune OBGY Society and our WC Ganpati to bless your conference. It is already a successful event. We all know that GDM is the problem in multiple folds, and the magnitude is quite high of this problem. Hyperglycemia is one of the most common medical conditions women encounter during pregnancy, and almost 1 in 6 live births occur to a woman with hyperglycemia. So we are sitting on a big iceberg. 1/3 of pregnant women, according to Foxy, having GDM, and they get diagnosed 33% in the first trimester, 40% in second, and 28% in third trimester. So detecting them early and then achieving the good tight control of the sugar levels is very important before they land up in labor, so that we can have labor which is safe for the mother as well as the baby. So we know that there are different maternal issues, from abortion to the long-term diabetes mellitus chances, but we are going to focus today on the delivery part, that how the labor during GDM would be, what would be the complications. They would be in the form of more chances of instrumental delivery, traumatic delivery, or there would be more chances of operative delivery because of macrosomia, in fear of shoulder dystocia. Because of polyhydramnios and the big baby, we have higher risk of PPH. So eventually, we have increased maternal mortality and morbidity. And also in puerperium, there are higher chances of infections because of poor control of sugars, landing in sepsis and maybe lactation failure. Even the neonate has so many things to handle when we talk about GDM. There is a risk of stillbirth, which we all are concerned about. Also, the neonatal period is not risk-free. There are higher chances of congenital malformations, more chances of shoulder dystocia, respiratory distress syndrome, cardiomyopathy, hypoglycemia, hyperbilirubinemia. Polycythemia is very commonly seen in these large babies, along with hypocalcemia, and as baby and traumatic, of trauma or Erb's palsy, maybe some bone fracture is quite common when we deliver these fetuses. So to optimize our outcome, we have to have early diagnosis, a good sugar control, good antenatal care, counseling, and then the mode of delivery has to be decided. And at the end of the delivery, a good neonatal care has to be provided to have a good outcome. So we cannot rule out the importance of good screening so as to diagnose that he's having GDM and having a good nutritional therapy and stripes control to have a non-macrosomic baby in labor. So we have to also rule out any retinopathies or nephropathies in a woman who already has diabetes. So we need to do these things. So we have this classification of grade Priscilla White. who has classified the known diabetic cases with either proliferative retinopathy or nephropathy or having both the criteria. So we know that this classification is there for pre-gestational diabetes disease. But our focus is about gestational diabetes, and we have two types of patients. A1, where the diabetes is diet controlled, and A2, where insulin related or insulin dependent gestational diabetes we have. So our patient is going to need insulin. So how are we going to decide the mode of time of delivery in such patients? So these pre-gestational diabetes, the known diabetics, they have always have more complications, and we extend or we allow the pregnancy till 38 plus 6, that means before 39 completed weeks, we would plan an elective section or elective induction of labor depending on the time needs for such patients. If they are type 1 or type 2 with metabolic or maternal or fetal complications, then we may do it before 37 weeks. And if there is further, like there is no contraindication if she is previous LSES, diabetes is not just the contraindication. And before allowing or before deciding the mode, we need to do ultrasound diagnosis by having proper growth charts plotted. And there we can discuss the risk of vaginal birth versus LSES and then take a joint decision with our patients. In such pre-gestational patients, the postnatal care is also very important because there is increased chances of hypoglycemia in the babies, and it's in mothers also when they breastfeed. So they have to be given snacks before feeding. These type 2 diabetes who are breastfeeding had resumed. They have we can start we can shift them from insulin to metformin or the oral ones immediately after birth, and stress the importance of contraception because they are now receptive, and giving them contraception, and also if we can convey the importance of preconceptional sugar monitoring, optimizing in this pregnancy only about their future pregnancy, then it would become an opportunistic counseling, and our patients would understand the importance of it very nicely. Now in GDM, if the patient is diagnosed with diabetes for the first time during this pregnancy, we are going to increase the monitoring. If GDM is either not detected or not well controlled, then there is increased risk of serious adverse birth complications. So we have to diagnose it and monitor the sugars to avoid sugar dystocia, macrosomia, polyhydramnios, because polyhydramnios will also lead to PROM, preterm labor, cord prolapse, and even the neonatal morbidity. So we need to monitor the GDM patients also very critically. They are known to have preeclampsia along with GDM. So starting ecostream time and monitoring for preeclampsia, giving high doses of calcium, all these things become important. Hypothyroidism has also been associated with GDM, so we need to diagnose it, repeat the TSH levels again mid-trimester, and rule out hypothyroidism to rule out the related complications. Now, these GDM patients, they have 3 times higher chances than non-diabetics. We have to give antenatal steroids. After understanding that our sugars are going to go haywire, but still for lung maturity, steroids are important. Dexamethasone 6 milligram 12 hourly, 4 doses are WHO has recommended it over betamethasone, and we need to have more vigilant monitoring during these 48 to 72 hours when the sugars are going to increase. If necessary, we have to add insulin and tocolytics. As tocolytics, nicotine is of choice, but beta-mimetics have to be avoided. And for neuroprotection, magnesium sulfate is very much recommended. 4 grams IV stat and then 1 gram per hour for 24 hours with the help of infusion pump should be given for neuroprotection of these preterm babies. Now for macrosomia, we need to have growth assessment. Only one single scan which showed suddenly that the ACE is above 75th percentile, then that is not a good parameter, or that's not the more sensitive. So we have to have serial scans And there we have to understand that whether the baby is really having growth above 90th centile. So proper growth chart would confirm the diagnosis, and if the baby weight is really coming above 4,000 to 4,500, we have to plan elective LSAS. These babies also need surveillance with Doppler because these babies are again prone for stillbirth and some fetal distress at term acidosis, so we need to monitor them. Polyhydramnios, yes, 10 times higher risk in poorly controlled diabetes because of fetal polyuria, there are anomalies, decreased fetal swallowing, and fetal glycosuria that causes irritation of amnion. And this may lead to preterm labor and PCROM, maybe sometimes sudden cord prolapse. So we need to monitor these and we have to do control ARM after fixing the head if such lady is in labor. Overdiabetes has definite increase of stillbirth risk, so we have to do the surveillance weekly or bi-weekly in such patients after 32 weeks to avoid any complications. The insulin, the patient who's on insulin, we have to be monitoring the strict sugar levels around labor. The 4 to 5 sugar levels per day are recommended. The insulin we have to change as if the postprandial levels are more than 120, we have to add pre-breakfast 2 units more. If the fasting sugar levels are more than 95, we have to add 2 units or more to the pre-dinner dose. So such way we have to monitor the sugar levels and adjust the insulin dose. The surveillance for macrosomia, FGR, poly or oligo, and preeclampsia we have already done. If there is euglycemia, the risk is not increased. So we can wait till 40 weeks to deliver such patients. All the guidelines say that we can wait in such patients. We should not induce them less than 39 weeks if she is on diet control and if there are no other complications involved. So, the gestational diabetes one, what we would do, we wait till 40 to 41 weeks. That's what the guidelines say. But we are going to decide that what are, if there are complications that we have seen that if there is pre-gestational, we are going to induce or we are going to deliver them earlier. But for these patients who are controlled, we are going to wait. We are not going to have delivery less than 39 weeks. Even ACOG also advised that. So we may not wait till 40 or 41 weeks, but we would have deliveries only after 39 weeks. If she is on insulin and uncomplicated, then the delivery has to be at 39 weeks and plus. So somebody who needs insulin but uncomplicated and good control of sugar, we will wait till 39 weeks. And if there are complications like preeclampsia or any other, or if the baby surveillance is suggestive, then we are not going to wait much on such patients who are on insulin and we would be delivering them earlier than 39 weeks. Now in labor, we have to have a team of expert obstetrician, a good assistant, reliable nursing care, physician for sugar monitoring and advice. Blood bank facilities should be available because we may have PPH, neonatologists to receive these babies and also need to care because they need follow-up later next 48 hours. These babies need good care. Anesthetists should be there because certain complications are sudden and we have to keep our relatives and the patients counseled that what we are having in this particular patient. But sugar levels monitoring in labor is very important. So every 2 hourly we should be monitoring. Treat hyperglycemia because that is detrimental to the neonate. Patient is having less intake during labor. She is also having pain. That decreases the insulin need. Our aim is to keep the sugar levels between 110 to 150. Endocrine Society say keep it less than 120. If it goes more than 120, we have to give IV insulin. If we are planning LSES, elective LSES, then the morning dose of insulin should be withheld and she is MVM since midnight. Fluid management and antibiotics has a very important role. For such patients, we will have admission CTP, then we will have cartograph. We have seen that we want to keep the sugar levels less than 120 or around. Institutional delivery is must, and a close electronic fetal monitoring of these fetuses is mandatory. And we will also have active management of third stage to reduce chances of CPS.
Excuse me, madam.
We have to
1
anticipate
minute more.
CPS in such cases. Okay, ma'am. Anticipate CPS and keep things ready in this particular patients. Neonatal care has to be very vigilant. Early cord camping because they have polysaccharide. Breastfeeding within 30 minutes is very important, and then every 2 to 3 hourly. And we have to do blood sugars of these babies at 2 to 4 hours if the sugar level are less than 44 milligram, because that is suggestive of hypoglycemia. Babies babies need tube feeding or dextrose. We have to keep watch for any cardiomyopathy, and keeping such babies warm and feeding them appropriately to avoid hypoglycemia is very important. And then this patient needs a good postpartum care in the form of detection of any infections like urinary tract, puerperal sepsis, or surgical site infection of episiotomy or cesarean. Breast engorgement, lactation failure is also very common, so we have to be vigilant and give appropriate antibiotics. These patients' need for antibiotics reduced, so we have to withhold insulin and shift on oral, and even the oral doses are less, so we need to monitor the sugar levels and then adjust the doses appropriately. So this is how we manage these and counsel them that after 6 weeks, repeat sugars are needed, and then that will decide whether they have what is the risk of having GDM later. So we have to counsel them appropriately and give proper contraception in the form of maybe the long-acting reversible contraception which suits them. Yes, COC, we have to be little careful because the microvascular disease is common in these cases. Thank you so much for patiently.
Thank you, madam. Thank you very much for your elaborate lecture on GDM.
Thank you,
Early
madam.
detection is very important, and to control the GDM, and very frequent visits and strict vigilance on such patients is important. Thank you very much. We are giving you the e-trophy. So
So
accept
kind
it.
of you, and thank you.
Thank you so much,
Thank you so much.
chairpersons, for conducting
And I again would like to thank Solapur Society. Thank you so much, chairpersons.
Thank you.
Thank you so much, chairpersons, for conducting the session so smoothly. I request Anjali Jama madam to be on stage to felicitate our chairpersons. Guram sir and Milinsha sir, please. Milinsha sir, please felicitate Dr. Rakhi Sada from Latur. Guram sir, please felicitate Dr. Madan Kamble sir. And please felicitate our very own Dr. Lalita Shittori, madam. Thank you so much. We move on to the next session now.
I request Dr. Rachna Jaju and Dr. Prajakta Shitore madam to chair the session. Dr. Rachna Jaju is practicing gynecologist at Latur, conducted many papers on adolescent health. Dr. Prajakta Shitole is a consultant at Balaji Nursing Home, dynamic person of our own society. Over to you, ma'am.
Good afternoon, everyone. At the outset, I would like to thank Solapur OBGY Society, especially Anjali Jama ma'am, Monica ma'am, and Dr. Pratibha Baldava ma'am for having Latur OBGY Society over here and making us a part of this prestigious conference. It is my proud and privilege to introduce our speaker today, Dr. Jyoti Banglowala ma'am. She has 26 years of experience. She is Vice President of Indore OBGY Society, and she is interested in ethical and medical legal aspects of obstetrics and gynecology, executive member of IAEC, executive member study of female breast committee 2017 to 2022, executive member in practical obstetrics committee 2021 till present. She is IMA representative for MTP committee Indore, treasurer AICOG Indore, coordinator of medical legal workshop at AICOG. So much and so to add. She is also recipient of the prestigious Wonder Foxian Award in 2019, and she also received Indore IMA Corona Warrior Award by MP government, recipient of Nari Shakti Award IMA Indore branch 2022. She has published many papers and conducted various educational and awareness camp and is invited as faculty in many national and international conferences. So please welcome Dr. Banglowala ma'am.
Hello. I want to thank Dr. Monica, Dr. Anjali, Dr. Archana, Dr. Shah for inviting me. And post lunch, this is a very theoretical talk, so I apologize in advance for this particular talk. So today my talk is neuroxytocics. And as you know, oxytocics are the chemical compounds that increase the tone and contraction of smooth muscle of uterus. It intensifies uterine muscle contraction during labor and postpartum period. So, why we are talking about this oxytocics? Because PPH in India, it is prevalence at 38% and it accounts for up to 56% of maternal deaths in India. And so, WHO recommends active management of third stage of labor for prevention of postpartum hemorrhage. So again and again, since we were student of PG student, since that time we are reading about oxytocic, and at this age also we are reading about the oxytocics. There are, as you know, active management of third stage of labor. It is bimanual uterine massage and uterotonic agent administration. And oxytocin in every PHC, every CSC, Pitocin is the gold standard for the PPH. But during cesarean section in the third stage of labor for vaginal delivery, we use oxytocics. But Pitocin, now it is time to ban the Pitocin from the government of India. Causes of PPH, one and only cause is atony. May it be due to fibroid, uterine inversion, atonic uterus, over-distended uterus. There are so many causes, twins, eclampsia, twins, primipara, multipara, nullipara, everything you say. The infertility patient becoming pregnant at the age of 42, 43, it is PPH. Primipara patient becoming pregnant at the 16, 17, 18 years of the age, she lines up in the PPH. So, multidisciplinary organ saying PPH kabhi bhi ho sakta hai. So, we need uterotonic in prevention of the PPH. There are so many drugs, uterotonic drugs. Posterior pituitary hormones and analogs like oxytocin and carbetocin, ergot alkaloids like ergometrin and methylergometrin, prostaglandin and analogs like PGE2, misoprostol or carboprost. Still, oxytocin considered as the gold standard treatment for the prevention of the PPH. But oxytocin is short-acting drug. Its duration of action is 15 to 20 minutes and half-life is 4 to 10 minutes. It must be administered as a continuous intravenous infusion to attain sustained neurotonic activity throughout the surgical process. Oxytocin is used for inducing and augmenting labor. So, it may desensitize the oxytocin receptor, thereby impairing oxytocin post-delivery effect on uterine contractibility. So, we need uterotonic agent which is superior than the oxytocin. Drawbacks of the oxytocin is antidiuretic effects due to structural similarity to the vasopressin, failure of PPH prophylaxis, stability and quality issues. Pregnancy and labor increase risk of the hyponatremia and water intoxication due to the osmoregulatory changes, impaired ability to excrete water load during labor and increased secretion of antidiuretic hormone during labor. Other than this, oxytocin misuse. It has over the past decade been used in the dairy farming where its properties as a lactation enhancer have been used to increase milk production amongst the milch animal. So, the farmers to increase the size of and speed up the ripening, conversion of the starch to sugar process and fruit and vegetable also. So, Government of India banned oxytocin. In April 27, 2018, it is banned and prohibited private sector companies from manufacturing and distributing oxytocin for domestic use. The other uterotonic agents other than the oxytocin are ergot alkaloid, symptometrin, ozone, misoprostol. Every PG student, every doctor know about the oxytocin, ergometrin, misoprostol and carboprost, but the concern with available uterotonics are they require spatial storage condition, 2 to 8 degrees centigrade, cold chain. If not maintained, it rapidly degrade and become ineffective and it associates with the side effects. The need of an hour, longer acting drug should be there, single dose of administration with no variation in dosage regimen. ऑक्सीटोसिन आप जाएंगे पीएससी में कोई 5 यूनिट देगा, कोई 10 देगा, कोई 50 यूनिट तक चले जाते हैं. राइपनिंग ऑफ यूट्रस के लिए, इंडक्शन ऑफ यूट्रस के लिए स्टार्ट करते हैं 2.5 से और पहुँचते पहुँचते 15 तक जाते हैं जब तक फीटल डिस्ट्रेस नहीं होता है. और आउटसेट ये रहता है कि आफ्टर डिलीवरी जब पीपीएच होता है तब वो ऑक्सीटोसिन यूज़ में ही नहीं आता है. जब आप पिटोसिन देते हैं तो कोई यूज़ ही नहीं हो पाता है. आप पहले इतना पिटोसिन उस पेशेंट को दे चुके रहते हैं. तो एक ऐसा डोज, एक ऐसा स्ट्रक्चर मॉलिक्यूल ऐसा होना चाहिए जिसका एक सिंगल डोज ऐसा हो जो यूनिवर्सली एक्सेप्टेड हो. ऐसा नहीं कि किसी ने 5 यूनिट दिया, किसी ने 10 दिया, किसी ने 15 दिया. Superior efficacy or similar efficacy as that of the oxytocin and devoid of receptor desensitization and superior side effect profile over oxytocin. So what is carbetocin? Carbetocin is a synthetic analog of human oxytocin with some structural modification as shown below. This structural modification increases half-life of carbetocin, thereby prolonging its pharmacological effect. How it works? It's oxytocic, uterotonic and anti-hemorrhagic. It causes slight thickening of the blood also. So there are many studies going on in the India, Canada and US. Especially there is one champion trial. So I just switching off to the champion trial. One more thing, carbetocin has been added to the WHO essential medicine list of the uterotonics for the prevention of excessive bleeding after childbirth. Everybody is saying now ban to the pitocin and accept carbetocin. And what is its composition and indication? You know, in the just after the cesarean section or delivery, and carbetocin comes in the 100 microgram and water soluble, water for injection. And prevention of postpartum hemorrhage due to uterine atony is the one indication, but nowadays we all are using in the normal labor or after cesarean section also. There are some contraindications for this also during pregnancy and labor. Before delivery of the head, carbetocin must not be used for the induction of labor. If there is some hypersensitivity to the carbetocin or oxytocin, it must not be used. If there is hepatic or renal disease, it should not be used. Serious disorder, it should not be used. And it is to be used with caution is the hypersensitive patient or taking antihypertensive drugs. In epilepsy and in eclampsia, clearly no. There are many adverse effects also for this composition. If IV administration is given, headache, tremors, hypotension, flushing, nausea, vomiting, abdominal pain, pruritus and feeling of warmth. If IM administration, then anemia, headache, dizziness, tachycardia, hypotension, chest pain, nausea, abdominal pain, vomiting, back pain, muscular weakness, chills, pyrexia and pain. Only 3 years is just 3 years went, and in 3 years only this side effect with very less studies are there, but adverse events observed with the carbetocin during the clinical trials only, where the same type of frequency as the adverse event observed with the oxytocins. It is studied worldwide in Europe, America, Asia and Africa. There are so many clinical evidences, but this trial, particular trial is went in the India, where heat stable carbetocin versus oxytocin to prevent hemorrhage after vaginal birth. And these are few centers in the India, in Cuttack, in many medical college, Karnataka, Lingayat, Jawaharlal Medical College, BM Patil Medical College in Karnataka, and Medical Research Foundation and Daga Women Hospital, Maharashtra, the Department of OB-GYN, Institute of Medical Science, Banaras, Hindu University. So we depend upon this particular champion trial rather than the Canada or Europe trials. Carbetocin proved to be non-inferior to oxytocin with ease of single dose administration. It is conducted by WHO Department of Reproductive Health and Research across 23 sites in 10 countries including India. Its objectives were to compare the effects of heat-stable carbetocin with those of oxytocin on postpartum hemorrhage after vaginal birth. It designed international randomized multicentric double-blind active controlled non-inferiority trial, and primary outcomes are proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents, and proportion of women with blood loss of at least 1000 ml. So results are 29,645 women underwent this randomized trial. Room temperature stable carbetocin 100 microgram administered immediately after vaginal birth in 14,823 normal deliveries and 40,822 vaginal birth. Immediately after vaginal birth, oxytocin was used. Results are room temperature stable carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml. No significant difference observed between the two groups in other measures of bleeding or any other adverse effect. So this is the AICOG 2019, where superiority of carbetocin over oxytocin was discussed in AICOG 2019, and after that many of us gynecologists are happy to use this particular molecule. This is by Dr. Uma Pandey. There are so many clinical evidences, carbetocin versus oxytocin, where conclusion is carbetocin was an effective and safe as oxytocin for prevention of PPH in women undergoing vaginal delivery. Carbetocin versus oxytocin in cesarean delivery, where carbetocin is effective in reducing the use of additional uterotonics, reduction in PPH and transfusion when used during cesarean deliveries. Carbetocin versus centometran in cesarean delivery, it is more potent long-acting oxytocin with less need for other additional uterotonic drugs and less occurrence of uterine atony. Carbetocin versus misoprostol, because many gynecologists in PSC level, they use misoprostol just because the tablets are handy, but this is not room temperature stable. Misoprostol loss is potency when it kept in the room temperature. And following were the significantly lower with carbetocin compared to misoprostol. Incidence of PPH, reduction in the hemoglobin level and blood loss, duration of the third stage of labor, and incidence of the side effects. This is the Cochrane review for this particular molecule. And now the guideline recommendations. Room temperature stable carbetocin does not require refrigeration. Therefore, elimination the cost associated with refrigerator storage and transport for non-room temperature stable uterotonics. The use of carbetocin is recommended for the prevention of PPH for all births in context where its cost is comparable to other effective uterotonics. So conclusion of SOGS reinforces use of carbetocin as the first line uterotonic for prevention at the cesarean delivery or vaginal delivery with one risk factor. The summary is carbetocin is superior over oxytocin with respect to prevention of PPH, blood loss after delivery, need of additional uterotonic agents, deviation in hemoglobin levels, need of blood transfusion, perception of pain, side effect profile. Carbetocin is superior over ergot alkaloid with respect to prevention of PPH, blood loss, need of additional uterotonic, need of blood transfusion, better side effect profile. And in compared to prostaglandin analogs, same, but the drawbacks of prostaglandin analogs are more, so it is used as the second line agent. So management of the third stage of labor during vaginal delivery in patient with singleton delivery, in patient with high risk pregnancy, in cesarean delivery, in patient with elective C-section delivery, in patient with high-risk C-section, in patient with twin pregnancy. You can use everywhere carbetocin. Carbetocin is proved to be superior over oxytocin and other uterotonic with respect to prevention of same, everything is same, low side effect, and the loss of prevention of PPH and estimated blood loss is always less. So it is long-acting structural analog of oxytocin. It administered after delivery of infant as soon as possible after delivery, preferably before delivery of placenta. If there is Dr. Vandana Gandhi madam, she was just saying कि carbetocin लगाने के बाद लगता है placenta किसी ने bloodless करके हाथ में दे दिया है. So everybody experiences the same. And room temperature stable formulation eliminates cold chain barrier to use in low resources setting. Single IV injection of carbetocin achieves uterine activity within 2 minutes and lasts approximately 1 hour. It does not require prolonged infusion owing to its longer half-life. Less additional uterotonic can be used and similar safety profile to oxytocin and better tolerated than ergot alkaloid. Thank you. And this particular few slides are provided by few pharma people, but pharma people as usual they don't provide the side effects or contraindication, anything they don't provide. They only say room temperature stable है, इसको use करना है, use करना है, use करना है. But everybody should know epilepsy, eclampsia, hypertension, CVS इसमें use नहीं ही करना है. काफ़ी बार वो लोग उसको कहते हैं पिटोसिन से रिप्लेस करने के लिए, पर स्टिल द गोल्ड स्टैंडर्ड इज पिटोसिन इन मैनी प्लेसेस. बट अभी जैसे गवर्नमेंट ने बैन किया है प्राइवेट सेक्टर के लिए, तो अभी वो कॉस्ट इफेक्ट के भी कार्बिटोसिन आए हैं, फेरिंग्स एंड इन सब चीज़ों के 25-26 रुपीज़ के आते हैं. बट जस्ट वी शुड नो आफ्टर डिलीवरी ऑफ एंटीरियर शोल्डर, उसके बाद ही कार्बिटोसिन नॉर्मल डिलीवरी में लगाना है. थैंक यू वेरी मच. थैंक यू.
Thank you, ma'am. There's one question. With all the available drugs for prevention of postpartum hemorrhage, people are just keeping on adding in the basket because they are using pitocin also, prostadine also, they keep misoprostol per rectally, and then now they also give carbetocin.
After using everything, and when we use the carbetocin, it will not affect. It is not effective as it is effective if given in the first line of treatment, because oxytocin desensitizes the uterine muscles.
Ma'am, actually, I wanted to ask what are the oxytocins you can give, the time period between first dose of carbetocin and if you want to add another oxytocin.
This champion trial and the one trial is going on in the Canada. They say only 1 dose of carbetocin, not more than 1. Yes.
Yes. Yeah.
No, Supriya, no. They are saying that it's...
If you want to add methogen or if you want to add some other oxytocin like
yes. though its half-life is more, carbetocin half-life is more, so she is saying right, but the carbetocin dose should not be repeated.
And you can add methyl ergometrin. That's the beauty, because methyl ergometrin is a different group. So you can use methyl ergometrin with carbetocin. It's not a replacement for methergine. It is.
I have seen one case where the pitocin drip is going on and PPH happened, and that particular gynecologist added carbetocin in the same drip.
That's not right. Actually, the advantage, if you are like many a times patient is on pitocin when she's delivering, and then it's supposed to be 15 minutes you stop the pitocin drip and then give carbetocin. Let the receptors, oxytocin has a short half-life, so the receptors become free faster.
I think many times what we confuse is between active management of third stage of labor, which is for prevention of PPH, and treatment of PPH, which is a different thing.
Yes.
So this carbetocin and oxytocin.
This is the prevention is better than cure.
So active management of third stage of labor is prevention of PPH, when we are going to give the medicines before the PPH starts. Whereas prostodin or misoprost or even acting methyl ergometrin, which we are going to give as a treatment of PPH. So carbetocin and oxytocin now basically
in morning someone was saying
as active management of third stage of labor, where we are going to prevent PPH. The blood loss in normal delivery is going to decrease. So carbetocin and these two things, they are advocating for prevention of PPH, and methyl ergometrin, prostodin and misoprost, they are for management of PPH, or it should not occur afterwards.
Someone was saying in morning, we all are running the solo clinics, so anesthetist, resident, gynecologist, physician, everything the one same person. So that's why prevention is always better for the solo clinics. आप multidisciplinary hospital में काम ही नहीं कर रहे हैं, तो आप risk लेने से better है कि you try to switch off the another drug other than the pitocin.
Thank you, ma'am.
Thank you, ma'am, for your inputs. Thank you, Doshi sir.
Thank you everyone.
We move on to our next lecture. It's on pelvic floor injury during vaginal delivery or optimal repair of third and fourth.
Hello, I request our chairperson, please felicitate Dr. Jyoti Banglowala. Dr. Milind Shah sir and Anjali Jamma and Dr. Guram, please join on stage.
गुर्रम सर तो बहुत मारेंगे, बनाया तो बहुत बड़ा लेक्चर रहता है, लेक्चर बहुत बड़ा बना के स्किप करते हैं, कितना 10 मिनट हो जाता है.
We move on to our next lecture by Dr. Parikshit Tang on pelvic floor injury during vaginal delivery and optimal repair of third and fourth degree laceration tear. He is a consultant at Ashwini Maternity and Surgical Hospital Center for Endoscopy and Assisted Reproduction, Mumbai. Consultant at Jupiter, Thane. Honorary Professor of Pacific Medical College, Udaipur. Consultant for Assisted Reproduction at 16 centers. Was a treasurer for FOXY. A PG teacher for CPS College of Mumbai. I welcome you, sir.
Can I be allowed to share the screen? Yeah, thank you. There's something happening with my PowerPoint slides. I can't seem to find them on the share option. Is there someone from the technical team around? Conference, are you there?
Yeah, sir. I've viewed the sharing options. You can share.
Okay. I've kept the PowerPoint open, but for some reason it's not coming up as an option when I click on the share screen. What could be the reason for that?
You have to open your PPT on slideshow and then you can share. Otherwise, you can share your whole window and start your PPT as a slideshow.
Okay, right. I'll try again. No, I still can't do. Thank you. I think there's a bit of disuse of Zoom. So I think I've forgotten how to use it as efficiently as I used to. First of all, thank you very much, Solapur OBGYN Society. It's wonderful to see Dr. Milind Shah, Dr. Guram, the senior members of the society there. And thanks to Monica for the kind invitation to share some thoughts about lower genital tract trauma or birth canal injuries with all of you. Let me begin by this peculiar word. It's tocophobia, and it essentially means an irrational fear of childbirth. And I don't mean this in the general population or in very fussy girls. This is a attitude survey of urogynecologists and maternal fetal medicine specialists. You could say that they are, people who are practicing OBGYN at the highest level. And a majority of these people said that they would rather have an elective primary cesarean delivery over a vaginal birth. What could be the contributory thought process behind this? Yes, of course, the well being of the child, but it's also the worry about injuries to the birth canal, which precipitate these kind of thought processes. So, I'm going to talk about why they happen and what should you do when they happen, because vaginal birth is not going anywhere. Generally, when we talk about birth canal injuries, it essentially means injury to the lower genital tract and perineum. The cervix, the fornices, the vaginal mucosa, perineal muscle, skin, anal sphincter, external as well as internal, and if it goes further, then the rectal mucosa. And injuries to the anorectal complex are divided into first, second, third, or fourth degree. We are all quite familiar with this classification, which has been put forth by the Royal College. And Dr. Sultan was here a few days back, and he did a wonderful workshop. He's done some pioneering work on perineal injuries. So this is essentially what we are talking about today. We are not going to talk about injuries which involve the uterus, such as a ruptured uterus, so on and so forth, or a broad ligament hematoma. That's not traditionally what we call birth canal injuries. Now, the reason why we are worried about these are the implications which birth canal injuries have. And these could be immediate in the form of hemorrhage, traumatic PPH as we call it. There could be shock which comes because of it. In the longer term, it could be sepsis, need for surgical interventions. It could mean transfusions for this woman. And really, if we take a long-term view, these are the points of beginnings of incontinence, both urinary as well as fecal, of chronic pelvic pain or perineal pain, and dyspareunia. So, birth canal injuries have a lot of meaning for this particular woman's life, not only immediately, but even in the long term. This is a study that we did at Wadia when I was an honorary consultant there. And what we found is that approximately 1% of births are complicated by genital tract trauma beyond a standard episiotomy. So they could be cervical tears, episiotomy extensions, or episiotomy injuries, and they could be those which involve the rectal complex. Now, we are familiar that if it's a very big baby which comes out, or one which comes out from a perineum which hasn't been tested before, the position is not favorable. It's a face to pubes or a persistent occipito posterior. labor has been prolonged, induced, there's been epidural, instrumentation, etc. All these are risk factors for birth canal injuries. But we must also accept that most birth canal injuries happen when you don't expect them to happen. They are quite unpredictable, just like the rest of obstetrics, isn't it? So there's no way that you can mark out that, okay, this one is going to have a third degree tear and I need to have the big boss around to help me to suture it. All people who are involved in birth process, all care providers need to have a certain degree of competence in order to see that they recognize the problem and they do what it takes to repair it. So recognition, sometimes it's obvious. It's a visible injury which goes helter skelter into the upper part of the vagina or into the rectal mucosa. It may be recognized because the woman is bleeding, but the uterus is well contracted and you've not traced the cervix immediately. But then you think that, okay, now why is she bleeding? And then the first thing you look for is a cervical tear. It could be because you do a rectal examination routinely, which I strongly recommend. And that's how you pick up that, okay, there is a small tear over here which I need to repair. So once having recognized, your next step is to assess. The first step is to find out how this woman is in general. Are her vital parameters affected because she's bled a lot, already in hypotension? What's her pain level like? Rule out abdominal injury. Though we are going to talk today only about lower genital tract trauma, please look for associated upper genital tract trauma too. There can be a ruptured uterus if you're giving a TOLAC. There can be a broad ligament hematoma once in a while. So you have to make sure that that aspect has been ruled out and then systematically evaluate the genital tract from below upwards, because as you keep mopping, you'll keep finding new things that you need to see. You have to not only see, but you have to also palpate, especially when it comes to palpating the sphincter. That's probably very important in recognizing injury to this part. So having recognized that there is lower genital tract trauma and you've assessed what the problem is, then comes your preparation. What do you need? You need competence. You need someone who knows how to repair that extensive lower genital tract trauma. So you need a trained operator. You need assistance. If you're the trained operator, then you can't do it alone. You'll need to call somebody to help you because you'll need a little more retraction than what you normally need. And you'll need an anesthetist because trying to repair extensive genital tract trauma without anesthesia is itself a very traumatic procedure. It's not only traumatic to the patient, but it's traumatic to the surgeon also, because you're going to struggle. You're going to need to have good exposure in the form of OT lights and a good table, but you'll also need anesthesia to make sure that you can retract to the extent that is needed so that you can stitch in the right spot and you need not keep on struggling and pricking the mucosa repeatedly. So anesthesia, we may hesitate to call, especially if it's been just a normal delivery, everything's going well, everyone's delighted, but this may sound like you're doing a little bit too much, but believe me, I've never regretted calling the anesthetist as a backup. What do you do while the anesthetist is coming, the OT is getting prepared? Pack the vagina tight while you're waiting so that the blood loss is minimized from the pressure. Make sure that your trolley and count are correct. On the trolley, I like to have thin-walled, small speculi and retractors. Vaginal tampon, if somebody is using, then a clip must be attached to it, because you don't want a situation where you've repaired the trauma very well and you stop the bleeding only for the woman to come back 2 weeks later saying that, there's some foul smell which is coming, and then you're stuck in a bad place. Use a suction. Now, this is something which we don't intuitively do when we are doing vaginal repairs, but it's very useful, especially if you've got that big couple of spurters going, one from this lateral wall, one from the episiotomy side, a suction will help to keep all that away, and you'll not have to use mops so much, because the more mopping that you do, the more you're abrading the vaginal mucosa, and obviously you can't use a cautery. You need somebody to adjust the light. And here again, I know it's a joke, but the anesthetic is very, very useful. Some people have tried using an ENT headlamp, and that helps to focus just as you would according to your line of sight. And of course, we only use on needle suture materials. Gone are the days when you use something which is off needle and that eye of the needle itself causes trauma. Those days are gone, of course. Now, what's the surgical plan? How are you going to go about doing all this? Of course, you need to manage the general situation, resuscitate and stabilize the woman. Start from the top of the vagina and the cervix. So if there's a cervical tear, suture that first. Suture whatever is in the fornix. Do the rectal mucosa before the vaginal mucosa. Then you come to the vaginal aspect. So first thing you're going to do is anchor the vaginal aspect and make sure that you've gone beyond that. Then you repair the sphincter, and then sequentially the rest of the vagina, the muscle, the perineal muscles and the skin. So you need to have this kind of like a game plan, so that the best way to do it is stop the bleeding from the uppermost part and then keep working yourself downwards. Resuscitation, already lots has been said about it. I won't emphasize anything on this slide, but let's go straight away to the surgical technique. If you are looking at a cervical tear, then don't use instruments which have a window in them. Like a sponge holder or a Babcock, because if by mistake your needle goes through that window, then you'll have to take the needle out and, take the bite again. So use an Alice forceps or any other tissue forceps, reach above the apex. If you can't find the apex, then go to the point where the apex and the fornix meet. And these are the women whom you have to really rule out a broad ligament hematoma, because you may have some trauma going upwards. People feel that catgut is better over here than polyglactin, but frankly, now I find it difficult to get catgut. So I just use polyglactin all the way through, and this is where I use the regular polyglactin, not the rapid version. Don't close the cervical canal in your enthusiasm of suturing the cervical tear, because that will land you in a different kind of a problem of a hematometra or a pyometra. And use locking sutures of adequate depth and stop just short of the external os, so that you know that you have enough of a canal for the drainage. The other sites you would go on to repair, if it's a paraurethral or a periurethral or the anterior vagina, just below the bladder, then I would suggest that you catheterize this woman so that you know you're not taking the urethra, and use fine sutures, a 2-0 or a 3-0 interrupted stitches to make sure that you've completed the job in the paraurethral region and the clitoral region. When it comes to suturing the vaginal mucosa, it's the direction of the retraction which is important, not the force. Just pulling it very hard may actually be counterproductive. As I said earlier, use suction, mop very gently so as the mucosa doesn't get abraded. Reach above the apex, or if you can't see the apex, take the suture as high as possible and use that suture to draw the mucosa down. You'll see the apex, go one above that. And suture according to the direction of the laceration. An episiotomy is always straight and downwards, but sometimes the genital tract trauma may be in different directions. One tear may be like that, another may be like that. So you've got to go perpendicular to the line in which the tear is. When you're suturing the mucosa, don't prick the blue points. The blue points are bruised mucosa. And there's always some amount of, mini hematoma formation below this. So look for pink mucosa and suture from pink to pink, because then you will prevent that oozing which can happen when you prick a bruised mucosa. At a certain point, you'll have to stop. You may not get the most perfect hemostasis in the world, but raw areas, pinpoint hemorrhages, you'll have to stop suturing them because you just pack and wait after a certain point. Otherwise, there's so much of suture material which gathers there, and every bite that you take, you're going to tear the mucosa some more.
Sir, 2 minutes more.
Okay. Repairing the rectal mucosa, you want to separate it away from the vaginal mucosa and do a tension-free repair. Use 3,0 polyglactin. Interrupted sutures are fine. And then you reinforce the layer of fascia. There are many ways in which you can repair the anal sphincter. The important thing is to identify and identify it very, very correctly so that you grasp both the ends and then bring them together either end to end, or you can do an overlap, that's fine. Then go on to repair the muscle, and I use the deep with polyglactin and the superficial with polyglactin rapid. Close the dead spaces so that you don't get hematomas later. Don't go too deep, otherwise you'll pierce the rectum. And the skin should be closed even after you spend 45 minutes repairing it. It should still be aesthetic. Make it a nice repair, not too tight, and don't close the introitus. The immediate post-op care, look after the vitals, do a vaginal and rectal examination. I always pack the vagina with a roller gauze. This is not for the uterine packing, it's the vaginal packing. Make sure that your count is correct, catheter is in place, provide good pain relief and antibiotics, and a stool softener at least for a couple of weeks. Document and debrief what you've done, and the best time to document is soon after you've done the repair. Estimate the blood loss, and you owe an explanation. You don't owe an apology, but you owe an explanation to the mother as to what exactly happened at the time of the delivery. At the postnatal visit, recommend physiotherapy and perineal exercises. Inquire specifically about incontinence, because if you catch them early, they might get better with specific exercises. Prescribe a non-constipating iron and discuss future plans about pregnancy and vaginal births. I'm not getting into that because that's a separate topic by itself and it merits a separate discussion. They say a labor is a human being's first, shortest, and most dangerous journey. And they often say this for the fetus, but I believe the same is true for the woman and her perineum as well. So here's to repairing and making sure that you get the best out of vaginal birth. Thank you very much, Solapur Society, once again.
Thank you so much. Sir, it was a very precise and a very practical lecture which we need in our day-to-day practice. Any questions from the audience? We would like to felicitate Sir on behalf of the society with an e-memento as a token of appreciation from the society.
Thank you very much.
I request Dr. Anjali Jamma ma'am to please felicitate our chairperson. किया ना Now let's move towards the next session. I request Dr. Pratibha Baldava ma'am, Dr. Smita Yadav ma'am, and Dr. Supriya Birazdar ma'am to chair the session. Dr. Pratibha Baldava ma'am, she is a consultant at Baldava Hospital. She has presented many papers in national and international conference. Dr. Smita Yadav ma'am, she is consultant from Barshi. She is a gold medalist and laparoscopic surgeon. Dr. Supriya Birazdar ma'am. She is a consultant at Birazdar and Krishnamai Hospital. Now I hand over mic to the chairperson.
Good afternoon, one and all. Now we'll start this session. The name itself is Facing the Unexpected and Unanticipated. So our heart rate is already racing. But to take us to three situations, we have two eminent speakers. First, I'll request Dr. Supriya Arwari ma'am to present her talk on cord prolapse and transverse lie. Madam is a consultant obstetrician and gynecologist. She's been trained at KEM Hospital and Wadia Maternity Hospital and St. GS Medical College, Mumbai. She's practicing at Supreme Hospital, Bhiwandi. And right now also you have heard her how she was helping us out through many questions. I request ma'am to please come and take us through the talk. Thank you.
Thank you, chairpersons. So, respected chairpersons and my dear friends, and I believe there are some online participants also. So, am I audible? Am I visible? Great. This very talk is about expecting or anticipating the unexpected, and transverse lie and cord prolapse is my talk. तो अर्ज किया है कि थोड़ा टेढ़ा थोड़ा मेढ़ा, थोड़ा टेढ़ा थोड़ा मेढ़ा, यही ऑब्स्टेट्रिक्स का नाम है. हर बोरिंग पल को चटपटा बनाना यही ऑब्स्टेट्रिक्स का काम है. So when you are going through life, sailing through life, conducting delivery after delivery, one delivery will come and stump you and make you wide awake. So I hope that has made all of you wide awake after having such good lunch and lots of sweets. Dr. Milind Shah, my dear friend, Dr. Anjali Jamma and Monica and entire team of Solapur OBGYN, I am extremely indebted to all of you for allowing me to stand here in front of this august audience. So, I'm sorry if you don't like my honesty, I'm going to be very honest here. But to be fair, I don't like your lies, especially the transverse ones. Now, what is transverse lie? The definition is when the long axis of the fetus lies perpendicular to the maternal spine or to the centralized uterine axis, it is called transverse lie. A very, very simple definition, equally difficult to manage. We have 4 different positions: the dorso-anterior, dorso-posterior, dorso-superior, dorso-inferior, and I'm sure this is all undergraduate revision for all of us. What are the important points here is that in the dorso-anterior position, the flexor surface of the fetus is better adapted to the convexity of the maternal spine, and that's why this is one of the commonest presentations in transverse lie, the commonest position rather. In dorso-superior, the fetal small parts and the umbilical cord are present at the cervix, and therefore these are the ones who are going to be extremely prone to hand prolapse and cord prolapse. And in the dorso-inferior position, the fetal shoulder presents at the cervix. Depending on the position of the fetal head, it can be either right or the left position, and the right position being more common because we have the transverse colon on the left side of the mother. Incidence around 1 in 300 births, so fairly common if you are talking about an institute, which is especially a third degree referral institute. It is more common in premature babies, in dead babies, especially if they are macerated, 5 times more common in multipare and in abnormal presentations and lies. What is the basic etiology? We all know, again, revision, multiparity, prematurity, because fetus is so small, lots of space, baby is doing his usual circus inside. Twin gestations, especially in the second twin after the birth of the first vertex twin. Polyhydramnios, a contracted pelvis. Placenta previa, basically because it doesn't allow the presenting part to descend down. Pelvic tumors, congenital anomalies of the uterus, especially septate and arcuate. I'm sure many of us have come across the uterine anomaly when we are actually doing the cesarean section for a transverse line, not previously diagnosed. Or intrauterine death. How would you diagnose? Abdominal on inspection itself, there will be something amiss. The normal sweet pyriform shape of the uterus will be missing. It's usually, elongated in the transverse direction. The fundal height may look smaller than what you actually anticipate. On palpation, the fundal grip is going to be empty. The pelvic grip is going to be empty. Okay. In the lateral grip, depending on whichever side is the head or the breech, you will palpate either a hard globular structure. And often you ask the mother, do you feel something hitting you here? And often they say, yes, I can feel something hard when the baby moves. So usually the head is on that side. Okay, and the pelvic grip is going to be empty. Auscultation, fetal heart rate, usually we, find that in any kind of abnormal presentation or lie, the fetal heart rate is going to be more towards the umbilicus and more higher up compared to, in the cephalic presentation, where we will find locate the fetal heart down below in the lower pole of the uterus. Of course, a sonography, if possible, if patient is in labor, you can do it in the labor room very well, or maybe an X-ray if it is like diagnosed before onset of labor, will be definitely, diagnostic of the diagnosis of transverse lie. Vaginal examination, if patient is not in labor, you will find that the lower pole is empty, the cervix is really highly taken up, and you cannot really feel any presenting part, or you may feel some soft part, maybe the limbs or maybe the shoulder. During labor, obviously when the cervix has dilated, there may be elongation of the bag of membranes, but again the membranes are going to be empty, or there may be some small fetal parts, or even worse, cord loops present. The shoulder may be identified on palpation, if at all, by trying to palpate the various structures of the fetal shoulders, or in a worst case scenario, maybe a prolapsed arm. What is a clinical course of labor? Okay, like this picture, turn baby turn, but it's not going to happen. So there is no mechanism of labor in transverse lie. That is it. That ends the matter, or maybe I can just end my talk here. But then what are the things that I would like to tell you? First and foremost, average size baby is not going to pass through the pelvis in a transverse position. So that is the end of the matter there. And most probably these patients, especially if they are, trying to deliver in a rural setup or in peripheral area, then by the time they present to us, they come with one of these very unfavorable events, which are the most common, that is pre-labor rupture of membranes, a hand prolapse, or with a loop of cord, so cord prolapse or hand and cord prolapse, ascending infection due to prolonged labor, the hand is or the prolapse, and ascending infection has taken place, and patient is in badly obstructed labor. There may be pathological retraction ring, maternal distress, sepsis, and either impending or actual rupture of the uterus. Favorable events, very rare, that is spontaneous rectification or virgin, spontaneous evolution and spontaneous expulsion. These are very rare and can only occur when the baby is extremely premature, very small size baby, or when the baby is dead and macerated. Okay, what is spontaneous rectification or virgin? Usually occurs in early labor if there is a lot of liquor and it's a small baby. The baby is mobile with contractions. Usually the baby's head is forced towards the lower pole. So if the head is forced, it is called as rectification, and if the breech comes down, it is called as virgin. And this can occur only when there is a lot of fluid, or the baby is very small and lot of place for the baby to retract, to change position, and usually will happen in multipara. Very difficult to happen in primipara, obviously, because tone of the uterus and the tone of the abdomen is going to be good. Spontaneous evolution, this is something that I have seen only once in my lifetime. That too, like I said, it was a really premature baby. The arm is usually prolapsed, then the head lies in one iliac fossa. The trunk and breech are forced into the pelvic cavity. The neck is elongated, so you can imagine what is happening. The baby's head is stuck somewhere and the rest of the body comes out. The breech and trunk are expelled, followed by delivery of the head. And this requires very strong contraction and a small baby. Spontaneous expulsion also I have seen in a macerated baby. Of course, I don't know whether anybody from the floor has seen what we call as a conduplicato corpore. Means the baby turns on his trunk axis. So the thorax and the abdomen are opposed to each other, and the baby comes out like, like you fold a cloth or something in that way. So this can only occur if it's a macerated baby. Otherwise, it's very difficult to take place. Now, what is the management? Transverse lie with intact membrane and live fetus. Now, if patient comes to us just before onset of labor or maybe in early labor, please take this as a disclaimer. I have personally never done external cephalic version, and I am not encouraging it from this platform. I am just completing the list of what can be done to manage a transverse lie, and maybe Sir Desai madam's time this must have been done several times, but in my lifetime I have never dared to do an external version in a live baby, full term baby with transverse lie. However, in absence of contraindication for vaginal delivery, we can perform an external cephalic version at approximately 37 weeks. If the transverse lie recurs, you can repeat the process at 38 or 39 weeks and then induce labor, and if it fails, straight away go for a cesarean section. In early labor, again, if the patient is in transverse lie with intact membranes, you can try external version at your own risk. If it is successful, maybe and the cervix is adequately dilated, you do an amniotomy and allow labor to progress, and if unsuccessful, do a cesarean delivery. Approach in active labor, patient actively in labor with a transverse line stuck there, perform a cesarean delivery, and I unabashedly say I belong to this school of thought. Not worth taking the risk of doing a version and probably land up with a rupture of the uterus or maybe a cord prolapse. Now, what everybody knows, transverse lie cesarean. This is something that will probably sum up the entire reason why I am standing here. What are the tips and tricks that you will do for a LSCS when you are dealing with a transverse lie? What is going to be different than maybe any random cesarean? The presentation, position and attitude of the fetus should be confirmed by palpation or better by transabdominal sonography. Very easily said than done. Most of us work in single standing nursing homes where sonography facilities may not be available. By the time patient comes to us, she is in active labor with strong contraction, the liquor is all gone, and you just cannot make out the head from the toe. And then you have to take up a cesarean. So it is always better if you can map out where is the head, where is the breech, and where do you expect the limbs. Should be done by skilled and experienced surgeon. That goes without a say. Anticipate the possibility of trouble and seek for an experienced assistant. Like Parikshit said, if you are the experienced surgeon, then you cannot do things alone. You need a good assistant, and it always makes sense in such situation, call and qualified assistants to, always help you out. 2 brains and 4 hands will always work better than single. Transverse incision to be taken, or maybe even a subumbilical vertical midline incision, depending on whatever you are comfortable with. When using a transverse incision, fan style incision 3 to 5 centimeters above the pubic bone should be used. Incision on the lower uterine segment should be liberal, or in case sometimes because of the transverse lie, the lower pole is not well formed, you may not have enough place, so you can easily take a T-shaped or a J-shaped or an inverted T-shaped incision. Don't be worried about suturing a T-shaped incision or a inverted T or a J-shaped incision. We have to have an adequate incision. It is better to take a planned inverted T than having to suture a tear which has gone down straight into the bladder. So take a good adequate incision. Feel for the back of the baby and trace the back and try to hold the feet. Okay, the best way. It is very difficult to go and try to rotate the vertex, but when you get to the feet of the baby, this is all what we've learned. It's very easy to grasp the baby. The podalic pole of the baby is smaller, so it's easier to turn. Grab the baby's feet and try and pull the baby's feet into the incision. Try to convert it into a breech presentation. Okay. Carry out internal version and deliver as a breech. Now, if baby's hand comes out, which is very often, you open shoulder and hand pops out, try to reposit the shoulder back inside and again go reach for the feet. And once you find the shoulder, you can help, use the shoulder to trace the back, go to the feet, grab the feet and get the baby out. Risk of complications such as injury to the cervical canal, vagina, bladder, ureter, and massive hemorrhage have to be kept in mind. So all resuscitative techniques that you would do in an anticipated PPH should be done, like having 2 large bore needle catheters going on both sides, keeping blood cross-matched and ready. All these things should be done pre-op. And a neonatologist should be there in attendance to revive and resuscitate the baby, because more often than not, the baby is going to come out in a bad shape. Already if she is in prolonged labor, baby is already doing badly. In addition, when you are trying to deliver, even in a planned section, cross your heart and tell me how many of us have not landed in problem. Even in a planned transfers, sometimes to deliver the baby, it takes time and baby is likely to come out hypoxic. Transverse lie in a second twin after delivery of the first twin. If it is a small size baby, usually already a fully dilated cervix, you can try an internal podalic version followed by a breech extraction. However, never shy away from doing a cesarean section if required for the second twin. It does not hurt your ego कि मैंने पहला normal करके दिया और दूसरे के लिए खाली Caesar किया. No, it is better than losing the child or worse, giving some bad complications to the mother. So if required, you can always do a cesarean for the second baby. Transverse lie with fetal demise or a very, very pre-viable fetus. Already we've spoken about it. Either one of the three, either there is some spontaneous rectification or, it comes folded on itself. So you can allow the baby to, the labor to progress. But if it is a full-term baby, and even if the baby is dead, I would still be worried to wait for a spontaneous evolution. At the least, I will at least try an internal podalic version. Cord prolapse, brother and sister of transverse lie. It is defined as a descent of the umbilical cord into the lower uterine segment, where it may lie either adjacent to the presenting part or below the presenting part without intact membrane. So the membranes have ruptured, that is cord prolapse. If the membranes are intact, that is cord presentation. Now this is one of the very common cause of fresh stillbirths. It is one of the obstetric emergencies seen in maternity where timely delivery is the hallmark of good treatment. And in many developing countries like ours, especially from rural area, when the referrals take place to bigger places where there is no equipment for cesarean at a certain setup and then patient has to travel, this is where majority of the patients and their babies are going to land up with trouble. Incidence, cord presentation, very difficult to make out the presentation because it can only be diagnosed if you are very vigilant about the fetal heart rate, decelerations, variable decelerations, so difficult to make out. But overt cord prolapse between 0.1 to 0.6% of the general population, of which only 0.5% happen in actual cephalic or frank breech presentation. But in case of complete breech, up to 5% cases can land up with a cord prolapse, footling breech 15%, and in transverse lie, around 20% babies will land up with a cord prolapse. So, 1 in 500 pregnancies, again, for a big institute, it's a big number. In a small nursing home, probably you might see 1 or 2 cases in a lifetime. The risk of death of the baby is written 10%, I would put it at 50% actually. Recent studies have estimated that 77% of the cord prolapse occur in singleton babies. Remember, we usually don't anticipate in singleton babies these kind of complications, but we should always be aware, especially when the presenting part is high up. Twin pregnancy is obviously very common and more so in the second twin. Occult cord prolapse, we've been through it when actually the membranes are not yet ruptured. Either the cord is adjacent to or below the presenting part. And if you are very vigilant and she's in labor, os is open, you can maybe palpate the cord pulsations, but before labor it's really very difficult to make out, and maybe if you are doing a routine NST and you find variable decelerations, you could suspect. Actual cord presentation, prolapse of the cord below the level of the presenting part, before the rupture of the membranes. This is the cord prolapse presentation. And this again, if she's in labor, we can find out. If not, we cannot. Overt cord prolapse, that is everybody's nightmare. Umbilical cord is below the presenting part. The membranes have gone and the cord is either lying in the cervix or the vagina, or worse, outside the vagina. We've already been through this. Okay, in overt, now this is something that is of main concern for us. Descent of the umbilical cord past the fetal part, and it is right there in the cervix or the vagina. Now, etiological factors, malpresentations and any fetal factors where baby is either in
Excuse me, ma'am. We'll have to rush a bit through the
Okay.
presentation.
How much time do I have?
2 minutes more.
Yeah, I'll finish in that time. So malpresentations, prematurity, multiple pregnancies, maternal factors like CPD or a high presenting part, cord and placental factors. Iatrogenic is what we should be extremely wary of, because that is preventable cord prolapse. Where ARM is done with a mobile high presenting part, done by a junior resident or somebody unexperienced like the nursing staff. Virgin or manual rotation, we just spoke about it, can lead to cord prolapse. Okay, and disengaging the head to facilitate rotation. Now, believe me, I never do all these histrionics, but I'm sure there must have been old timers who did these kind of things where you try to disengage the fetal head and try to rotate it, and the first thing that comes into your lap is the cord. Fetal factors, we've already been through. Maternal factors. This is something that we should always note. Some authorities speculate that cord abnormalities like true knots or low content of Wharton's jelly can, and also fetal hypoxia, if patient is in prolonged labor, this can alter the turgidity of the cord and predispose to prolapse. Okay, procedure related, amniotomy, external version, internal version, induction of labor with a high presenting part, applying fetal scalp electrodes, amnio infusion, and placement of a cervical ripening balloon catheter. All this can predispose. Consequences, obviously cord compression, yes, but also when the cord falls out and is exposed to external atmosphere, there is vasospasm of the umbilical vessels, and that can lead to asphyxia in the hypoxia in the baby. Okay, let's go to this quick chart which tells you how you can diagnose. Occult, meaning membranes are intact, patient not in labor, os is closed, but there are some variable deceleration on the NST, you would suspect a occult cord presentation. Actual cord presentation, on PV you can find that the os is open, you can feel pulsations of the fetal cord. Remember, they could be your own pulsations. Also, due to vasospasm, the cord pulsations may not be felt, and you may think it's a dead baby, but actually baby may be alive. So if you want to palpate the cord pulsation, wait for the contraction to go so that there is little relaxation of the uterine musculature, and maybe you can feel the cord pulsations. In overt cord prolapse, it is there, right there for you to have a look at. Cord pulsations, you would like to see whether baby is dead or not, because according to that our management will proceed. Maternal prognosis, usually if we just allow the baby is dead and allow the labor to progress, it will be like any other labor for the mother. However, if baby is alive or we try to do some high risk procedures, then maybe mother will end up either with an operative delivery, anesthesia, blood loss, infection. Fetal prognosis is going to be pretty bad if it is a cord prolapse already. There is a higher risk of cephalic presentation, completely dilated cervix, and the head is high up, more likely, because the head is very hard, it's going to compress the cord much more than the breech. So the prognosis is going to be worse in a cephalic presentation. Management, now this is what we all should be more concerned about. Occult prolapse, immediately rule out, do an ultrasound. If you suspect, do an ultrasound. Oxygen, left lateral position. After change of position, if the decelerations are gone, you can still wait and allow the labor to progress. If not, then maybe straight away go for a cesarean section. At term, cesarean section prior to rupture of membrane. Rupture of membranes is going to land the baby with 50% mortality. So let's do it at a better time. If there is a premature baby, now here there is no consensus, it is going to vary from baby to baby. If you feel baby is viable, you might as well do a cesarean section if she comes in labor with cord prolapse. But if it is a cord presentation, maybe you can try some conservative procedure and try to take her to as close to term as possible. Speed is the essence of perinatal outcome, and this is largely dictated by the diagnosis delivery interval, and studies have shown that if the diagnosis to delivery interval is less than 30 minutes, the fetal outcome is going to be fairly good. And meanwhile, what are the main targets of our management? Prevent or relieve the cord compression if possible. Ask the assistant to push the head up while you prepare for a cesarean section. Ask him to push the head up so that you can relieve the cord compression. Secondly, like I said, exposure to external atmosphere causes vasospasm in the umbilical cord vessels. So you can use warm mops soaked in warm saline. Pack the vagina so that the cold atmosphere does not cause vasospasm, and bring about prompt delivery. Delivery mode, okay, bladder filling. Since I am short of time, but I'll just quickly go through. If you're expecting to transport the patient to a place where cesarean can be done, maybe you are at a center where cesarean is not possible, then you fill the bladder. That way the presenting part gets pushed up, the uterine contractions can be brought to a minimum, and transport the patient to a place where she can then undergo a cesarean section. Now this knee chest position, Sims lateral position, Treadlenburg position, frankly just these are of theoretical importance. I don't know how many of you have put your patient in a knee chest position. You are more concerned about preparing for a cesarean and getting the baby out, for God's sake, right? But this is definitely what can be done in case transport of the patient is required for some reason. So these are the various positions that the patient can take. If the baby is viable, she is fully dilated, immediate normal delivery is possible. Attempt a forceps delivery and get the baby out. Within 30 minutes, if the baby is out, you can have a good outcome. If dilatation is not adequate or distress is too much, don't waste time, just go for a cesarean section. So this is basically the chart which just tells you what all those things that I wanted to. Now in a community setting, already I've said a lot, we are in a developing country where primary health care is given in centers which are not equipped enough. So if the mother needs to be transported. Now for here, there should be trained people who can at least diagnose that she has a cord prolapse and do various things to transport the baby while the baby is still alive. Prevention for us as obstetricians: don't try to induce labor in high floating heads. Don't do ARM with high floating heads. If at all rupture of membranes is to be done, then ask an assistant to give some pressure and to fix the head abdominally, and then attempt a rupture of membranes. Counseling, Parikshit said that you don't owe them an apology, you owe them an explanation. So debriefing the family or the mother about exactly what happened. If the baby is alive, probably they'll be so glad, but if the baby is gone especially, it is very important that you talk to them, explain exactly what happened, and discuss future possibility of maybe a planned section or something like that with them. Very, very important. And especially if the baby is gone or the mother has undergone a lot of trauma and long hospitalization, she may also need some psychotherapy. So in conclusion, cord prolapse is a frightening and life-threatening event for the baby, could be life-threatening for the mother, that occurs in labor. Rapid identification, immediate appropriate response may save the baby as well as the mother, and therefore clinicians should be knowledgeable in its recognition and management. So once again, I thank you all for a very patient hearing, and since I began with a shairi, I might as well wake you up by ending with a shairi. कि अर्ज किया है कि ऑब्स्टेट्रिक्स भी अजीब बला है, खूब देती है मौका. ऑब्स्टेट्रिक्स भी अजीब बला है, खूब देती है मौका, मगर ट्रांसवर्स लाइन और कॉर्ड प्रोलैप्स कभी भी दे सकते हैं धोखा. हम ऑब्स्टेट्रिशियंस भी डटे हुए हैं, हमें किसने है रोका. मॉनिटरिंग, वर्जन या LSCS का चौके पे मारो चौका. So thanks a lot, and really thank you for giving me the opportunity and for the patient hearing.
Thank you, ma'am. Thank you for such a precise lecture, and we are really things are very clear how to handle the cord prolapse. I would request the next speaker to come up, please. We'll take the questions at the end of the session.
सुप्रिया मॅम, तुमच्यासाठी ज्यांनी एमॉक्स अटेंड केली, मंडळी टाळ्या. मंडळ आपलंच आहे, सोलापूर ओबीजीवाय सोसायटी पण आपलीच आहे. थँक्यू. मंडळ आभारी आहे. Okay, now moving towards the next topic, it is the catastrophic complications in labor. I would like to invite Dr. Kasturi Donimat ma'am. Ma'am is president of Karnataka State OBGY Association 2022 and 23. She is professor and HOD Department of OBGY, KIMS Hubli. Madam is a MCI inspector too, and again a TOT trainer also. She is faculty at many state and national and international conferences and conducted many workshops and CME. Over to you, ma'am. Thank you.
First of all, a pleasant evening to one and all present here. It's a real moment of pride to be on this dais in Solapur. I carry lots of good memories of Solapur, and I immensely thank Dr. Milind Shah sir, Dr. Anjali, Dr. Monica, and many more, all the team of Solapur OBGYN Society for inviting me, and also thank the chairpersons for a kind introduction. Just, I think 2 weeks back, Dr. Milind phoned me and asked me to speak on catastrophic events in obstetrics. Then I thought, these events, I readily agreed when he told, because these are the events which we are facing day in and out, especially me working as the head of the department in a tertiary care center. That's the last referral. From here, we don't have anything to refer further. So we, a day in and out, are facing such catastrophic events in obstetrics. So today I'll be mainly talking on some real-time events, real-time cases, which I have seen in the recent past. So because of 15 minutes, so I think though I have 5 cases, I try to cover 3 cases. If time permits, other 2 cases I'll be showing. So first case will be traumatic PPH after vaginal delivery. So just now, I think you all heard the lecture on perineal tears and how to repair perineal. But after a normal vaginal delivery, a traumatic PPH. I'll just tell you how this case presented to us. This is a very recent case which we had. She was an elderly gravida, 36 years old female. She was para 4, living 4, means she delivered in a government hospital. She was delivered by nursing staff there, and she was immediately referred to us in the view of bleeding per vagina. When patient came to us, she was very pale, almost unconscious. Pulse was feeble, almost we couldn't feel the pulse. Blood pressure by just 70/40, SpO2 90. So as soon as we received her in the triage, we just shifted her to the main labor room, resuscitated her, and then we thought, what was the cause? Was it atonic or traumatic? So then when we started examining, we saw that they had kept one big pack in the vagina. So we just removed the pack and saw that when we put the speculum, hardly we could see the cervix. Cervix was very much pulled up. Then we saw they had put some 2 stitches on the cervix. And when we really put some light and then saw there was a bluish bulge, a boggy mass in the right fornix. It was seen in the intravaginal wall and on the vault on the lateral aspect. And when we asked the patient attenders, did she undergo any instrumental delivery? They told no. No forceps, no ventus, nothing. It was just a spontaneous vaginal delivery conducted by a sister, and this patient had landed up in a huge broad ligament and retroperitoneal hematoma. So since patient was very bad, immediately we shifted this patient to the emergency laparotomy after taking high risk consent, and when we opened the abdomen, there was a 20 centimeter, more than 20 centimeter huge broad ligament hematoma going up to retroperitoneum, and we saw that there was a tear in the cervix and the vault almost coming up to the isthmus lower segment. So can you imagine this patient has ended up in this thing, that to 4th gravida, all 4 normal deliveries, easy delivery, patient tells easy delivery, but she has ended up in such, no instrumental delivery. Then anyway, because it was very bad, we had to start with do hysterectomy, and then after hysterectomy, we explored the retroperitoneum and we did bilateral intra-iliac ligation, and then we saw still she was spurting from the lateral wall. Then there was a small tear in the right internal iliac vein, So then we had to put 1 or 2 stitches there with a 7-0 this thing. Then it was so bad. Full, huge, this is after evacuating the hematoma, all this retroperitoneal space. And then thorough packing was done, pelvic packing. We kept 4 Foley's catheters, pulled it, and then left the pack in C2 and closed the abdomen. And very happy to say that patient was discharged fit and fine after. Means we had to put many bottles of blood resuscitation, everything was done, and happy to say that patient was discharged after all this. And a message is broad ligament hematoma is a very unusual complication and very unusual after a normal vaginal delivery when there is no instrumentation. So when we really asked the questions to the patient and the attenders and the doctor who was handling it, maybe she had gone in for precipitate labor. And when we asked, he told they had given some tablets, some injection, who knows, a higher dose of misoprostol was given for her. So she went into precipitate labor and had all these problems. So whenever patient is in shock, when you cannot find, and uterus is well contracted and you cannot find out the cause, please suspect any broad ligament hematoma or retroperitoneal hematoma and evaluate further. Though it is rare, it can happen, so you should have high level of suspicion to diagnose these conditions. And because they are very quiet and remote, sometimes you may miss and patient may end in catastrophe. And the treatment, as you all know, most of the time it is these patients end up in hysterectomy with intra-iliac ligation, and good packing is very much essential. And one more thing when you should suspect is postpartum they continue till they have pain in the pelvis, continued pain in the pelvis, patient ending up in shock. That the shock doesn't explain the external bleeding, and you find the fundus of the uterus is elevated, and usually it is the mass is unilateral and it is fluctuant. So if you see these findings, suspect and do laparotomy, then only you can save these patients. So treatment, if it is a very small hematoma, it can be conservative, but most of the time these people end up in laparotomy. One more thing, when we had seen long back this case, so whenever there is a fracture due to some accident or anything, if a patient comes with an accident and if she has a pelvic fracture, please suspect some broad ligament or pelvic hematomas. If you don't suspect, either she will end up in IUD because of the compression, the blood supply to the fetus is cut off, and these patients may end up in again shock because it is concealed. So, and most of the time these patients are in orthopedic department and they are not detected because the bleeding is not evident outside. So whenever they tell that there is a pelvic fracture, please suspect some hematoma, evaluate accordingly and manage. That is a take-home message from this broad ligament. Then this was another case, inversion of uterus. She was a 26-year-old female, again a primipara. She delivered in a private hospital, my own friend, and that friend in the middle of the night, she brought her to us. She told just 1 hour back she delivered, and suddenly this patient started bleeding. More than the bleeding, patient suddenly became unconscious in shock. So she didn't have anything to explain that shock, but this patient then was immediately brought to our hospital, and our staff who were on duty, they just called me, madam, please rush immediately. Then even I rushed, and then when we saw that there was inversion of uterus. So inversion of uterus, this thing is they end up in shock is, one is because of hemorrhagic shock, patient is continuously bleeding. Another thing is neurogenic shock. So that when she was unconscious, patient suddenly became unconscious, she was really afraid. She just brought, and she personally accompanied the patient to the government hospital. On arrival, patient was in shock, BP not recordable, pulse feeble. So we didn't even waste any time. We started the fluid resuscitation on the trolley, shifted this patient to the OT, immediate, both our resuscitation, fluid resuscitation and reposing back the uterus was so fast, you know. So we didn't wait for anything. We just told one of our junior, you consult the patient, you take this consent, everything. So she was doing all that by the time we had shifted the patient, did resuscitation, reposed the uterus back, and patient was fine. So after reposition, one more thing is you should keep the hand in place in the uterus, there only, because if you just remove it, again it can reinvert. So, and then you give the uterotonics. And for this patient, because there was lots of bleeding, we kept one Bakri balloon, inflated it, and gave a lot of blood and blood products, and patient condition improved, and we could discharge this patient after 1 week with 8 grams hemoglobin. So then that our private practitioner doctor was extremely happy with us, because we could save, and without wasting 1 minute. This was one catastrophe, like she was patient, even the obstetrician almost was in shock seeing that kind of thing. So we could save this patient. This was a picture. So causes of inversion, I will not go into the theory. As you all know, some uterine anomalies, or if they have some connective tissue disorders, or placental, as all of you know, if it is a fundal placenta and adherent placenta, or very short umbilical cord when you try to pull it, and very macrosomic fetus, or precipitate labor, uterine atony, and most of the time it is sometimes primies which end up when you, if you are untrained dai or a sister tries to pull on the call before the separation of the placenta, that is mismanagement of a third stage, etc. And sometimes it is idiopathic, you don't have any reason to tell why the uterus inverted there. And the management, as I told you, fluid resuscitation and control of hemorrhage should go hand in hand. And most of the time what happens, because she is bleeding, they would have given her uterotonics, either some oxytocin drip or something is going on. Please stop all these uterotonics. Whenever you see a inversion of uterus, stop all these uterotonics, start giving tocolytics. Otherwise, there will be a ring formation by the cervix, and your procedure of putting back the uterus is going to be extremely difficult. We have faced those situations when we had to open the abdomen, try pulling it, the round ligament, etc., tried all the procedures, tried giving all the tocolytics. So first thing I tell our postgraduates is, please stop all the oxytocics which the patient is getting whenever you get a case of inversion. When you stop that and start them on tocolytics, shift the patient, fluid resuscitation should start on the trolley, shift the patient to the OT, somebody else is taking the consent. So if you act only so fast, then you can save these patients. I know not many people can have the chance of seeing this inversion, because it's not a very common thing, inversion. How many of you all see it a day in a, no, it's once in a year, or sometimes inversion occurs. Very rarely you get a case. So everybody is not very trained, or have not seen inversion cases, and so they don't know. There are no fixed protocols for this. But if you have this in mind, then you can really save these patients, and the results are excellent. Once you repose, the improvement is so fast, the results are excellent. So you should know how to. So the tocolytics which you can give is magnesium sulfate, terbutaline, nitroglycerin, all have been tried one after the other. If still not responding, then you should tell the anesthetist to give halothane or isoflurane or sevoflurane, and better are these sevoflurane and all are good, because they have very little side effects on the hemodynamics. So you tell the anesthetist, please give these relaxants like sevoflurane, which can save the help you in reposing back the uterus. Then there are other methods which I will not go into, but only if this reposing back with the vaginal is not effective, hydrostatic methods we are not using now. We directly go to the laparotomy, pull on the round ligaments. If all that is, and we use vacuum cup also there on the fundus, try to pull it with a vacuum cup, that we have used. If still not, then we cut the cervical ring on the posterior aspect. So these things we use, and with that cutting the ring and taking out, that is the last option, and definitely that will help. But in case of this, even after reposing, if she is heavily bleeding, then sometimes we have resorted to hysterectomy, especially in a woman who has completed a family. So there are very rare occasions where we had to do hysterectomy to save the life. So these are whatever I told, these are some take-home messages for the inversion of uterus. And wherever possible, you can use balloon tamponade also to stop the further bleeding also. Then this is one more case of placenta. This is the third case, placenta accreta. She was a 34-year-old patient. She came to us in the early morning with mild pain abdomen. She was just 32 weeks. She was second gravida 2 para 1 living 1 with previous 1 LSS, and she had come with pain abdomen. We thought she is just threatened preterm labor, and just we were looking into it. And then by the side of labor room we have a scan machine. We just put a scan to see.
Just last 2 minutes.
Just right. So we put a scan, this thing probe, and saw that placenta it was placenta previa and previous section. So immediately we suspected it could be a adherent placenta accreta. And then we almost 90% we suspected, we wanted to confirm. So but to send her to the radiology for further Doppler study and MRI, it was scheduled at 10 o'clock. But within half an hour, patient so badly, profusely started bleeding. So, and her BP started dropping. We had to immediately rush to the OT. And in the OT, what we saw, I'll just show you the picture. This was the picture. This was the placenta percreta, not just accreta. It was percreta. It was almost extending up to the bladder, and we immediately gave an incision on the upper segment, removed the baby, stayed away from the placenta, and because we had to do subtotal hysterectomy for her, we tried separating the bladder, and it was so profusely just pumping blood. Bladder was opened, and we had to call the urologist, and we did bilateral intra-iliac ligation, subtotal hysterectomy. Urologist repaired the bladder because it was bleeding so much, even he had hell of time, but patient was saved. Again, we had to pack the vault with the balloon tamponade, and patient recovered well. This is the stepwise approach for placenta accreta. Actually, if you diagnose prior, it's a team approach. You should have a senior gynecologist, urologist, and everything in place for intra-iliac ligation, vertical abdominal incision, vertical incision on the fundus of the uterus. Stay away from the placenta. Don't touch the placenta. We tell dustarinda duriviri. So placenta in this case is dusta. Please stay away from the placenta. Don't touch the placenta. She'll start bleeding, and go ahead with hysterectomy. If you have to save the placenta, then just cut the near the insertion cord. You can leave the placenta behind. So this is in detail how to go ahead. These are the guidelines for placenta accreta. So I have told it. So early diagnosis, multidisciplinary approach, and clear-cut, very good follow-up of these patients can save these patients. So since there is a lack of time, I'll just show you the pictures of 2 very bad cases which we had. This is a vasculitis with hypothyroidism with gangrene of both lower limbs. This patient was referred from a nearby government hospital with hypothyroidism and thrombocytopenia and Rh negative status to us. And we delivered a preterm. She went into spontaneous labor. She delivered a preterm baby. Baby was shifted to NICU. And patient became semi-conscious, almost unconscious, and with rashes, everything. And she suddenly developed this. I'll just show you the picture because of lack of time. She started developing this rashes like this, both on the upper limb and the lower limb. Can you see this? This is what she developed. This is the gangrene she developed. Then this gangrene we treated for 15 days. All the specialists. All the including the immunologist, endocrinologist, the physician, everybody came into picture, everybody tried to save her limb, but in spite of that, this all what she went, and at the end of the day, she had to undergo amputation. This is the worst catastrophe anybody can see after delivery. One more thing, this is a uterine artery AV malformation. This was another case which was diagnosed as molar pregnancy. Everybody, 2-3 centers she went, they thought it is molar pregnancy, and because of the increased flow and those this thing. And 2 times she underwent DNC also. When she came to us, she was 2 grams HB. Then I told her, okay, but when she came, her bleeding had reduced with her, but she was 2 grams. We were correcting her anemia. Then I personally went for the scan for this patient. When I saw there was a turbulent flow in her myometrium, extremely turbulent flow. It was so pulsatile, turbulent flow. Even I was feeling very distinct. Immediately we diagnosed it as a case of arteriovenous malformation. And immediately we subjected her for CT angiography. This was the AV malformation we saw. And we don't have a facility for interventional radiology, so we didn't have in any of our centers in Hubli. So we wanted to shift her to a place where she had interventional radiology. I told my residents, keep ready, I'll talk to the patient when I come at 9 o'clock. And by 8 o'clock, our resident phoned me, Madam, she's profusely bleeding, what shall I do? I just told her, shift her to the OT. When I went I immediately, within 10 minutes, I rushed to the OT. By the time I reached, and anesthetic started giving, patient already her BP could not be recorded, she was pulseless. I had to, for a 26-year-old person, I had to do hysterectomy in order to save, but I actually forgot to put the specimen, photograph here after we did hysterectomy. So we didn't even time to send her for interventional radiology or anything, though she was young, because it was a catastrophe. To save the patient, we had to do a hysterectomy for a 26-year-old for AV malformation. Yes, treatment differs on under what circumstances you are seeing, how bad she is, how hemodynamically either she is stable or unstable, your treatment differs. If she is stable, then maybe you try artery embolization. If it's unstable, they do end up in hysterectomies. Thank you so much everyone for it. Yeah.
Thank you, ma'am. Thank you for such an elaborative yet precise lecture. And now, we as an obstetrician, we actually don't want to have such type of catastrophe. But now, with all this lecture, we have got the courage that we can face these unexpected and unanticipated complications. Thank you very much.
Thank you. Yeah.
Ma'am, on the behalf of organizing committee, we like to felicitate both the speakers. I request Anjali ma'am, Milind Shah sir and Guram sir to please come.
I also request Dr. Chamma ma'am, Dr. Milind Shah sir and Dr. Manik Guram sir to felicitate our chairperson. I request Dr. Anjali Jamma ma'am, Dr. Nanda Magai ma'am, Dr. Monica Umbardan ma'am to join this session.
I request Dr. Anjali Jamma, Dr. Nanda Magai and Dr. Monica Umbardan to join the session as a chairperson. Dr. Anjali Jamma is a SOGS president and chairperson of this conference. Dr. Nanda Magai and Dr. Monica Umbardan is organizing secretary of this conference. Over to you, chairpersons.
Everyone, it gives me great pleasure to introduce our own Dr. Milind Shah. Actually, he doesn't need any introduction. He's an international fame. He has international fame, and he has almost given orations in more than 25 countries. He is president of ISOPAB, Deputy Secretary General, Asia Oceania Federation of Perinatology Society, ex-chairman, Rural Obstetric Committee of FOXI, and he will be speaking on respectful maternity care today. Over to you, sir.
Yeah. Thank you very much, Dr. Nanda. It's indeed pleasure. At the onset, I must say big thanks to Solapur OBGY Society and considering this topic as well, because I found that yes, very few platforms allow you to speak on respectful maternal care, which is definitely a need of the hour. Surudhala? Yes, yeah. Friends, per se, people will get astonished what actually it could be. Are we disrespecting our patients when they come to our clinic? Absolutely not. Yes, we will definitely impart respect to our patient, but sometimes something goes wrong. Maybe your staff, maybe your ayama, maybe your nurses, maybe your assistant, reception, someone may disrespect our patients. And the patients, they come to you for enjoyment, for the joy of motherhood. And we need to give them maximum what we can do, because our great struggle in the medicine these days is not just the ignorance and uncertainty, it's also with complexity, how much you have to make sure you have in your head and think about. There are 1,000 ways things can go wrong, and where the things again can change as well. Probably you will ask, what is respectful? It is subjective term, isn't it? But yes, friends, it's dealing with so many aspects in the human life. Could be feelings, could be emotions. We all feel pain, we all bleed in, we are cut, work to provide for ourselves and our families. We expect to be treated with respect at work, in public places, family, community, and also consulting room. Can I request the people to please keep quiet? I understand you're tired. You can take your cup of tea and please keep quiet. Yes, near tea stall. Excuse me, can I request you to please keep quiet? I understand, yes, it's a really tiring moment. But friends, see, every speaker spends a lot of time to prepare the presentation, to make certain things to come to you. So please respect that as well. So friends, I will tell you one very interesting story about it. You know, one day I got a patient in my consulting room, registered with another gynecologist, and came to me for the registration again for the delivery. I said, what happened? She said, doctor, I will tell you what has happened. I was, measuring my weight when the doctor was sitting on the consulting chair, and to adjust that particular weighing machine, the doctor touched that machine with the foot. Just remind that patient said, I felt so insulted and I decided to quit that clinic and I'm coming to you. I realized this is respect. Just a small actually thing which we sometimes do with pinch of salt, but that is again very important as far as our consultation or giving maternity services are. Respect for ourselves guides our morals. Respect for other guides our manners. We don't need to share the same opinion as others, but we need to be respectful. This is again a very important issue. Again, then another story. Just a week before, patient came with AFI 8. Doctor has advised immediate induction of the labor. And then we realized the BPP was normal, NST was absolutely good. So we said we can wait for some time, but that need to be told in very respectful manner, because that previous consultant must be having some opinion on that particular case. You'll have to tell that, and I'm so fortunate, the same patient after 8 days, this morning delivered with us. So that is what one need to understand whenever we are doing that. Friends, this respect we all learn more when this particular thing came actually in front of us, the COVID virus. So many patients, so many medicos, so many gynecologists, I will tell you, in the city of Solapur were pushed to the government medical college. I know Dr. Vidya Tirankar, how she was struggling with her staff and management to manage those cases from different strata. And those gynecologists from the Bid, gynecologists from the Osmanabad, they were saying, doctor, now they are so flooded with the work, we need to have the private setup to deal with our deliveries when we are COVID positive. We actually decided to form a team. And again, I told my team also, the two anesthesiologists, my pediatrician, you can see that particular Ayabai on the extreme left, and nurses and brothers, even the runner nurse. And to my surprise, when properly told, they consented to become a part of that particular team. and we could deliver 25 COVID positive actually patients very effectively in private setup. That time only private setup who was delivering COVID positive cases. And God is always helpful to you. You cannot believe. None of us got the COVID infection in that particular span of the time. But of course, we were taking extremely good care with all those protective gears. So respect is in the terms of so many things. The honor, recognition, dignity, regard, consideration, reverence, courtesy, and esteem. All these elements need to be addressed. That's why respectful maternity care encompasses respect for the women's basic human rights that includes respect for women's autonomy, dignity, feelings, choices, and preferences, including companionship during maternity care. This is again a very important aspect. We always face this particular problem of companionship because in Indian scenario, it is never a single company. It is always a group who always comes in the maternity homes. But then you'll have to convince them. You'll have to tell them what we do in my setup. Always tell them the story of famous actress Mita Patil. And I tell them that, see, we don't want to indulge any infection in your case. That's why, please, you try to be minimum as far as your visits are concerned. And that's why we need to understand this particular concept of Hamara Swasth Hamari Awaaj, our health, our voice, what patient is saying to you, and that campaign need to be taken into propagation with all of us, which is very, very important. Now, this particular campaign, when it was run by White Ribbons, you know what were the actual impressions? One particular patient says, I went to hospital for my delivery, where I had a very bitter experience. When my labor pain started, instead of taking care of me, the nurse started screaming at me. One of the nurses asked me either to go to a private hospital or to deliver the baby at home. I asked for the respectful behavior. Very true. Is it a very uncommon scenario? Forget about the government. Even in the private hospitals, I have seen the nurses slapping on the thighs, slapping on the abdomen, screaming, "Zor kar, tula kya kalat nahi ka?" But you'll have to be very gentle. You'll have to convince her. You'll have to tell her what actually she needs to do in that particular case. What they are expecting, a dignified care, consented care, confidentiality about her actually facts, non-abandonment in the care. For example, suppose I want to come here for the conference, I need to speak with that particular patient. I went at 6 o'clock in the clinic. I delivered that lady who had come from other clinic 8 days before register with us. Then I decided I must attend her as well. The no physical abuse, which is never and never accepted by anyone of us, we understand that. So patient has come to you for the care. It doesn't mean that she's your property. You cannot slap her. You cannot shout at her. Maximum, you can, do maximum of the counseling to that particular patient. No abuse related to cost, including detention and the equity in the access. There should not be any discrimination about the cases. I remember a police commissioner's wife came for the delivery and our rooms were already occupied. So I told, we'll go to the another hospital, maybe the Yashodhara or the Ashwini hospital where I can deliver you there. Because I cannot ask that lady who is sitting in that particular room to come out of it for only you. You know, that lady was so happy. She said, this is what actually every woman wants. And she decided to stay in the ward for a day. And next day when the room got vacant, she occupied that particular room. See friends, patients, they always and always see you very carefully. How you behave, what you are discussing with your other colleagues, what you are discussing in the operation theatre, all that need to be done very, very carefully. And very simple interventions also can make a lot of things. Here it is not only the respect to your patient or to the staff, but also to your family also. When these COVID days were there, we were understanding the family members who are non-medico may get frightened. But simple interventions like, using this particular handle to open the doors, we used to use that whenever I used to rush to the clinic. Because I used to understand that my old mother probably will get frightened. Because those times, that the TV was portraying so much about the COVID actually mortality and morbidity. So we need to be careful. We need to convince them what actually we can do about it. The substantial barrier to progress in the patient safety is dysfunctional culture rooted in the widespread disrespect. So there are 6 categories. disruptive behavior, humiliation, demeaning treatment of nurses, residents, and students, passive aggressive behavior, passive disrespect, dismissive treatment of patients, and systemic disrespect. You know, again, your seniors teach you. I remember when I was president of Solapur OBGYN Society, I had organized an event, endoscopy workshop. In those days, that was a very hi-fi thing because endoscopy was new, and we had organized that at Chitare Clinic. You know, and the one sister, she committed a very wrong, actually the sort of mistake. And what madam did, Dr. Chitare, Mrs. Chitare, what she did, तू माझ्यासमोरून निघून जा, तू माझ्यासमोरून निघून जा, तिथं बाहेर जाऊन थांब. I just, thought that what would have happened, suppose it happened in my clinic. We start shouting at the sister, we start shouting at our ayabais, hey, asं तू कसं करू शकतेस, and all those things. But then that taught me that how to speak when they commit mistake. Don't shout immediately, you can do that afterwards because that is a training process. It is not that everything happens goody-goody. पण मी ज्या वेळेस मग माझ्यावर असा प्रसंग आला, मी आता असंच बोलायचं ठरवलं की तू जरा बाहेर जा. मग काही वेळ गेल्यानंतर कदाचित त्याला मी वेगळं घेऊन सगळ्या गोष्टी शिकू शकतो. ऑफकोर्स दे डू मिस्टेक्स, दे ऑलवेज डू मिस्टेक्स. इट डझंट मीन दॅट यू शुड शाउट इमिजिएटली ॲट देम in front of everyone, because finally that mistake could be out of ignorance, maybe inadequacy of your training as well, that we need to understand. And that's why this category of disputes has some corresponding rights as well. I'm not going to read all that list because I understand already we are so late and we're waiting for a wonderful panel of the all pediatrician friends who are going to tell us something about that. But you can see that those rights need to be addressed when we say about respectful maternity care. And that respect for the beliefs, traditions, culture, empowerment of the women and her family to become active participants in the healthcare, continuity of the care, the right to information and privacy, good communication between client and provider, and use of evidence-based practices. You know, recently, last week, I got a patient, a very handsome boy of almost 22 years, came to my clinic for his wife's treatment. And the mother says, हाय बघा तुमच्या तो थोडा स्कार लागला होता ना सिझेरियन करताना, so he always reminds of that scar. But I felt so happy they had taken it in good faith, saying that they were very in pleasant mood to tell that. But I realized that I suppose would have hidden that particular event, that could have created another actually the impact in that particular family. But that was very well taken. So friends, whenever we do that, we need to address certain checklist. Suppose we do that, definitely that respect automatically pips in what we did. And everyone, even the world notices that. Because in the COVID-19, what was done, we modified that surgical safety checklist and we used to call it the COVID-19 surgical patient checklist, which had the same elements what we had, but there were certain modifications in that. For example, we kept one nurse or the brother only to run from the clinic to clinic. I remember there were very few actually even the pediatricians who were willing to come and attend those actually particular cases. But one lady pediatrician, Dr. Usha, she said, sir, I won't mind coming and attending those cases. But we never used to ask her to come immediately in the theater as we normally do. She used to wait outside in the waiting room, and when the baby used to get delivered, that time we used to summon her to come inside with the help of that runner, actually the brother or the runner nurse. But that created a lot of things. The team got a lot of confidence in delivering those particular cases. So COVID-19 has changed our routine practices, but also taught us a lot about the respect about the humanity also. We must adopt and accept this new normal. The simulation training important for the staff and debriefing after each case to improve the system, which is very, very important. We needed to do a lot of changes in our practice also after that. And we decided to do it very carefully because I remember even wearing that PPE kit was very difficult. Simple interventions like using these mobile pouches to avoid our mobile getting contaminated also made a major difference. And all these things, as I told you, the word always take cognizance of it. The Royal College took the notice of this particular thing and they decided to have a workshop for all other doctors across the globe about this new safety checklist for the C-section. And I was so happy to interact with all of them that everyone had his or her own actually experience in that particular period. and FIGO also definitely takes the notice of it, and they also has come out with the medical ethics guiding principles. Again, they have the same actually components in that: beneficence, non-maleficence, autonomy, and the justice to the patient. These are the key stakeholders in the respectful maternity care: the pregnant woman, her family, community, women's advocates, human rights activists, policymakers, training institutes, and of course the healthcare providers. Could be individual, could be professional associations as well, which can take part to follow this particular message. These are the key action points: the research, policy, legal action, education, service delivery, advocacy, and the community or the social activism. So whenever we thought that this need to be told, you cannot believe, AOFOG invited us to tell this experience. The SAFOG invited us to tell this experience. Though that time the physical going was not possible, virtually I could go to all these organizations to tell about this thing. And if at all you want to learn little more about that, there are a lot of actually literature and guides available on the internet. For example, this workshop which was conducted by USAID has a very comprehensive addressing about this respectful maternity care, which you can go through it. There are certain studies, yes. 1 minute, yeah. Last 2 slides and then I will finish, yeah. So the status of respectful maternity care among women availing delivery services at tertiary care center in the central India, a cross-sectional study by Sarita Sharma and all. And what they found that still there is need to be lot of changes done, because it is not that 100% get the respectful care. There are actually the lacunas where we need to do that. Another actually study by Ansari and all, and they also concluded that there is high prevalence of disrespectful maternity services, which indicates more and more actually the training for our healthcare providers as well. And it is not only our Indian actually scenario, even abroad, especially African countries. This is another study where they also concluded with the same thing what happens. So friends, to conclude, it's an opportunity to care for and care about our commitments, a challenge to meet and exceed client expectations, a chance for everyone to create the right impression for both clients and the provider. And what can happen? This is a review actually of that particular workshop. After the campaign in the labor rooms, I saw a change, and that change need to happen in our day-to-day practice as well. We need to get ourselves also sensitized, then only we can attain these sustainable development goals which we are aiming for. There are actually many projects by the government also. We need to get participated in that. You know about the Lakshya, you know about the Manyata, you know about the so many other actually the activities. We need to be very active in this particular part, and the things will be very, very easy. So friends, thank you very much for patient listening. Simple things also can make a major change. See this particular very innocent boys, but how respect can be imparted. A wonderful lesson for you. So kindness is natural, hatred is always and always not accepted. So we'll have to be kind with everyone. Thank you very much, friends. Thanks a lot for the patient listening. I understand at the fag end of the conference, listening to a keynote is not very joke. But I respect you for your patient listening. Thank you very much, chairpersons.
Thank you, sir, for giving such an elaborative talk and giving incidents to show how disrespect is not good. All women deserve respectful maternity care, and treating the women with empathy and respect should be our goal. You must have experience in your practice, day-to-day practice, की पेशंट येतो, जर तुम्ही नक्कीच चांगली काळजी घेतलेली असेल तिची तर, मॅडम मी तुमच्या नावाने माझ्या बाळाचं नाव ठेवलं, हिचं नाव अंजली ठेवलं, हिचं नाव मिलिंद ठेवलं, तर सर तुमच्याकडे जास्तीत जास्त पेशंटचं नाव मिलिंद असेल.
Great, thank you.
Thank you, sir.
Thank you very much. Now I request the chairpersons to please felicitate Milind Shah, sir.
I also request Milind Shah sir to felicitate our chairperson. Let's move towards the panel discussion. I call Dr. Sandeep Kulkarni sir, Dr. Sudesh Doshi, sorry, to moderate this most interesting panel discussion. Our panelists are Dr. Rachna Jaju, Dr. Kundan Chopde, Dr. Monica Umbardan, Dr. Anuradha Garad, Dr. Vinayak Revankar, Dr. Amruta Kumtekar. The stage is yours.
The pediatrician in time would be a good practice. It is better to have one or two pediatricians, one standby pediatrician, so that in case one person is not available for some or other reason, you don't get panicked, you don't yell at their pediatrician, how can you go away with your wife for the movie or with someone else for the movie without informing me, nothing like that. But it is better to have a one person standby so as to avoid anything. One more thing which we should be very particular at is that it is not only that when the pediatrician comes then our responsibility is over. We need to have the infrastructure in our place. एखाद्या स्वयंपाक्याला बोलवलं त्याला जर येऊन स्वयंपाक कर म्हणून सांगितलं तर आपलं स्वयंपाकघर छान असलंच पाहिजे, सगळ्या गोष्टी बरोबर असल्या पाहिजे तर स्वयंपाक छान होणार आहे. त्याच्या हाताला चव नाही म्हणून चालणार नाही. सो वी नीड टू हॅव द न्यूबॉर्न कॉर्नर ऑलवेज रेडी, अवेलेबिलिटी ऑफ ऑक्सिजन, एंडोट्रिकल ट्यूब्स, इन्फंट फीडिंग ट्यूब्स, सक्शन मशीन, वॉर्म कॉर्नर, बेबी रॅप्स, timely call. And one more thing is you should always provide one staff of your hospital who is trained in the resuscitation of the baby. He should be a helping hand to the pediatrician. That would be good. Next question, Dr. Sandeep.
Yeah, I'm going to ask this question. I'll ask this question to Dr. Kundan. What is the role of pediatricians? Now, as sir has rightly said, and Dr. Monica has already pointed out that she'll be able to communicate many things. But we all know in practice it becomes very difficult, and many a times we get a call as a pediatrician कि एक सीजर है या timing ला, you just come. And most of the times we have to go and fetch the information. So as a pediatrician, what do you think that what is expected from an obstetrician, as well as whenever you enter into the labor room or operation theatre, what all things you will be expecting to prepare for a successful delivery of the baby?
First of all, thanks. Revisiting the journey of birth is incomplete without pediatrician. I want to congratulate this organizer team for calling pediatrician to this dialogue. And most of the important thing is we should work as a team. Team means together everyone achieves more. Obstetrician should first inform, as already told. Most of the time we get call that, sir, head-on perineum is there. Sir, one Caesar call is there. Most of the time one staff nurse or someone calls, sir, one Caesar is there. Minimum we want 3 things from the obstetrician. First, whether the baby is term baby. Second, what is the liquor, whether it is clear or meconium stained. And third, any maternal risk factors, that is very important. Madam has covered many things. I will just say some words, like term baby, preterm baby is there, then we have to be ready for resuscitation. There can be chances of apnea. If there is meconium stem liquor is there, then if baby is depressed, then we have to do resuscitation. And maternal risk factors are very important. That should be told. Like PIH, there are chances of uteroplacental insufficiency, and there are chances of IUGR baby. If diabetes is there to mother, then we have to monitor the sugar. Then if there is microsmia, chances are there are chances of shoulder dystocia, brachial plexus injury, we have to look after that. If mother is having thyroid, hypothyroidism, then we have to monitor T3, T4, CHH, we have to do T3, T4, TSH. Then one important thing, if history of oligohydramnios is there, we have to look for renal problems. If history of polyhydramnios is there, we have to rule out tracheoesophageal fistula. We are more alert. We will put the Riles tube again and again. We will see. Then second, PROM. This is most of the time missed they already. If it is more than 18 hours, then we have to give, send blood culture and do empirical antibiotic therapy. And important thing is APH also. APH, obstetrician is already panic. If there is APH, the baby going into shock is very common. We have to give crystalloids, or we have to keep O negative blood ready. Basically, pediatrician role is all I have seen 3 Idiot movie. We came if there is problem, and we make all is well.
Sir, I would just like to add whether we have given steroids to the patient antenatally, and in case of a mother who is PIH, if she has received Maxelf, we need to inform that to the pediatrician, because the baby would be respiratory depressed as well. The same thing for a preterm labor, if we have given Maxelf as a tocolytic, then that also needs to be informed.
I would like to ask Kundan one more question. Once you enter a labor room, or maybe before entering the labor room, would you like to have a word with relatives of the baby or mother, or maybe some anxious parents who are waiting outside? Would you like to have a word with them before delivery?
Definitely good question. Most of the time we do not do this in clinical practice, but ideal situation we should talk the relatives, especially if there is history of bad obstetric history or many miscarriages are there. If any previous baby is having any chromosomal anomalies or any defect is there, then if there is twins or triplets babies are there, then we should ideally tell the plan of action. We should give all information so that they can make decision, that is informed decisions they should make. Decision will be ultimately theirs, but we should give information to them. What are the risk factors? What are we prepared for? And we give message that we are prepared for this all, handling these all situations.
Right. Very good.
And counseling is very important. One family person, mother, father, and one person, because mother will not be there coming in NICU if patient is goes. So one person should be there from start to end, so that he will be well informed.
Yeah, because mother is there with the obstetricians for almost 9 months, and they have a good rapport, but they don't know who is the person who is going to take care of the baby, and ultimately they need to be introduced. So in that case, even a gynecologist also can introduce the pediatricians. He'll be taking care of your baby and all. Would you like to visit the labor room and place of where the baby is going to be resuscitated if necessary? Would you like to see the place, or would you like to go see that all the things are in place?
Yeah, that is very important. I usually go and see the places, or instrument or equipments all there. Ideally, it should be a separate place, and it should be radiant warmer should be seen. It should be preheated. What happens many of the time, radiant warmer is there, but it is not on. Even after baby comes, then warmer is started. It should be preheated. 10 to 15 minutes prior, it should be preheated. 2 warm towels should be there. When we clean the baby, we have to keep in another warm towel. Then most of the time, laryngoscopes, whether they are working, extra batteries, then bulbs are required. Most of the time, emergency and we get panic. Then stethoscope should be separate, preferably pediatric, so that there are chances of infections are less. You do not mix with other stethos. Then other things like ambu bag, all that, blades, the mask size 0, 1, whether it is available, ambu bags should be there, and it should be seen, oxygen, whether it is started. Most of the time oxygen has been not started. All don't have central oxygen facility, they have to start the oxygen. That is very much required. And talk with obstetrician regarding this all.
And sir rightly pointed out that there should be a staff who is named, like so and so staff will be there with you for help if you need it. So would you like to have a word with her, because many times the staff is unknown to us, or even if she is known, we don't know how much her caliber is, like in what way she is going to help you. So would you like to have a word with her or him?
Basically, she should be ideally trained staff regarding neonatal resuscitation. What steps, next steps we want, even for normal delivery also, if we want after suction we want clamp, she should give clamp first, then immediately she should give Caesar. And all that should be told to her, and told repeatedly to her. We know our staffs, told repeatedly to her. And whether every baby we give vitamin K, that should be filled. What is the quantity, that all should be informed to her.
Thank you. Thank you.
Yeah, the point which sir has brought, we have a very good practice at Pandharpur Hospital. We generally have a one common meeting with the anesthetist, pediatrician and all the staff in the hospital, so that in last 3 months what we have done, what has gone wrong with someone stuff, rather than pointing out his or her mistake, what was the mistake and how that mistake will not be committed from anyone. So 3 monthly or maybe once in 2 months a meeting of all the staff and all the consultants coming to your hospital, maybe it is a radiologist, a sonologist, a fetal medicine consultant or a pediatrician or an anesthetist and the consultants hospital. We should have a good meeting maybe with a cup of tea किंवा संध्याकाळी बसायला तर तसं पण त्यावेळेस बोलता येत नाही पण with a cup of tea and the staff, so that you have a relaxation atmosphere and the staff, once you give them responsibility, they feel that it is a dignified job to them and some responsibility is given to them and they feel very elated to pass on that responsibility. And we should offer them few trainings to them, so that त्यांना येतच नाही तू गाढवाचं असं म्हणण्यापेक्षा त्या गाढवाला काहीतरी शिकवलं तर तो गाढव काहीतरी शिकेल ना, ह्या गाढवाने त्या गाढवाला काही शिकवलं नाही तो गाढव कुठून शिकणार असं होतं. सो वी हॅव टू ट्रेन देम पिरियडिकली अँड इट रिक्वायर्स रिपीटेड रिव्हिजन्स विच शुड बी डन, बिकॉज इन इमर्जन्सी देन एव्हरीथिंग स्टार्ट्स येलिंग ॲट ईच अदर.
And one more point, watch should have second digit, the second one.
Second.
Watch.
Second.
Most of the time digital watches are now, we do NRP, we take time, 30 seconds, 45 seconds, 60 seconds. She should be able to tell.
Has a big
With a second.
Yeah, but that is important.
Right. Next question to Dr. Vinayak Revankar. Now that the baby is delivered, so it could be anyway, like it could be a normal delivery, or maybe the baby needed some assistance, or maybe the baby didn't cry, or whatever scenario is there. Now, I just wanted to ask whether you would like to have a post-delivery counseling with the relatives, depending upon what is the condition of the baby, because they have to be informed. Already you have been introduced to the parents or the relatives, so they know you. Now you have to counsel them regarding what is the outcome of the delivery.
Definitely, communication with the parents is very important. And regarding communication, we should disclose the gender of the baby, the weight of the baby, and well-being of the baby. Whether the baby needs NSU care or not, baby can be managed in the birthing room or rooming in done with the mother. We can very well evaluate with the parents.
In case the baby needed some assistance or maybe some sort of resuscitation, but the baby is now crying well, and you have decided the baby will be remaining with the mother itself, would you like to tell or instruct the staff nurse who is attending the baby regarding how and when to inform the baby regarding the baby's outcome, well-being and all, whatever?
Immediately after delivery of the baby, if the baby is normal, first thing we should do is skin-to-skin contact with the mother. It is helpful to maintain euthermia, initiate breastfeeding as early as possible. The first 1 hour is a golden hour for initiating breastfeeding, which will be helpful for the baby, even for the mother.
Right, very good. In case the baby unfortunately needs to be shifted to an ICU for whatever reasons, what would be your plan of action? Like how would you go ahead with it?
Neonatal if a baby needs an NSU admission, first and foremost the thing is in the birthing room, there should be still the transport team is available. So transport is usually an emergency. The transport team should be available within 30 minutes so that baby can be resuscitated as early as possible. Right. So till the transport team comes, we should have a radiant warmer to maintain euthermia. We can give supplemental oxygen therapy. If artificial ventilation is needed, for that time we can continue ambu-bag ventilation. And once the transport team is available, then we can shift the baby in a transport incubator so as to maintain euthermia, and a trained staff should be available. Along with 2 staff should be available. One who can help the leader so that respiration is taken care of, temperature is maintained, nutrition is taken care of in order to prevent hypoglycemia during transport.
Very good. Now the baby is handed over to NICU, so now the obstetrician's work is over. But I'll come back to a normal baby who has been delivered and the baby is going to remain with the mother. Would you like to say a few words about postnatal rounds of pediatricians? Many a times एक बार बुलाया जाता है और फिर बाबा टाटा किया जाता है. But would you like to revisit the baby or see the baby for some things after the delivery?
most of the times things we miss during delivery room can be catch up in the next day rounds. Certain respiratory anomalies, even cardiac anomalies, murmur is not audible on the first day, but murmur may come on second day. The baby which has been seen on the first day, usually you don't see icterus, but suddenly icterus may develop on second or third day. Similarly, if there is any feeding problem, even surgical emergencies, if baby is having any bilious vomiting which may come on next day also, that also you should taken care of. Then urine output should be taken care of. Stool output should be taken. If the baby is feed intolerance, lethargic, seizures, if the baby develops cyanosis, this should be taken considered during the rounds.
So I just wanted to give a summary of this session is like obstetricians, many times it happens that pediatricians have been called only for one day and later on the baby is managed by gynecologist or obstetrician who's over taking care of. But many times things are missed, which are then the baby becomes very bad on third day or fourth day, or sometimes it throws a convulsions. It could be a hypoglycemic convulsions, and that can give rise to anxiety to the relatives as well, and the baby may become morbid because of these complications. So it is better once the pediatrician has seen the baby, ask him or her to come revisit the baby at least 2 to 3 times during the stay in the obstetrics wards. Thank you very much.
Yes, rather from obstetrician side, what I would suggest is, if you want a pediatrician to come to your hospital again and again and do give a good services, it should be that the pediatrician not only sees the baby on day 1, but till the baby is in your, the patient is in a hospital, it is better to have a pediatrician around every day, because the first day when the labor is going or a cesarean section is going on, the pediatrician is in a hurry, we are in our OT or labor room. The second day, third day, the parents can have a very good look at the, have a talk with the pediatrician, and the pediatrician should also come on the next day or third day, so that they confirm it that the baby will come to them only for the immunization, and the obstetrician should avoid giving immunization at their hospital, because that would be a good incentive for the pediatrician to continue with the rounds. Now to Dr. Jaju, about a few things which are very important for perinatal outcome. What is your say about antenatal steroids, antenatal maximum sulfate?
So in case of preterm delivery, or whenever we are expecting the delivery to be prior to term, say before 34 weeks of gestation, then antenatal steroids are to be given for every patient who is about 24 weeks of gestation and less than 34 weeks of gestation. The ideal steroids which we prefer are beclomethasone, 12 milligram 24 hours apart in 2 doses, or dexamethasone as per choice. They will help in lung maturity, and they should be given 18 to 72 hours prior to delivery. But if we are expecting delivery, at least 1 dose has to be given, and if the delivery does not occur within 7 days, then we can repeat a single shot dose after 7 days.
So antenatal steroids and antenatal magnesium sulfate are 2 things, most important things, which have helped us a lot in improving the perinatal outcome, definitely.
Magnesium sulfate acts as a neuroprotective for the baby and prevents the incidence of cerebral palsy.
Yes, one more thing which the obstetricians nowadays we are doing is delayed cord clamping. What would Dr. Amruta say about delayed cord clamping? How will it help in improving the perinatal outcome?
One word on antenatal steroid. It decreases the chances of RDS almost 33%. Decreases the IVH, intraventricular hemorrhage in neonate, almost 50%, and it decreases the chances of sepsis also. So when we are used to use ventilator like anything, nowadays we can manage those baby who have received antenatal steroid on CPAP only, and the need of surfactant is also decreased because of this one single intervention.
Dr. Kumthekar, about...
If the baby is not requiring any immediate resuscitation, that means if the baby has cried immediately after birth, then I think delayed cord clamping definitely helps. It gives around 200 to 300 ml of extra volume to the blood volume to the baby, and it definitely helps in the further progress of the baby.
Yes. On similar lines, I would ask your view about giving antenatal anti-D. Previously, we used to give only postnatally anti-D 300 milligrams after doing the blood group of the mother. But nowadays, it is recommended about giving antenatal anti-D at 28 or 30 weeks. What is your say about that?
Antenatal anti-D definitely helps. If the mother is Rh negative and her indirect Coombs test is also negative, then antenatal anti-D at 28 and 34 weeks definitely prevents Rh isoimmunization.
Yes, to be very precise statistically, it is said that if you do not give anti-D, the chances of Rh isoimmunization are around only 10%. So sometimes the patient comes, तो म्हणतो की आम्ही आधी anti-D घेतलं नाही, आम्हाला कुठं झालं RH negative, आमच्या बेबीला काय वेळ झालं नाही काय नाही, because statistically only 10% pregnancies are likely to get immunized after delivery. So to decrease those chances from 1 in 10, if we give anti-D postnatally, those chances come to 1 in 100. So only 1% babies will get immunized even after giving anti-D postnatally. And to decrease chances, those chances, again 1 in 1000 antenatal anti-D is prescribed. So antenatal anti-D is definitely going to help in case of Rh negative mothers.
Yes. Sir, one word on delayed cardiac clamping. It should not be done in preterm, and it should not be done when baby needs resuscitation.
Yes, definitely.
Regarding deliveries, it is said, delivering a normal baby, maybe vaginally or by LSCS, is a half job done. The second half is important, is initiating the breastfeeding and see that the baby gets exclusive breastfeeding. So, Kundan or Revankar, anyone, would you like to talk about this no prelactal feeds, exclusive breastfeeding, and about how you are going to advise the mother?
Exclusively breastfeeding should be followed, and the baby-friendly hospital policy should be written, and it should be done antenatally only. Most of the time there are retracted nipples that should be taken care during antenatal only, and most of the time what happens, we go to round, already there has been one formula feed given. So we say do not use this. Prelactal feed will decrease baby's drive to suck the nipple. So exclusive breastfeeding should be given, no prelactal should be given. That is the message.
When I go to the rounds, second day or third day, I see, many times I see a dabba in the hand of grandmother. And then she said, "Nee, we are already giving the milk." Then I explained them regarding breastfeeding. I explained them. Then they asked me second question, then what to do about this? I said, give it to mother. Let her eat it. Because they 400 रुपये बडवलेले असतात, त्यांना त्याच्यात जीव असतो. Give it to mother, but don't give to the baby. That is what my say. Because otherwise another dabba will come once the dabba is finished. Right.
About the prescription of dabba, my hospital has strictly no prelactal feeds, no dabba policy. My hospital doesn't have a medical store, so it is very difficult for them to get that dabba. But I found that once that dabba enters the hospital, एखाद्या जरी बाळाला काही कारणामुळे pediatricianने ते formula feed दिला असेल, then it becomes very difficult to eradicate that dabba for almost 1 month. कारण शेजारच्या बाईला ते लगेच हवं असतं. दुसरं एक बघितलं मी, the pediatrician said, I never recommended that formula feed. I said, I never recommended formula feed. My houseman also said, I never recommended formula feed. Then I found out that my मावशी or आयाबाई who had to feed that baby for the whole night, तिला झोप मिळवून ती हळूच सांगत होती, डॉक्टरांनी डब्बा मागून घ्या म्हणून. So you have to manage at various levels to prevent that dabba from entering your hospital.
Dr. Vinayak, regarding neonatal screening. So initially we used to think about this is a fashion कि ये कुछ तो करते रहते हैं, नया नया फंडा निकालते हैं, but it is really important. So would you like to say some words about neonatal screening?
Newborn screening program is definitely a very good program which has been initiated by Government of India. Even many state government has also initiated this program. Most of the common disorders which can be evaluated as early as possible, which are treatable and which can give good prognosis for the baby, are really helpful. So thyroid screening, G6PD deficiency, galactosemia, congenital adrenal hyperplasia, newborn screening is really helpful, and it doesn't require much workup or much blood. Even a filter paper test is also helpful with a heel prick. And if there is a history of previous siblings with unexpected death or previous abortions, That time also newborn screening is really helpful.
Right.
Now we, after having this all discussion, now we'll go to some case-based scenarios, practical scenarios, where we can see what the obstetrician can do and what the pediatrician can do. Dr. Amrita, for you, this is a case one, regular case, primary with 36 weeks pregnancy, her blood pressure is 150 by 100 millimeters of mercury, urinary bilirubin 1+, deep reflexes are normal, CBC is within normal limits. What are the investigations and treatment line to avoid perinatal complications in the baby, which you would suggest in case of primary with PIH around 36 weeks pregnancy?
Since she's 36 weeks already, there's very less chance of respiratory distress. But still, if there's a need of LSCS, then betnesol can be considered.
Okay.
Steroids can be considered. And if the prophylactic magnesium sulfate has been given, that needs to be informed to the pediatrician to look for respiratory distress in the baby. And if after ARM the color of the liquor is, if it is meconium, that needs to be informed to the pediatrician.
What would the pediatrician like if it is around 36, 37 weeks near term baby, PIH, and is delivered either vaginally or by LSS? Would it make a difference in your treatment for the baby or something?
There are chances of uteroplacental insufficiency, so that baby is usually small for gestational age, and on the top of that it is preterm also. So we have to look for his respiration, respiratory distress any, and growth parameters. We have to monitor everything. If required, if beforehand we should talk to the relative that you have this problem and there are chances of baby having preterm or small for gestational age, and he may need NICU care, so that they are mentally prepared. If the baby is good, we can give trial feeding there only. If no distress, baby is stable, we can practice rooming in also.
So one more thing I would like to add, the Doppler parameters and the expected fetal weight needs to be informed to the pediatrician before delivery.
Yes, since it's a case of PIH and she's 36 weeks, if she's well controlled, we may delay induction of labor for maybe a week or so, because 36 and 37 weeks is definitely going to make a difference. The pediatricians will agree with me. If we can delay her for 1 week or something like that, maybe her service will become effaced, her Bishop score would change, she would be more, it will be more easier to deliver vaginally, and the baby gets maturity, and the maturity will help the baby. So first deciding about the induction of labor time and informing the pediatrician. So antenatal steroids induction, whether immediately or afterwards, elective CS or according to your hospital policy, and management of PIH. So,
this is the second case. It is G2P1, 30 weeks pregnancy, PROM. PROM may be around 1 or 2 hours, not very this thing, but how will you manage? Monica, madam?
So first and foremost, I would like to evaluate her clinically and the cervical status, whether she is in active labor or whether there is a high leak. Then I would confirm whether there is an actual leak with whatever available facilities like fibronectin if available, or at least a litmus paper test. Then we need to do a complete blood count of the patient and a CRP test to see what is the chances of infection. If the WBC count is normal, if the CRP is also normal, then we would give her antenatal steroids, try and give her a tocolytic at least till the next 24 hours till the steroids act. If she is in extreme preterm, then I would like to give at least 3 grams of magnesium sulfate for the neonatal neural development and maturity. And we would like to explain the prognosis to the parents in cases with preterm, the chances of sepsis due to PROM, and the neurological complications that would expect in the preterm baby. If at all it is a high leak and it stops with the tocolysis, then and the pads are completely dry, her CBC count and CRP remains normal, then we would like to prolong this pregnancy at least till 34 weeks. But if there are contractions or if the leaking continues and the WBC count is showing infection or CRP is increasing, then we might need to induce the patient.
Yeah, one more question for Dr. Jaju. If you have to deliver a mother at around the baby's 30 or 32 weeks and your hospital doesn't have an NICU setup, then would you prefer transfer of the baby in utero, or you will deliver the patient there and then transfer the baby to the NICU?
So practically, I would like to deliver the patient in my hospital and then transfer her because that will be more practical. But theoretically speaking and in ideal circumstances when my hospital does not have those facilities, it is always better that I transfer the patient to higher center where all the facilities are available and then deliver the baby over there.
One more question. Would you like to, would sending a culture of amniotic fluid help in managing the mother and baby both in this case?
So for culture, I am not very sure.
Okay.
Routinely, we don't do culture.
You don't
We
do.
just do CRP and CBC counts and then manage the patient accordingly.
Amniotic fluid culture in a vaginal leak is very difficult because the vagina is contaminated with so much of amount of bacteria. Then the culture will not tell you whether there is a bacterial fluid or amniotic fluid flora or which flora. So it becomes difficult.
So we would send a high vaginal swab for culture and sensitivity if there is profuse vaginal discharge, not for leaking, sir, just to rule out infections in the vagina.
It is really difficult to send off your patient to some other place or something like that. But if your place is small and if your nursing home doesn't have a pediatrics facility or NICU facility at your place and you have an institute in your town where both the things are available under one roof, it is better to transfer the patient in utero. Maybe you can go and deliver the patient there, you can go and do LSCS there, but for the benefit of the baby and for the mother, it is better to do it under one roof so that the results are optimal. Would the pediatricians agree with this?
Yes, sir, definitely. And post-delivery, if patient delivered, he will definitely require NICU. Patient should be shifted to NICU and I will send culture first and then start empirical antibiotic as there is history of PROM, and depending on his chest retractions, X-ray, we will decide about surfactant.
Regarding in utero transfer, there are certain definite conditions where the baby needs an ICU care immediately after birth, mainly congenital diaphragmatic hernia or extreme low birth weight, or maybe twin-to-twin transfusion or RH isoimmunization, severe anemia. All these cases, it is better because the time lost while shifting the baby, not only time, the baby becomes more hypothermic and hypoglycemic, and there are so many metabolic changes happening during transfer, and transfer will not take less than 30 minutes. Wherever it is, even if it is in the building besides the NICU. So it is better to send the mother, shift the baby in utero and deliver there so that the care can be taken very fast.
Yeah, but what happens at a place like Pandharpur where I am practicing? There is not a single institute in Pandharpur where the gynec care and the NICU optimal NICU care which is required for these small babies is not available at a single place. So we have a middle path there that whenever there is such a preterm baby or baby who is likely to get admission, then we prefer to call a houseman or a pediatrician who has good NICU care with the ambulance. With the NICU care ambulance which has a ventilator, which has a which has everything inside with the ventilation facilities, the CPAP with it, and a person who knows how to operate it. I don't know how to operate CPAP. I need a person who knows how to operate a CPAP. मनुष्यबळ, infrastructure आणि वाहन आणि ड्रायव्हर वेळेवर असं ज्याच्याकडे उपलब्ध आहे अशा माणसाला बोलवून घेतो, and then we see to it that the baby gets transferred immediately in less than 15 minutes or maybe half an hour, something like that. So that is the middle way out because we don't have institute which has both the things together under one roof. So we have to find a middle way out. So in case of preterm, steroids, antibiotics, conserve, induce, LSS, as Dr. Monica has very rightly said, post-delivery surfactant, the pediatrician has told about retro-optic screening. ROP.
Sir, I would like to add the use of prebiotics also in case if you are trying to conserve the patients. Prebiotics definitely work rather than giving long-term antibiotics to the mother.
Thank you so much for adding that knowledge. I have never used prebiotic. Maybe people in audience are also using it. Anyone has any experience with prebiotics for PROM? How was the experience, ma'am?
It gives you more number of days, sir, at least.
Okay, thank you. About this ROP. See, ROP is something, no, I know. Once I got a call and that I had to talk in a conference and thing where I have to talk about ROP, and it was similar panel discussion. Sorry for my academic ignorance, but I never knew what this ROP was. मैं बोला right occipital posterior के बारे में मैं क्या बोलूँगा? And then I got this. And one more thing, when I was doing a post graduation, one day we were having ward rounds, and suddenly our boss asked, so what was the indication of your LSCS? Then the patient सरळ उठून म्हटला, मॅडम ते माझ्या बाळाला काहीतरी आरोपी म्हणत होते म्हणून माझ्या बाळाला सीझर केलं म्हणे. So it was the Marathi ROP, not the English ROP. Yes, something about ROP, sir.
It is retinopathy of prematurity. It is, as word suggests, it is affecting retina, and it is seen in premature babies. And as NICU care is increasing and more preterm babies are being surviving, this incidence is increasing. And it came to light after case on pediatrician whether they have not done ROP screening. It should be ideally done in every preterm baby, and it should be done by ophthalmologist, and we have to keep follow-up of the patient. That is very important. We have to inform him at the time of discharge that you required ROP on this date, you are supposed to come, and we have to do serial ROPs also if there is some problem in vascularization of retina.
Intact survival is very important nowadays, because we have many nuclear families. They have maybe one or maybe two children, and then they need to be perfectly normal. Every parent wants a normal child. So intact survival of every baby, we should make every chance that even if the baby is prematurely delivered, has some complications during neonatal period, but the baby's outcome should be definitely good. So that is what we are all doing now, these so many years.
And
Thank you.
Also bearer also for our deafness.
Right.
So thank you SOGS for giving us this opportunity to moderate this session. Thank you our panelists for the enthusiastic discussion at this fag end. So the take home message would be, उद्या हॉस्पिटलमध्ये गेल्यानंतर किंवा संध्याकाळी गेल्यानंतर आपला बेबी केअर कॉर्नर सगळा व्यवस्थित आहे का बघा. बराच वेळा आपलं तिथली धूळ झटकण्यापासून सुरुवात करावी लागते. दिस इज फॉर ऑल ऑब्स्टेटिशियन्स. आणि पिडियाट्रिशियनशी चांगलं वागा. तो आपल्या भावासारखा किंवा बहिणीसारखा असं वागा. जावेसारखा किंवा नंदेसारखा असं वागू नकात. गिव्ह हिम कॉल फ्रिक्वेंटली, इन्फॉर्म हिम प्रायर इन टाइम, and give him the incentive that the baby will definitely come to you, the immunization will be carried out, that pediatrician only, then he will be more willing to come at your hospital, and we are good mothers and good babies. Thank you so much.
Thank you very much. Thank you for giving the opportunity to come on this dais. Thank you very much.
We thank the moderators for giving us an opportunity to speak here, and thank you SOGS.
I request Kulkarni sir and Sudesh Doshi sir to felicitate our panelist, Dr. Amruta Kumthekar. Good. Dr. Vinayak Revankar, Dr. Kundan Chopdi, Dr. Monica, and Dr. Rachna Jaju. I request Dr. Anjali Jama ma'am to felicitate Dr. Sandeep Kulkarni sir and Dr. Sudesh Doshi sir. Thank you very much for such a wonderful panel. I request everyone to please attend the valedictory function. Please do not leave the hall.
सांगतो एक मिनिट फोटोला जाऊन येतो. Friends, there is one more request. Are actually the friend and the alumni of our Vaishnampayar Medical College. Connect karna. Dr. Sunita Tanduradkar has sent a message. She could not attend this particular conference, but she has extended her request to support for her presidential candidature. So please support for her presidential election. Thank you very much.
Today we are here for the valedictory function, the most important part of the conference, as we need to felicitate all those who have contributed immensely for the success of this conference. I request Dr. Anjali Jamma ma'am to say few words.
Good evening all. You must be tired, I know. But still I will take some 2-3 minutes, not more than that. Distinguished guests, respected seniors, teachers and my dear friends. Over the last couple of days, we have developed a deep insight into the basics and nuances of labor. We have witnessed 2 wonderful academic feasts in the form of didactic lectures, Fernandes workshop, debates, panels, the keynote addresses by Dr. Neeraj Nagpal, Dr. Prakash Mehta and Dr. Milind Shah. Organizing conference successfully is always a teamwork. My team has been working tirelessly for the last few weeks to make this a smooth and flawless weekend. Dr. Sadesai Madam, Rohini Deshpande Madam, Dr. Milind Shah, Dr. Guram Sir, Dr. Jhamre Madam, Dr. Chitnis Madam, Dr. Kumtekar, Dr. Dabde Sir, Bhahubali Doshi Sir, under all these pillars of SOGS, under able guidance of these peoples, we could work and do this conference. For scientific sessions, Dr. Monica and Dr. Pratibha had really worked hard. For pre-papers and posters, Dr. Tirankar Madam and Dr. Vrinda Chaudhary Madam has given their precious time. And Supriya has worked hard for that. Because of Nanda, we have enjoyed ever memorable cultural program. And our enthusiastic participants had performed excellently. Our esteemed faculties could enjoy our hospitality because of hard work of Meena Gunjotikar, Praveen Khare, Karamjit Dongre and Supriya. We could manage all decorum of conference with our beautiful, enthusiastic MOCs. And Dr. Sujata Kulkarni and Dr. Ketki took a lot of efforts for beautiful inauguration. We enjoyed mouth-watering delicacies because of Nisha's hard work. In all these days, Dr. Monica had worked very hard. She is a backbone, pillar and whatnot. Words fall short for her. Dr. Archana Khare and Dr. Supriya Jadhav had given their 100%. They were my right hands in these days. Last but not the least, our pharma partners, Balaji Sarovar, Shailendra, Shejal, Mohan, Aivale, and everyone has contributed their share. If by mistake I have forgotten any one of you, please forgive me. Thank you all the delegates. Because of you all, this could be possible. This is SOGS spirit. So thank you, and thank you. Thank you very much.
Thank you, Jama ma'am. Now I call upon stage Dr. Milind Shah sir for further proceedings.
हो चालेल हँड माईक द्या मला well friends, we had a very good response to the paper and presentation, poster presentation, and we are happy to announce the results. All those papers were really praiseworthy, and they had put in a lot of efforts by all our young doctors. Yeah. So we are declaring the result now. Yes.
I request Dr. Manik Guram and Dr. Anjali Jama ma'am to join on a stage.
Yeah. The first prize in the junior category goes to Dr. Kiran Thombre. She has presented on maternal outcome in referred PPH patients to tertiary healthcare center. Dr. Kiran Thombre is there? नहीं है. VMMC.
Anybody from EMMC student?
The second prize goes to Dr. Sushmita Y, who presented on the effect of maternal birthing positions on maternal and fetal outcome. I think she's from BLDA. Anyone is there? She's not there. Yeah, sure. हाँ. The first prize in the senior category goes to, yes, Dr. Sampath Baldava. Rare case of uterine gas gangrene. So, Pratibha, now you can do the honors and please come here to accept this prize. Baldava family has, decided to have all prizes among this. And the appreciation prize for the poster goes to Dr. Apurva Khatokar on challenging cesarean section in BMI 66 kg, first case report in India. Yeah, please come. Dr. Apurva. Come. Good. Congratulations. Come. Oh, this. Thank you very much. Friends, in fact, we wanted to felicitate all our committee members who were working very hard in last 2 months for this labor conference. Unfortunately, many of them, they have left actually because it's little late today to finish our academic events. But still, we want to felicitate all of them who are present in the hall. So let us start with, yes, Dr. Supriya, please come forward. Dr. Pratibha Baldava. I think the second sweetest sound after Lata Mangeshkar was Pratibha's voice yesterday. Good it was, yeah. Good. Absolutely, it was good, yeah. Yes. Yes. Dr. Madhura Virkar and Dr. Vivek Virkar, please come. दोघे या एकाच वेळेस. तुम्ही आहे ना असं कसं डॉक्टर प्राजक्ता प्राजक्त कोणी नाही तर मी आठवण नेहमी करतो तुझी. तुला ॲक्सेप्ट करावं लागेल ते. कम 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 या. येस या पुढे या पुढं. येस घे घे.
हॅलो.
थँक्यू. देन या डॉक्टर विरकर कपल प्लीज कम.
चालू.
एकमेकाला.
हॅलो हॅलो.
येस या डॉक्टर निशा कोतवाल. येस. डॉक्टर अमृता कुमठेकर प्लीज कम फॉरवर्ड.
डॉक्टर मी बोलते.
हो घेतो सगळ्यांना.
डॉक्टर सुप्रिया जाधव प्लीज कम फॉरवर्ड, कम सून. डॉक्टर समन तांबोळी. येस. डॉक्टर हिलालपुरे. डॉक्टर शिल्पा हिलालपुरे.
डॉक्टर स्नेहल.
and Dr. Swapnali, please.
Yes, Dr. Swapnali. Yes. Yes. Come. Yes. Good. Very well done. नाही आपण सगळे घरचेच होत आता. आणि घरचेच आहात म्हणजे आता हे सगळे ऑर्गनाइज. हो करमजीत कम. गुंजोटीकर कुठे आहे?
Karamjit has worked for travel. Dr. Supriya and Khare sir, all four of them, even after finishing this conference, they will be still working to draw the remaining faculty. So the conference is over for us.
आणि काही जण उद्या सकाळी चाललेत बरं का. कोण राहिलं अजून? हां या ॲक्शिस देअर या. स्वप्नाली या. गुड प्लीज. येस ये इकडं.
आणि मोनिका राहील.
मोनिका. येस. मोनिका, सुप्रिया, अर्चना. आपण काय म्हणतो आम्ही पण घरचे आहोत. ओके. हो फार्माचे आहेत ना. दूर
तुमच्याशिवाय होणारच नाही.
काय संदीप आयवळे.
इकडे.
फार्माच्या सगळ्यांना बोलो.
समींद्र.
नाव लिहिली ना सगळ्या फार्मा.
आमच्या सगळ्या चित्रफिती चांगल्या पद्धतीने दाखवल्याबद्दल या 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 या.
मोनिका ये.
ये समींद्र बोल.
Archana, I would request Samindra also to come and Mohan also to join us for the felicitation. मोहन आम्ही तुमचा फोटो काढू या.
अरे तिनं आणली तिलाच देण्यासाठी. चला.
जेवढे सगळ्यांना बोलवा तुमचे. ये संदीप ये.
कमी घेते सर. The scientific program, even if it is very great, it cannot work without the efforts from the pharmaceutical company we have. We have Eris Montana and Eris Venus who have supported us for this venture. Tivos Pharma Limited, Pharmed Limited, MCure Pharma, Sun Pharma, all the divisions, Corona Remedies, Bharat Serum and MCure Inventia. We request each one of you to please come one by one for the felicitation. We also would like to mention Gangji Saris, Kanu Collections, Chinchorkar for the jewelry and linen care.
अंबुज को मोहितोष आ जाइए आप भी.
We would also like to thank Santosh, please collect appreciation from us. आप थोड़ा बिल भी कम कर देना प्लीज. इसीलिए माइक पे नहीं बोला. And we would also like to thank conference for hosting the conference online.
अरे ये लोग रह गए ना. Your division is remaining.
Yes, sir. नहीं सगळ्यांचं झालं सर.
Thank you everyone. I declare the valedictory function is over.
विनायक राजपंत त्यांच्यावर ये नाही आहे. You come again.
Hip hip hooray!